For this session are Dr. R.K. Dalai and Dr. Devidatta Pradhan. So I would request the esteemed chairpersons to kindly come on the stage and start the proceedings.
Welcome all to this session of recent updates in medicine. I think a qualitative audience is better than a quantitative one. And let us discuss about the recent updates. And I request Dr. Lolatendu Mahanti to come to the dash and speak about updates in the management of sickle cell disease. Dr. Mahanti needs no introduction. He is now professor and HOD of TIMS. He is my student. And, he has got a lot of research publications. And he takes a keen interest in teaching and one of the best teachers in medical college. So I request Lolatendu to speak about sickle cell disease. Introducing the subject, I probably need not tell anything because sickle cell disease is all known to you. But the only thing is that the management is really difficult. And we have got very less drugs with us. Only one drug with us, that is the hydroxyurea. And probably I think it is one of the best drugs to be started from the very first year of life. And it prevents the complications and increase the hemoglobin F. Except this hydroxyurea, probably we have got no other drugs. And the recently introduced drug like levetiracetam or D-glutamine and its cadonlimab, they have got some place what is an add-on therapy for the sickle cell disease. And the recent advances about gene therapy and other things are coming out, and that will be probably told about, will be told by Dr. Lolatendu. So I speak, tell Lolatendu to go on.
Thank you, sir, for
at
your
least
time.
seven people are there to say chairpersons. So that's okay. That's really suffices nowadays. But I personally feel that we are not able to attract the young persons, the postgraduates and the students to the. So what the really cause, I do not know. Probably we have already left, and the Lolatendu have to think a bit. So how we can attract the students to come over and hear at least what the things are, proceedings are going on. Otherwise, all our labors are fruitless. If there will be no speakers and all that, there will be 3 chairpersons and all that, and there will be 3. So I don't think that Lolatendu will be very encouraged to speak about the recent advances and recent updates. So probably we are all going back to the old ones. The students are not interested, the speakers are not interested, the competition is not. So let us have, don't talk about this. So I request straight away to Lolatendu to speak about the sickle cell disease and recent updates.
Thank you, sir, for your kind words. I welcome you all to the last day of 8th ACP meet, and which has been very encouraging. In the last 2 days, we have had very great scientific sessions with great personalities discussing. And initially, I must thank the organizing team and especially Professor Jayant Panda and Professor Anil Birmani and Professor Anul Maheshwari, who has done great work and given me this opportunity. I'll be discussing today one of the important topics of internal medicine. Slides are not coming? Okay. It will be updates in management of sickle cell disease. As Sir was pointing out, there are very few drugs to only hydroxyurea is the established drug in management of sickle cell disease. But I will be discussing few things about what new is there in the horizon, or whether we can take up some other drugs which are possibly helpful in management of sickle cell disease. So giving some introduction about the disease, which all are aware, sickle cell syndromes are examples of the structural hemoglobinopathies caused by mutation in beta globin gene of hemoglobin that changes the 7th. Please mark my word. We historically knew it is the 6th position, but now it is counted as 7th position amino acid, which changes from glutamic acid to valine. Because there have been some changes in the nomenclature, so now it is the 7th amino acid which is changing. And sickle cell disease occurs when HbS is present in homozygous trait, or it can be compound heterozygosity with certain other hemoglobin variants like HbC, D, or E sometimes. It has originated long back, around 7,000 to 22,000 years ago in Africa initially, but it's reached very high frequencies because of increased genetic fitness of heterozygotes under selective pressure from Plasmodium falciparum. We are all aware of that, how the interaction between Plasmodium falciparum and sickle cell trait. In some regions of Africa, India, and even Middle East, nearly 50% of the population have sickle cell trait. And population movement have spread the HbS gene throughout the world. And prevalence of HbS carrier or sickle cell trait is 2 to 15% in immigrant population. A few lines about pathophysiology, what happens when in a sickle cell disease. HbS, the fundamental hemoglobin in sickle cell disease, is physiologically similar to HbA, except it polymerizes when deoxygenated. So whenever there is deoxygenation, there is polymerization. And this precipitates inside the RBCs, causing the morphological change to a crescent shape. These HbS polymers lead directly or indirectly to multiple abnormalities, including membrane vasculation, dehydration of the RBCs, increased mean sickle hemoglobin concentration, decreased cell deformability, and increased polymerization, along with translocation of aminophospholipid to the outer membrane. And all these leads to irreversibly sickled erythrocytes. And these sickled erythrocytes that are forever deformed because of permanent membrane damage, regardless of whether HbS remains polymerized or not. So after a few episodes of reversibility, there occurs permanent damage leading to permanent change in the RBC shape, leading to irreversibly sickled cells. And damaged sickled erythrocytes are responsible for initiating the vaso-occlusive, hemolytic, and inflammatory features of sickle cell disease. This is a diagrammatic explanation of the pathophysiology, what happens. And when the HbS remains in solution in the red picture, when they are oxygenated, once deoxygenation occurs, they polymerize and sickling occurs. And initially, this is a reversible process. But after few episodes of sickling, there occurs irreversible sickling of the RBCs. And these irreversible sickled RBCs has interact with endothelium and other blood cells, leading to vaso-occlusion. Initially, the smaller arteries, then the larger arteries. And these sickled cells have also a less lifespan as compared to normal RBCs, almost 20 days less. So they get initially hemolyzed by either extravascular or intravascular hemolysis. Intravascular hemolysis leads to release of free hemoglobin, heme, and also arginase, which consume the nitric oxide available in the blood and leading to vaso-occlusion initially, or when vaso-occlusion inside the cells. So these two are the fundamental pathologic processes by which hemoglobin or sickled hemoglobin cells, RBCs, cause damage to the body. This is again another representation of sickling, vaso-occlusion, polymerization, and the interaction with sterile inflammation initially. The diagnosis is pretty easy in these cases. With sickle cell trait and disease can be diagnosed by combination of CBC, HPLC, and sickle solubility test. Sickle cell trait has near normal CBC indices with slightly or almost normal hemoglobin concentration. MCH or RDW are slightly increased, and HbS is almost 35 to 40% on HPLC. Whereas sickle cell disease, hemoglobin remains in the range of 6 to 8 gram per deciliter. Sickled RBCs are seen on peripheral blood smear, and HbS is 80 to 90% on HPLC, with a slightly increased HbA2 similarity. But genotyping of family members and potential parental patterns is critical for genetic counseling. So this is a picture showing HPLC picture in hemoglobin trait, sickle cell trait, disease, and HbS disease. Management. Now the fundamental, the basic concept of our talk today is management, how it has changed, whether anything new is there in the field. Sickle cell disease is characterized by multi-system acute and chronic complications. Advances in early diagnosis, medical care, and comprehensive treatment have led to substantial improvement in life expectancy. Remarkable changes in treatment have occurred with promise of even greater benefits from newer agents and new curative approaches based on gene therapy. These therapies modify disease course, namely hydroxyurea, as Sir has pointed out, erythrocyte transfusion, and hematopoietic stem cell transplant. Blood transfusion in sickle cell disease is an important parameter or important management tool in managing patients of sickle cell disease. So transfusions can be categorized into simple episodic, simple chronic, or even excess transfusion. Major indications being severe symptomatic anemia, treatment and prevention of stroke, increase the hemoglobin level to almost 10 gram per deciliter before a surgery requiring general anesthesia, and acute chest syndrome with hypoxia and multiple lobe involvement. Sometimes during pregnancy in case of history of complications of fetal loss. Simple episodic transfusion indications are shown in the left side: acute coronary syndrome, severe anemia, pre-operative to make the patient fit for surgery, symptomatic patients with heart failure, dyspnea, hypotension, and other organ failures, infection-related anemia like parvovirus B19, or hemolysis-related anemia with concomitant G6PD deficiency, hepatic sequestration, and splenic sequestration in children also. So these are the major indications where we give simple episodic transfusion. Sometimes when we consider in prolonged priapism and non-healing leg ulcers. Simple chronic transfusion can be indicated in primary or secondary stroke prevention, complicated pregnancy because of progressive anemia, preeclampsia, increased pain episodes, and other things. It also can be considered in children following acute chest syndrome, pulmonary hypertension, moderate or severe, silent, hemorrhagic, and vasculopathic stroke, chronic heart failure, and other list where you can think of simple chronic. And excess transfusion is indicated in acute chest syndrome, which is moderate to severe seriousity, and stroke, or one or multiple organ failure, and HbSC patient with any of the following like pre-operative preparation and general anesthesia and other conditions. Stem cell transplant, the new thing in the horizon. It is the only curative therapy available as of now. These results of HLA identical related donor transplants are excellent, having an event-free survival of more than 95%. It might be extended to all patients with a suitable donor. Unfortunately, only 15% patients have a fully matched donor. New approaches to like haplo-identical transplants are improving the event-free survival in these patients. Hydroxyurea, the main treatment modalities available for sickle cell patients, is currently the only FDA-approved drug for hemoglobin F induction. So hydroxyurea is a cell cycle S-specific agent that blocks conversion of RNA to DNA, inhibits a ribonucleotide reductase enzyme. It primarily causes hemoglobin F induction, which inhibits HbS polymerization, but other benefits may include decreased leukocyte and platelet count, decreased hemolysis, decreased bone marrow cellularity, and nitric oxide generation. These are the effects of hydroxyurea in a diagrammatic representation. It has increased hemoglobin F synthesis and also has cellular effects like decreased HbS polymerization, decreased RBC polymerization damage, decreased hemolysis, and decreased neutrophil count, increased hemoglobin synthesis also, and decreased vasoconstriction. So it affects all areas of the pathophysiology of sickle cell disease, especially increasing the HbF induction. Clinical use and monitoring of hydroxyurea In adults and adolescent with HBSS or HBS beta thalassemia trait, is the indication. Dosing starts with 10 to 15 milligram per kg to titrate of aquarid. Monitoring initially with CBC every 2 weeks and biochemistry every 2 to 4 weeks. Treatment endpoint, look for less severe or frequent pain and increase HbF to 10 to 20%. Cautions, dose reduction in hepatic renal insufficiency and contraception for men and women. Okay. And there are certain new drugs who have come into the field, basing on the pathophysiological mechanisms like the change the genotype with allogenic bone marrow transplantation or autologous hematopoietic stem cell transplantation modification, targeting HbS polymerization, which is another pathophysiological process, increased by increasing fetal hemoglobin, or with genetic and genomic approaches, suppressing BCL11A, simulate hereditary persistent of fetal hemoglobin variants, pharmacology with hydroxyurea and HbO2 affinity. And also targeting vaso-occlusion are like inhibiting adhesive interaction between cells and endothelium, targeting inflammation like feedback loop of sterile inflammation, L-glutamine, inflammasome inhibition. The evolution of drugs over a period of since 1910 we started, it has now landed up with, in 2017, the L-glutamine with FDA approved. In 2019, other drugs got approved like crizanlizumab and voxelotor in 2009. These two are the new drugs. HbF induction beyond hydroxyurea. There are other drugs in the pipeline which the trials are going on like histone, diacetyl, IMR6H and other drugs. Still the trials are going on. The voxelotor, the new drug which are being used, and it targets HbS polymerization. It's a US approved agent for sickle cell disease in adults and pediatric groups over more than 12 years. It binds specifically to N-terminus alpha subunit of HbS, and it directly inhibits HbS polymerization, which is the fundamental pathological process in sickle cell disease. Dose is around 1500 milligram per day, associated with 1 to 2 gram rise in hemoglobin. It studies and decreases hemolysis, decreases propensity of stroke, nephropathy, pulmonary hypertension, leg ulcer, and priapism. This is a mechanism of action of voxelotor, reducing HbS polymerization. And other drugs in that category are like Cenicapoc, Memantine, and Sanguinate. All these are in the pipeline ongoing research trials. Targeting vaso-occlusion, another mechanism is L-glutamine. It appears to decrease the oxidative stress significantly by increasing NADH and NAD redox potential and decreases endothelial adhesion. It was approved by FDA to be used in sickle cell disease patients more than 5 years of age, but has not been approved by European Medicine Agency. But in a phase 3 clinical trial, it is associated with 25% decrease in painful episodes and 33% decrease in hospitalization. Another important drug is crizanlizumab. It's a monoclonal antibody to P-selectin, and it blocks the adhesion of activated RBCs, neutrophils, and platelets to the endothelium. It has been approved by US FDA to decrease frequency of vaso-occlusive crisis in adults and pediatric SCD patients. And given intravenously every month, it was shown to decrease acute painful episodes by almost 45%, and is an option for those who cannot tolerate hydroxyurea or who have continued pain despite hydroxyurea. Recommended dose is 5 milligram per kg per dose IV on weeks 0 to then every 4 weekly. This is the mechanism of action. Other drugs in that group is rivipancel, sebuparin, unfractionated heparin, vapoloxamar. These are ongoing trials going on. And these are the 4 important FDA-approved drugs which is FDA-approved for use in sickle cell disease. As we have discussed, hydroxyurea, L-glutamine, crizanlizumab, and voxelotor. The year of approval, mechanism of action, dosing schedule, and common adverse effects is shown. We don't go to details. And targeting inflammation, another pathway is simvastatin, N-acetylcysteine, and canakinumab, a humanized monoclonal antibody targeting IL-1 beta. These are also undergoing trials. Gene therapy. Another important aspect is allogenic hematopoietic stem cell transplant is the only available curative therapy. But gene therapy, by introducing a new gene or editing an existing gene, can have potential to cure the sickle cell disease. Unlike allogenic hematopoietic stem cell transplant, these approaches modify patients' own HSCs, and concern about graft versus host disease is not there. So we don't transplant other diseases or other bone marrow from outside. We change the gene by gene editing or even concentrating the new genes. Typically, endogenous HSCs are harvested, manipulations are done in the laboratory, and same cells are again reinfused to the patient as autologous HSCT. So the graft versus host disease is not there, and a number of approaches are under investigation, including providing a corrected beta globin gene, providing a modified beta globin gene, and altering normal hemoglobin switching program to revert to a fetal program, which no HbF is curative protective, and gene correction and gene editing are processes by which a wild type beta globin gene is used as a template. So these are diagrams showing how gene addition works, lentiviral based gene therapies, and RNA inhibitor gene editing. These are the, because of paucity of time, I have to rush through these slides. And the most important slide is this. We need to know what are the current and ongoing treatment available for sickle cell disease. We can see the standard of care has reached hydroxyurea, L-glutamic, crizanlizumab, and voxylator, and also HLA match transplant. All these initial five drugs are reached the standard of care level. Other drugs in the phase 3 trial are haploidentical transplant and ribipancel. And other drugs like servaparin, N-acetylcysteine are still going trials. So we have got 5 drugs which are reached the level of standard of care approval. So we don't have, sir, with only hydroxyurea, we have so many drugs now in the armamentarium in managing a patient of sickle cell disease. And once HLA mass transplant is easily available, that is almost curative in patients of sickle cell disease. And there are what related complications, what's new in the diagnosis and management of complications. We know it is very, 1 minute, sir. Yes, sir. We'll see, we'll finish this. Chronic SCD pain management, there are conditional recommendations are occurred in current practice guidelines to consider drugs like trifluperagine, which is antipsychotic, milnacipran, duloxetine or SNRIs, amitriptyline or TCA, and pregabalin, a gabapentinoid. These can be used in chronic SCD pain treatment. Non-pharmacologic therapy like integrative, psychological-based therapy, acupuncture, these can also be considered. Emerging modalities for diagnosis of obstructive and restrictive lung disease in SCD include impulse oscillometry, this is the diagnostic new thing, and airway provocation studies for diagnosis. Screening brain MRI in children and adults with SCD to facilitate detection of silent cerebral infarction should be done. And MRI can be added to look for cerebral vasculopathy. And annual screening for increased stroke risk should be done with transcranial Doppler ultrasound. So these are diagnostic modalities for earlier detection of complications of sickle cell disease. And equations that incorporate serum cystatin C for detecting sickle cell nephropathy, urine microalbumin, and various novel predictors of AKI like biomarkers like kidney injury molecule 1, monocyte chemotaxic protein 1. 1 minute, sir. ACE inhibitors, ARBs, we're almost finishing. And renal transplant can also be considered for sickle cell nephropathy. Concluding, in last many years I have witnessed revolutions in medical sciences and sickle cell disease because of its genetic simplicity and has been among the front runners in numerous scientific discoveries. It is associated with complications and end organ damage, including cardiopulmonary, cerebrovascular, and renal disease that results in increased morbidity and mortality. And progress has been made in understanding its pathology and treatment options, including pharmacologic and genetic. And well-designed clinical trials have resulted in advances in its management and past decade. These trials have led to FDA approval 3 new drugs, L-glutamine, crizanlizumab, and voxylator, which prevent acute pain and improve chronic anemia. Moderate to high quality data support recommendation for managing SCD in cerebrovascular disease. However, further research is needed to explore and determine treatment strategies for other SCD related. And SCD is far more prevalent in regions like Africa and Asia where healthcare is not available. And in background of existing or upcoming newer therapeutic approaches, attempts should be made to make them accessible to those who suffer the most. These are my references. Thank you. Sir. I'm open to questions.
Thank you. Any question? We'll take. Any question? Okay.
Sir.
Good morning. I'm Dr. Panda from Tata Main Hospital, Jamshedpur. Excellent deliberation, Dr. Mahanti. I have two specific questions. In your experience, have you used L-glutamine? There's a lot of literature about the L-glutamine being used to reduce the complication. I think it's available also commercially, and some companies make it. Second question is we have diagnosed the case of rheumatoid arthritis in a patient of sickle cell disease. And what drugs, and we have also published that paper also. Now, what drugs would you think is quite safe to be given? Because this patient comes again and again with repeated bouts of pain in the joints and also had developed deformity like typical of RA. So, what drug would be safe in regarding both the conditions?
Sir, thank you, sir, for your questions. Initially, the first question, L-glutamine, I don't have much experience. Sir might have some experience. I don't have personal experience in using L-glutamine in sickle cell disease. So the second question, rheumatoid arthritis, treatment of rheumatoid arthritis as is separate in, so there is no contraindication of using drugs for rheumatoid arthritis in a patient of sickle cell disease. But we have to be clinically careful whether the pain is because of sickle cell crisis or because of rheumatoid arthritis. So, and in patients of sickle cell disease, we go on giving long-term treatment. We have got only hydroxyurea at present, but other drugs are coming up, and how relevant they are, the time and experience will tell us. But theoretically, they are helping, and it reduces polymerization like risankizumab. So we can use those drugs. In addition to hydroxyurea, even the recommendations are also there. So it is two separate diseases not to be treated at its own. Sir.
Real difficult in case of this. There are a lot of about this infarction and all that. About leg ulcer, there are so many things. So we still say that the morphine is the drug of choice. Sometimes the morphine, even oral morphine, you can start with, there are very clearly or very anywhere, PSC also it is available, that oral morphine can be given to the drugs. But this non-steroidal anti-inflammatory drug still remains with the same diclofenac. But the ketorolac should not be given.
Ketorolac should not be used.
One question that ketorolac should not be given, that very specific.
Sir, thank you, sir. Thank you.
Now I request Dr. Monica Gupta to speak her topic on women's health in 50s, the consequences of life choice. Actually, after 50s, there are many hormonal imbalances in women's health. So the disease conditions and the physiological processes, they are different from the elderly males. So the ladies above 50, there are many specific diseases and how to manage. I request Dr. Monica Gupta, she is MD in medicine and done her MRPPS from Glasgow. I request now her to start her talk.
A very good morning, dear chairpersons, and to all of you. At the very outset, I'd like to thank the ACP organizers for giving me this opportunity to deliver my story. I'm a 50-year-old woman. It's a little unusual for a physician to talk on this topic, but I think I'll do some justice to this topic. So, women's health in their 50s, consequences of the life choices. Ladies and gentlemen, these are your heartthrobs in their heydays and today. You can see their pictures, a life well lived. You can see the fine creases, you can see the thinning hairline, you can see how they have matured over the period of time. But their smile remained intact. Topics which I'm going to cover are these. Now, there are two things, health and menopause. So what is health? Health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. Women's health involves their emotional, social, and physical well-being and is determined by the social, political, and economic context of their lives as well as by biology. Why focus on women's health beyond 50s? Well, in today's time of Beti Bachao, Beti Padhao, why are we talking about this? Well, there is a plethora of lifetime health problems. You can see the lifetime health problems of gender violence, which is prevalent all over the world, be it a developed country or a non-developed country, certain occupational and environmental health hazards, depression. But when you restrict yourself to 45 years above, you talk of these diseases which are prevalent amongst all of us. These are the gynecological cancers, cardiovascular disease, osteoporosis, osteoarthritis, diabetes, and depression. Now let me tell you, the global population at the age of 60, in worldwide it's 580 millions. Amongst them, 48.2% females in India, 55% are widows, 70% dependent on others, and 50% are postmenopausal. The life expectancy of our women is 67.57 years as against 65 years for men. The proportion of elderly women is 71 in 1,000 in rural areas, and in urban areas it is 71 in 1,000 compared to men, which is 62 in 1,000. The sex ratio is favorable to women only in the age group of 65 years and above, because women have a longer lease of life. This is a slide of overall life expectancy and a healthy life expectancy. Not much of a age difference. So why do you have this increasing aging population of women? Because of decreased fertility rates and also because of increased life expectancy. We as women, what are the health mistakes we make in our 50s? We ignore ourselves. We ignore our heart. We talk about ourselves as the last person to go to a doctor. You put up with menopause miseries, you have hot flashes, you have memory issues, you forget names, you have sleeping issues, you have bad hair days, your skin starts sagging, you have extreme skin dryness, there is weight gain, tiredness, bone loss, and then you skip screening. I said, you are the last person to go to the doctor. You don't believe in going for screenings. You always think that weight gain is inevitable. Once you reach your 50s, your body changes and weight gain is inevitable. Finally, you lose your sense of purpose. You are a nut. You are lost, you are confused, you are unsure, you are unclear, you are always disoriented, bewildered. That's what you are. That is what 50s makes you behave like. Well, it is commonly believed that Asian have a lower prevalence of menopausal symptoms than the Western women. Asian women, they ignore their menopausal symptoms. 90% of Asian women accepted it as a natural consequence of aging. There was a population-based study in Singapore, and on 1,000 women between the age of 45 to 60, and 7% women were significantly bothered by any of the symptoms of menopause. Asian women demonstrate a prevalence of significant hot flushes from 10 to 30%. 64% of Asian women did not feel that their reduced sexual desire lowered their self-confidence. So, this transition can be a very, some people might always complain and some people take it as it comes and some people are not bothered about menopause. These are the few things nobody told you about menopause. I repeat, I'm talking about myself at this age of 50. Your workouts change, your sex drive won't necessarily suck, you can still get pregnant, you may be more susceptible to STDs, your hair is thin, your sleep might suffer, you could be achy, or you might not experience any side effects. These are the 10 leading causes of death. So, I don't want to delve much on this slide. Now coming to the health event in 50s. Menopause is 12 months period of no menses. Aging slows down, it doesn't stop. Your life cycle doesn't stop. So, it marks the end of your reproductive life. This is between the age of 45 to 55 world over, and nearly 1/3 of women's life is spent after menopause. The short-term problems, menstrual irregularities, hot flashes, palpitation, muscle and joint pain, low backache, vaginal dryness, urinary incontinence, urinary frequency, fatigability, mood swings, depression, sleeping problems, memory lapse, decreased libido, weight gain, dryness of skin, hair loss. Mind you, they might seem very trivial, but they are also capable of creating a havoc. Long-term problems, osteoporosis, heart disease, depression of menopause and of aging, arthritis, cancers, diabetes, hypertension, problems of hearing, problems of seeing. Osteoporosis is a common problem. It is prevalent in 52% in urban areas and 76% in rural areas. Falls account for 87% of all fractures for elderly women. About 1/5 of hip fractures patients require long-term nursing home care, and 10% remain functionally dependent for daily living care. So, osteoporosis is a very silent change you see in the body. Meanwhile, osteoarthritis is a painful situation for which you have to actually get to the doctor. Cardiovascular diseases, stroke is the most common cause of death, leading to 21.7% deaths. Ischemic heart disease leads to 19.8%. Well, despite all trials about the hormone replaced therapy, it has been noticed that there is no protective action of estrogen. The chance of having a stroke more than doubles for each decade of women's life after the age of 55. There is decreased heart capacity, decreased pumping capacity. The risk factors being age, gender, hypertension, high cholesterol, family history, even stress, obesity. Coming to mental health. We as women, after the age of 50, we have a very unstable or poor orientation of our mental well-being. I wouldn't say that in a very large extent, but yes, 20% women suffer from depression at some point during menopause. Mood swings, irritability, tearfulness, anxiety, and feelings of despair in the years leading to menopause. You realize that 2/3 of your life has been spent and there is only 1/3 of your life which is there ahead of you. And you want to make the most use of it. The symptoms occur in conjunction with vasomotor instability as a result of declining ovarian function. Well, one major eventful disease in the age of 50s is the cancer. Breast cancer, colon cancer, and the cervical cancer. World over, the highest incidence is that of the breast cancer. We know it is it can be hormone triggered as well. Then the second is your colon cancer. But in less developed countries, the most common prevalence is that of the cervical cancer. Cancer occurs before the age of 60s, but most of the deaths occur at old ages. Breast cancer is hormonally influenced. It all depends on age at menarche, age at first and last pregnancy, and age at menopause. Family history of breast cancer, these are associated with an increased risk. Breast cancer accounts for almost more than 5 lakh cases each year in the world, of which 40% occur in developing countries. And out of this more than 5 lakh cases each year worldwide, it accounts for between 1 and 3% of all deaths in developing countries and 3 to 5% in developed countries. The cancer of the cervix is more than 5 lakh new cancer cases each year worldwide. About 80% of these occur in developing countries, accounting for 2 lakh deaths annually. Well, these cancers, they develop slowly, but if you go to the doctor, they are readily detectable. The other health problems are diabetes, 3.8% in rural areas, 11.8% in urban areas, urinary incontinence because your pelvic floor muscles are loose. It affects to 31.5% of women. There is poor vision, even hearing difficulties. So, to establish epidemiological data on health problems in elderly, men and women, they go hand in hand. You can see the graph which shows that how the epidemiological stratification of men and women are, if not same, but very similar. Health promotion. It is very important that we as women physicians should talk about awareness of even the minutest of your health issues. We have to talk about exercise, we have to talk about healthy diet, cessation of smoking and alcohol, encourage physical activities, stress management, and screening. In today's times, this remains to be the most controversial therapy, the hormone replacement therapy. While I was going through the literatures for this, so I came that there has been 2 major trials, the WIT trial, Women Hormone Intervention Therapy, and the HERS trial. These are the 2 trials, major trials, which have talked about the pros and the cons of hormone therapy in postmenopausal women. But we still remain unclear about the results. The results have really not been very, very great. So there is one trial which is ongoing, which talks about that there is the new hypothesis, which is called critical window of hormone therapy. And it says that if you give HRT at the right time or at the early onset of the menopause, there can be some good results about it. Currently, there is KEEPS trial, which actually is trying to cover up all the aspects of aging in women. So hot flashes, sweats, and other complaints disappear once you start with estrogen. The Administration of estrogen without progesterone increases the risk of endometrial cancer and breast cancer. In women with intact ovaries, cyclical therapy with 10 days progesterone per month can reduce the incidence of cancer. Mind you, all this is still very inconclusive. It is important to talk about immunization in today's era. Vaccination for cervical cancer, 3 schedules. It should be given to women between the age of 11 and 26. Influenza, pneumonia, tetanus, and zoster. So, what is most important to have an early diagnosis and treatment? It is important for us to encourage women, whether living in rural or urban area, to go to a doctor for treatment and get yourself tested properly. Regular checkups of your dental, vision, and hearing. Screening tests. You can do your own screening tests, self-breast examination, mammography, your regular blood tests as advised by the physician, pap smear, DEXA scan, bone mineral density, lipid scaring, everything. Everything is important for a woman as it is for a man. You must have noticed that in your own home, your mother, she would not accept a walking stick or a hand. Well, you have to help her realize that she is aging, and or even for myself, if I need a walking stick, I should be able to accept it. Most common disabilities are usually locomotor and vision. 46.8% suffer from poor vision. Nearly 19% women have difficulty in hearing, but only 3.6% of women use hearing aid. And proper dentures are also very important. What are the lifestyle approaches? Yes, I'll be quick. So, apart from medication, eat healthy, talk about the mind diet, combination of Mediterranean and the DASH diet. It talks about healthy eating, maintain your weight, maintain your right BMI, daily physical activity, exercise of 150 hours in a week, sleep well, avoid smoking, hold on to alcohol, mental well-being, do pranayam, do yoga, go for affirmation prayers, accept and adapt the transition or change which you are heading for. Summarizing, health and social status of women beyond reproductive years, highlight greater emphasis on involvement of health care activities, awareness generation regarding healthy lifestyle should be done, information on common health problems and facilities available should be provided, policies need to be more gender sensitive and should focus on women's needs, encourage more research regarding health and social issues in relation to women beyond 50 years age. Health strategies has to be country specific as there are variation in diseases, lifestyles, and standard of living. Nasti matra sama chhaya, nasti matra sama gati, nasti matra samang tranam, nasti matra sama prabha. There is no shade like mother, no resort like mother, no security like mother, no other ever-giving fountain of life. Thank you so much.
Thank you, madam, for completing subject in a real good time. And I think this is most important topic for the ladies after 50s. If we can really take the proper measures and health style and lifestyle modification, I think the women after 50s can we remain of 70 to 80s like Madhuri Dixit or like others. So it's a message to all the young ladies that they should take care of health as others and very screening procedures, the management, exercise, good health. Even if stress is there, don't forget. So a stressless life will give you good health to the young and ladies after 50. Thank you very much. Any question? Yes.
Good morning, ma'am. I'm a postgraduate from KIMS. Since we see a lot of young, like postmenopausal women at 50 years in our OPDs and admissions with all non-specific symptoms, and since you have already discussed about hormonal replacement therapy, is there any fixed guidelines, like how many months should we treat, or is it continuous? Like when should we stop hormone replacement therapies, or what is an endpoint for it?
Okay, so like I said, this still remains to be a, a point of debate. So grossly, what it mentions that it is important to, when to start the therapy. If you have symptoms and if you are like really troubled, you should immediately start the HRT, okay? And for initial 5 years, you can give the HRT. Yes.
Madam, is there any role of isoflavone, phytoestrogen?
There is no proven literature, but everybody's been using isoflavonoids and soya. I've yet to come across any proven literature. It must be helping some way or the other. It must be doing so.
Is there any need to add progesterone with phytoestrogen?
Sir, I have not found any literature. I have to tell you that I said in the beginning, this is my story. I'm a 50-year-old woman. So that is what the reason when we're talking to Dr. Virmani, he only said that do something different. I said, okay, I'll do this.
Thank you, madam. Now the next topic is one of the most important things, that acute coronary syndrome, what is new in 2023. I request Dr. Ajay Pandey to please come over to us and speak.
Good morning, respected chairpersons and delegates. My colleague, Dr. Monica, we both belong to the same institution where we passed out and practicing in the same city as well. There was a wonderful deliberation of women's health by Dr. Monica. Now the job assigned to me is regarding the discussion of ACS management and what is new in 2023. So 2023 is an important year for ACS management. Why? Because European Society of Cardiology has given a new guidelines regarding the ACS management. And as we all know that coronary syndromes are of two types, acute coronary syndromes and coronary syndromes. Acute coronary syndromes consist of STEMI, non-STEMI and unstable angina as well. And we have got a lot of medical therapies, revascularization therapies, as per the risk stratification. And we are taking this topic, why? Because there are really significant problems in our country. That cardiovascular disease is basically responsible for more than 80% of CVD deaths, and 272 per 100,000 population in India is having a death rate, whereas the global death rate is around 235 per 100,000 population. And there's a recurrent ischemic event which occurs in patients of acute coronary syndrome. And there's urgent need to improve the prognosis of patients with ischemic heart disease, and that's why we need something new to discuss regarding this. And the challenges exist in choosing between the multiple potential therapeutic combinations, ranging from medical therapy to interventional therapy. This is a very important slide discussed in the ACS management in 2023, that ACS patients, we have to think of ACS at initial assessment and an abnormal ECG, clinical context and stable patient. Then we have to think for invasive strategies like, those who are needing an invasive strategy, there are people with STEMI where we can take them for primary PCI, or if it is not feasible, at least fibrinolysis initially, then if needed primary PCI. People with non-STEMI or non-ST elevation, they have got very high risk and high risk categories, and they need to be taken for, invasive management strategy depending upon their risk stratification. Antithrombotic therapy is a mainstay of treatment for these group of patients. Antiplatelet aspirin, we all know, is an important option always, but P2 white valve inhibitors is now an add-on for them, as well as the anticoagulation therapy with unfractionated heparin, low molecular weight heparin, biliverdin or fondaparinux, any of them. And we have to think for revascularization in people based on the clinical status, comorbidities, and disease complexity. We have to aim for complete revascularization. Many times we think of, just doing a single vessel angioplasty. That may not be the case for all patients of ACS. That may cause recurrent symptoms. Consider adjunctive tests to guide revascularization, because nowadays the role of intravascular imaging, intravascular ultrasound, OCTs are coming up to guide the interventional cardiologist for the best possible revascularization therapy. Secondary preventions are also very, very important. Why? Because giving an antithrombotic therapy or antiplatelet therapy after revascularization or after ACS, lipid lowering therapy in a proper doses, smoking cessation, cardiac rehabilitation, risk factor assessment, and psychosocial consideration. These are all looks very small in quantity or size, but they are very, very important for management of ACS patients. And that's why 2023 ESC guidelines has given this diagnostic algorithm and triage in acute coronary syndrome. And what they say that as per the ECG, physical examination, clinical history, and patient's vital signs, as well as the cardiac troponin levels, we can, decide what is these all can be done at the primary care center. That's very, very important. And if uncertain findings on ECG, refer these patients to secondary care center or for a lab test, for an echo or non-invasive testing. Depending upon these important, primary care centers parameters, we have to decide between the, patients of STEMI, non-STEMI, those who are very high risk, and non-STEMI, those who are without very high risk feature. And we have to look for what the management options will be there in this group of patients. For STEMI patient, primary PCI or antithrombotic therapies and fibrinolysis are the important option. For non-STEMI, those who are very high risk people, they have to risk stratify them, take them for immediate angiography and PCI, and followed with, antithrombotic therapy. And non-STEMI without very high risk feature, we can consider angiography within 24 hours for non-STEMI with high risk features. And those who are not having these issues, the further investigation like non-immediate angiography, echocardiogram, intravascular imaging, non-invasive imaging, high sensitive troponin, and ECG monitoring are the important aspects in the armamentarium of management of these ACS patients. The further management of these patients require a PCI, CABG, long-term medical follow-up, lifestyle modification, and smoking cessation. Now, if you see the ACS assessment for the initial evaluation of patient with suspected acute coronary syndrome, it is an abnormal ECG, clinical context, and then we have to decide whether the patient is stable or unstable. As Dr. Monica was discussing about the difference between the women and men, 80% of men and women, they have a usually similar type of symptoms for acute coronary syndrome, but the last diagram, you can see that dizziness, nausea, vomiting, jaw, neck pain, and shortness of breath, they are more commonly seen in patients of ACS with women compared to men. Recommendation for diagnosis, risk stratification, imaging, and rhythm monitoring in patients with suspected non-ST elevation, acute myocardial infarctions are class 1, and these needs to be followed, and initial risk stratification is a very, very important aspect. If you see that how these are important ones, like ECG, doing a 12-lead ECG and recording the interpretation within 10 minutes of the patient presentation of the first medical contact is very, very important. If the patient, those who are looking for, you are looking for a STEMI, at least V3R, V4R, and V7 to V9 ECGs are also recommended in case of inferior STEMI or those who are having ongoing chest pain or total vessel occlusion. In addition, 12-lead ECG is recommended in cases with recurrent symptoms or diagnostic uncertainty. Blood sampling should be done as early as possible, and the high sensitive troponin result should be within 60 minutes. It should be there. initially many of us as a physicians are using one or only two sets of troponin, but the recommendation by European Society in 2023 is that at least 0 and 1 hour or 0 to 2 hour to rule in and rule out whether the patient is having ACS or not. The use of established risk scores like GRACE score, which were initially not so recommended, is now come up as a class 2A recommendation for assessment of, non-ST elevation MI. Triage of our emergency reperfusion therapy is very, very important in patients with suspected STEMI, and immediately triage for an emergency reperfusion strategy, whether in the form of thrombolytic therapy or a emergency PCI. This is a diagram regarding ruling in and ruling out of STEMI or non-STEMI in patients, those who are having troponin levels. Troponin high sensitive should be done 0 hour and 2 hour if the patient is having very low initial high sensitive troponin or low initial high sensitive with no increase in 1 to 2 hour. You can rule out this patient is not having ACS, but at least minimum 2 of the troponin should be done. And if the patient is getting a high initial high sensitive troponin or increase in 1 hour or 2 hour, their rule in pathway in between can be observed for some time, and then you can take on for other initial assessment in patient with acute coronary syndrome. Emergency transthoracic echocardiography in patient with suspected ACS presenting with cardiogenic shock or suspected mechanical complication is class 1 recommendation in 2023. But patients, those who have got a suspected ACS, non-ST elevation or uncertain high troponin, no ECG changes and no recurrence of pain, incorporating coronary cardiac CT angiography or a non-invasive stress imaging test as a part of the initial workup is now class 2A indication, but it should not be done as a routine coronary cardiac coronary CT angio in patient with suspected ACS. It's a class 3 recommendation, so this has to be taken as an important aspect. Patients, how to manage them in an emergency department. If the oxygen level is less than 90, supplement them with an oxygen. Routine oxygen use is not recommended, and it's a class 3 if the saturation is more than 90%. Intravenous opioids or mild tranquilizers are class 2A, means many of the physicians, they agree to that. An intravenous beta blocker, preferably metoprolol, should be considered at the time of presentation of the patient undergoing PCI, but should not have any signs of acute heart failure, and systolic blood pressure should be more than 120. There are class 2A indications. And pre-hospital care in these patients, we recommend for working diagnosis of STEMI. If it is a base, effort to be made to send them for primary PCI. It is recommended that primary PCI capable centers deliver 24/7 facilities. It is recommended that the patient transfer to primary PCI, bypass the emergency department. We should not waste time in the emergency department. They should be taken straight away to cath lab. It is recommended that emergency medical transfer patients and suspected STEMI to a PCI capable center. So these are the pre-hospital logistic care in these patients. Ambulance team people, they should understand how to identify ECG. They should be very well aware about giving the fibrinolytic therapy. Recommended that all hospital and emergency department participating in the care of the patient with suspected STEMI record and audit delay time that whenever the patient is reaching. Now coming to non-STEMI, the risk stratification is very, very important. Previously we were using these scores like TIMI score and GRACE score. Now GRACE score has been recommended as a class 2A indication. And there are many electrical ECG abnormalities seen with patients with non-STEMI. The two important ones like D Winters, STT changes, and valence sign, they are very, very important, and they suggest for proximal LED occlusion, they need to be taken care of. There are other, changes are also there. Like many times we see a T wave inversion in 1, 2 AVL and V2 to 6. They only mildly impaired prognosis. So this is not a very important ECG sign, but ST depression with the downsloping ST segment are the important ECG sign in patients with non-STEMI. These are the TIMI risk scores. We used to calculate quite a lot of them, and less than 3 is low risk, 3 to 4 is intermediate, and more than 5 or 7 is high risk. Now TIMI risk score gives you a prognostic information, and this is now routinely recommended. GRACE risk scoring system is now upgraded as a class 2A indication in ACC 23 guidelines, and more than 140 of GRACE score, and the GRACE score requires, Phillips class, blood pressure, heart rate, age, and creatinine levels. These all gives you a GRACE score. You all can find it in your mobile app. and less than 108 is low, 109 to 140 is intermediate, and more than 140. And with the help of GRACE score, you can determine in-hospital death and a post-discharge 6-month death. So risk criteria mandating the invasive strategy in STEMI are as follows: high risk criteria, intermediate risk criteria, and you have to follow these criteria in your day-to-day clinical practice. And then you have to go for selective invasive strategy and reperfusion strategy in therapy in patient presenting with non-STEMI. This is a very important slide. The suppose patient with symptom of ACS and ECG consistent with non-STEMI. There are two options. You can have a PCI center in your city. You can have a non-PCI center or ambulance. You have to see how is the patient, whether very high risk or suppose a very high risk. Immediate invasive strategy has to be taken and patient should be transferred to a PCI center. Those who are having these features, they are very high risk, like hemodynamic instability, recurrent ongoing chest pain, acute heart failure, life-threatening arrhythmias, mechanical complications. Those who are not having these, at least high risk, they need an early inpatient transfer. And those high risk features are GRACE score more than 140, transient ST elevation, dynamic STT changes. They need early less than 24 hours of invasive strategy. And those who are not having these non-high risk, they can be either selectively invasive strategy or inpatient transferred, and they can be monitored and risk stratified further. So these are the pharmacological treatments you all know very well about. Lipid lowering therapy, the newer guidelines which has come up in 2023 that we have to keep the lipid lowering drug therapy in such a way that the level should be, LDL cholesterol should be less than 55 milligram per deciliter. Within 4 to 6 weeks, with high dose statin it is not coming down, you can add azithromycin. If it is not coming down, in next 4 to 6 weeks you can add PCSK9 inhibitors. These are very well recommended. Now the other therapies like beta blockers, RAS blockers, and adherence to medications. The most important aspect which has come up is an anti-inflammatory drug therapy, which is now as a 2B indication, but low-dose colchicine may be considered, particularly if other risk factors are insufficiently controlled, as an immunomodulator. Adherence to polypill is also class 2A now. Routine ACE inhibitors in all ACS patients regardless of patient dual antitherapy for 6 months and then a single antiplatelet therapy beyond 6 months. For high bleeding risk patients, we can keep it only for 3 months as well. In all non-ST elevation and STEMI, at least 12 months of dual antiplatelet therapy, and then you can shift it to either a single antiplatelet therapy. Now coming to STEMI, we all understand that we have got different type of hospitals in our country, big cities, small cities, and villages. For villages, thrombolysis in nearest possible hospital, and for small town, hospital-based thrombolytic therapy, and if the failed thrombolysis, or as soon as possible within pharmaco-invasive strategy or within 24 hours, rescue PCI is an ideal choice. Thrombolysis in nearest hospital in villages, and then pharmaco-invasive guidelines has given that that gives us a clue, like ST depression more than 1 millimeter in 6 or more surface leads and coupled with an ST elevation in AVR suggests patient is having left main or multivessel disease. ECG and administrations of drugs, and this we have already discussed. There's an Indian study from Indian Heart Journal regarding the reperfusion utilization. There's so much of stress on reperfusion. Proportion of STEMI coming as an ACS in different studies from Kerala study, CREATE study, around 60 to 40% of them, and out of them 80 to 90% were thrombolized with STK, and newer antithrombotics, anti-fibrinolytic drug like TNK and all are very less, And you see the level of PCI, only 8 to 12% of patients are getting PCI in our country. So reperfusion versus fibrinolysis, I think still in many of the cities, fibrinolytic therapy is very, very important because the time is muscle and we need to, if we cannot get the PCI within 120 minutes of index event, then it is better to give them at least a fibrinolytic therapy. The common fibrinolytic agents, we all know about them. The streptococcus is an older one which we are using for a pretty long time. LT-plays, retiplase and tenecteplase are now in the market. Retiplase and tenecteplase are quite important and we are using quite frequently. Significant difference exists among various fibrinolytic agents for reperfusion therapy in STEMI and LT-plays, which is accelerated infusion. Tenecteplase and retiplase should be considered over streptokinase if the cost is the only issue. This is regarding the different classes of fibrinolytic. The big challenge is the late presentation because we see that many of our patients come very late. And if they are high-risk people, LVF less than 40%, then we should take them for CAG. If they are not having those high-risk feature, pre-discharge stress evaluation, and if they are having high-risk feature, then they have to take for CAG, or in CAG there is a 100% occlusion and patients come late, more than 24 to 48 hours, then viability assessment is the most important therapy. This is a basic approach in our country that, and this is the data came from Indian Heart Journal, that, patient of 1/3 of CAG patient, they go for medical management, and 2/3 those who are going for CAG in ACS, they are having for, revascularization. And only out of those who are having these 2/3, 50 to 60% are there going for revascularization therapy. Now coming to the anticoagulation therapy, we all understand that in patients with ACS, anticoagulation therapy is very important. Which antiplatelets to be given? The newer antiplatelets like ticagrelor and prasugrel is in the market, and administration of pre-hospital ticagrelor is safe and may prevent the post-procedural acute stent thrombosis. But definitely, Atlantic study is a very important one which has shown that the rate of definite stent thrombosis was lower with ticagrelor. In Indian context, ticagrelor has been used across ACS types and different management strategy in real-world settings in India, and the incidence of clinical events was lower in compared to data in the literature. So post-thrombolysis, as we have discussed, even in patient it is safe to administer ticagrelor even within 24 hours. It is said that the fibrinolytic therapy is given, then we should avoid ticagrelor in the first 24 hours, but just JACC paper in 2019 shows that it is safe to administer ticagrelor even with 24 hours of fibrinolytic treatment in patient with STEMI. Now the modes of presentation and pathway for invasive management of myocardial infarction. This I have already discussed, that if suppose the patient has got a PCI capable, we should go for a primary PCI. Aim is to do less than 60 minutes of wire crossing. In PCI possible in less than 120 minutes, then we should proceed. Otherwise, we should not waste time and take it for a pharmaco-invasive approach. That is a very, very important. There is a recommendation for reperfusion strategy for patient with STEMI, and we all understand that routine primary PCI strategy should be considered in STEMI patient presenting late. So, though this was a quite bigger topic, so I thought to cover it all, but these were the few important points which I have taken in. The new important points which I am going to summarize, that there are many other patients of MI with non-obstructive coronary artery disease, and these patients also needs to be investigated, and there are many other etiologies for them. There are several other complications or problems during acute coronary syndrome like arrhythmias, heart failures, bradyarrhythmias, and elderly people, they need to be taken care of. Cancer patient, I just want to highlight one important thing, that aspirin is not recommended in cancer patient if the platelet count less than 10,000. Clopidogrel is not recommended if it is less than 30, and in patient with cancer, ACS and cancer, if it is less than 50, platelet count, prasugrel or ticagrelor should not be recommended. So long-term management, I have discussed already that we have to look for cardiac rehabilitation, lifestyle management, pharmacological treatment with lipid-lowering drugs, beta blocker, ACE inhibitors, and ARBs, adherence to medication, imaging. Vaccination is very, very important because, the influenza vaccine is now class 1A indication for all patients of ACS, and we should take it for granted that they all should receive it. Person-centric approach is now preferred. We need to teach and back technique. This is an important technique that ask the patient to explain the concept, explain the new concept to the patient, ask the patient to explain, and this way we should teach the patient. Patient concern and educational needs to be taken care of. And this is an overview of what I have taken as the first slide. And this is the really a new 2023 ESC guideline, which gives us a real clue. And to end my discussion, there are a few very important concluding remarks. Myocardial revascularization is performed for the relief of symptoms of myocardial ischemia and improvement in prognosis. Timely PCI of the culprit lesion remains the mainstay of treatment of STEMI ACS patient. Low-risk non-ST animation and unstable angina can be managed at primary care center with appropriate antiplatelet and risk factor management. Timely referral or thrombolysis is a key to better outcomes, and we should take care of that. Current guidelines provide class 1 recommendation for ticagrelor and clopidogrel for 12 months for patients with STEMI treated initially with conservative or invasive management, and prasugrel for 10 months in patients with ACS treated with PCI and coronary anatomy is known. Even though 12 months of DAPT is generally recommended after PCI and STEMI, but even those who are a high bleeding risk patient, you can reduce it to 6 months as well. Monotherapy can be considered post-PCI in selected patients. However, decision must be taken by cardiologists. So thank you all for your patient hearing.
The difficult subject so simplified so that even undergraduates can also understand this.
Thank you, sir.
Thank you very much, Dr. Pandey, for giving me such a time. Any question from the audience, to Dr. Pandey?
Pardon?
So, like when a patient comes to you with acute chest pain, so first thing, like we've always been taught about aspirin being the preventive drug.
Yeah.
So, what is your take
Aspirin,
on this?
I've shown this slide that aspirin is always the first, and in the management of patients of ACS, antithrombotic therapy, the first antiplatelet is an aspirin has to be given. It should be soluble aspirin to be chewed, and then because there are multiple pathways where the platelets are acting, so single antiplatelet modality of aspirin will not help. Adding another dual antiplatelet is important. Initially we were using clopidogrel quite a lot, but the new literature has showed that ticagrelor is better compared to clopidogrel. We have got a lot of scaring that if it is ticagrelor is given within 24 hours of a thrombolytic therapy, there are high chances of bleeding. So initially there was a lot of recommendation that ticagrelor should be given if you're using a fibrinolytic therapy after 24 hours. But now there are different trials which have shown that even 12 hours of fibrinolytic therapy it can be given, and it gives a long-term benefit. In patients of those who are taken for a primary PCI, preloading them with ticagrelor or a prasugrel are beneficial for preventing the stent thrombosis. It will not improve the outcome of angioplasty, but stent thrombosis can be prevented. So aspirin still remains the first choice. But suppose somebody has got an allergic to aspirin or having GI bleed, even after 3 to 6 months of post-PCI, you can shift them to ticagrelor-like drug, which are potent. You can take them on monotherapy. The trials are coming up, but the recommendation has not yet come up that you can go for a monotherapy. But you have to take them for a monotherapy. The best is a potent ticagrelor compared to clopidogrel whenever you are going to take it. Otherwise, in a stable ACS patients, you can after 6 months you can shift them to monotherapy. Otherwise, all ACS with STEMI and non-STEMI, at least 12 months of dual antiplatelet is still the guideline-directed therapy.
Can I ask you a question? Sorry.
Sure.
So last month there was a huge trial that was published in the Annals of Internal Medicine where they compared colchicine 50 milligram against aspirin with ticagrelor or prasugrel. And they found non-inferiority or slight superiority of colchicine over aspirin in post-PCI patients. Your thoughts on that?
I can't give any thoughts on these recommendations, but I have shown one slide by this ESC 2023 recommendation that colchicine can only be started as a 0.5 milligram daily, but that cannot replace dual antiplatelet therapy. In patients, the guideline says that it can be given in patients where the other risk factors are still are controlled, but patient, you see this slide, the last one, the low dose colchicine, I think the slide is not coming in. The low dose colchicine of 0.5 milligram daily may be considered, particularly if other risk factors are insufficiently controlled or if recurrent cardiovascular disease events occur under optimal therapy, and that is class 2B. 2B means many of the physicians, they don't agree to that. So still it has not come as a class 1 or class 2A recommendation. So, but this is coming up, like many of us are discussing regarding the anti-inflammatory therapy in diabetes yesterday, and anti-inflammatory therapy in a chronic coronary syndrome as well. So here the role is coming up, but still it has not come as a recommendation in the guideline. So those who are having a recurrent cardiovascular events, on all the risk factors are complored, their LDL is less than 40, because the patient, those who are having recurrent cardiovascular events, the LDL goal of 55 milligram, they have reduced to 40 milligram. And even with that, and that is only possible if you add statin with ezetimibe or bempedoic acid or PCSK9, because without going for a high dose, statin, we're not able to achieve the goal of 40 milligram of LDL cholesterol. So yeah, definitely the low dose colchicine is coming up, but still not recommended as a class 1 or not even class 2A. It is 2B recommendation, but not for all patients. Yes,
Yeah,
Okay. Okay.
as usual, very nice lecture.
thank you.
Yeah, I think regarding management of ACS, if some secondary care center is managing ACS and some tertiary care, it is entirely scenario is different,
Yeah.
Doing intervention, putting stent, and so one thing like ticagrelor, as you mentioned, MEMAS, the concept of loading is still same, 300, 380, or you are replacing clopidogrel with the ticagrelor while working on secondary care center?
Yeah, definitely.
Simple question.
Whether primary care or secondary care, the antiplatelet therapy regimens remain same. If you are taking them for a high risk invasive strategy or a high risk ACS patient, whether it's a non-STEMI, it is better to load with ticagrelor 180 milligram or a clopidogrel if you are giving, at least if the patient is not taking, give him 600 milligram of
Now,
clopidogrel.
if I am sure
But
that
now it is widely available and it is very cheap, ticagrelor. So we all are using, as a dual antiplatelet, ticagrelor as a loading dose. The only issue is that whenever taking them for a fibrinolytic therapy, like you want to want to take him for a thrombolytic therapy, it is better to load with clopidogrel.
clopidogrel, yeah.
Yeah, if you are going to give them a thrombolytic therapy,
Yeah.
because there is a risk of high bleeding risk,
Yeah.
giving ticagrelor in first 24 hours of thrombolytic therapy. But the recent trials, they have shown, once published in JAC 2019, that if the ticagrelor is given within 12 hours also, it is not going to cause you, that amount of bleeding risk. So it can be given up to 12 hours, but still the recommendation has not come for fibrinolytic therapy to start with load with ticagrelor. But if you are going to take the patient for a invasive strategy in the cath lab, you can load with ticagrelor and aspirin and take them for cath lab.
I mean, just to, if you go
And
for
we are
invasive,
in time.
ticagrelor.
Yeah.
Thank you. Yeah, please.
Very short of time.
Thank you.
So thank you very much, Dr. Pandey, and let session comes to an end.
It was an excellent session. So I request chairperson to deliver the token of appreciation to the speakers. So Dr. Latanu Manti, please. Dr. Monica Gupta, please come to the dais. And Dr. Ajay Pandey, please come to the dais. I request the speaker, Dr. Ajay Pandey sir. Dr. Ajay Pandey sir, please give the token of appreciation to the chairperson. Yes, ma'am, please, ma'am. Okay, thank you. So the next session will be Dr. Muruganathan orations. This session is in the BC Roy Hall, and I request audiovisual team. Sir. Yes, sir. But the video link will be play here, sir. Okay, I request audiovisual team.
Again, very good morning. And last session, we are going to a very good speaker, and we know this hall will become full after few time. People start to coming. Yeah. So calling to our chairperson, Dr. Monica Gupta. I think she is from Varanasi, and Dr. Satyapriya Mishra. Welcome to both chairperson, and over to you, please, to invite our speaker, starting with Dr. Sanjay sir. I think hope it will be very mesmerizing speech here. Please.
Good morning, everybody. Now moving to the next session. I will invite Dr. Sanjay Agrawal to talk about novel concept in management of diabetes kidney disease. Over to you, sir.
Good morning, ladies and gentlemen, and I would like to thank the entire organizing team of ACP for giving me this opportunity to speak here today. I just want to talk what we really know now about management of diabetic kidney disease, and it's kind of some of the newer concepts that we think are shaping up in the management of DKD, as well as I just want to review some of the earlier data. Now, we're quite familiar with the fact that diabetes remains the most common reason for progression to end-stage kidney disease in many parts, and it's also a strong predictor of mortality and cardiovascular disease. And sometime back, the CKD registry pegged down that what is the incidence of diabetic kidney disease in India, and this was run by Dr. Rajapurkar from Nadyad, which, of course, the registry is now shut down. But they found that almost 30% of our population with diabetes end up getting diabetic kidney disease. And this is all across the country in different zones. And this is not very different from what the statistics are from the international community, where they found that almost 40% of patients with type 2 diabetes end up with presence of kidney failure. But what is more important to note is when you break down into the stages right from stage 1 to stage 5, what is the awareness about recognition of diabetic kidney disease amongst the healthcare professionals. And this study, the AD-CKD study, looked at that how many patients were diagnosed in different stages. And you can clearly see here that in stage 1, almost 99% of the patients were not picked up. In stage 2, 95%, stage 3, 82%, stage 4, 47%, and stage 5, 41%. So clearly you can see that almost about half the population of people were not looked at or not diagnosed for kidney disease, all the way up to stage 4 or stage 5 end-stage kidney disease. And the first presentation was in the form of end-stage kidney disease. So it's important that at all points of time, we should be picking up these very early. Our threshold for doing the microalbuminuria estimations should be very low, and we should be doing this in all our population right from the time of diagnosis onwards and periodically, so that we can assess what is the kidney function of these patients. And the moment you find that there is a gradual trending towards increase in the albuminuria status, or in terms of reduction in the GFR, we know something is going wrong with the kidneys. Now, why do I say that albuminuria estimations are important? Because there's a direct correlation that as albuminuria tends to go up, there is a strong reduction in the GFR values. And the higher the proteinuria, the faster the GFR decline that you tend to get. So it's important that when you pick up proteinuria early, measures should be instituted, and we have the tools for managing albuminuria now with normal GFRs. So can we sort of prevent or sort of regress macroproteinemia to microproteinemia, and from microproteinemia to normal proteinuria? So if you can achieve this, you're going to reduce or delay the onset of GFR decline and to progression to end-stage kidney disease. Now, diabetic kidney disease is diagnosed when you have a persistent low eGFR of less than 60 or elevated albumin creatinine ratio of more than 30 or both of them together. And we know now that if you have CKD, and this is the KDIGO classification, which looks at the proteinuria versus the GFR, and when you see a progressive GFR decline and an increase in the albuminuria, you know that this patient is going to end up quickly with an end-stage kidney disease. Now, it's important that we recognize our patients for presence of kidney disease, because if you look at the transition rates of nephropathy and death in type 2 patients, and this comes from the UKPDS study, we see that as patients progresses from no nephropathy to microalbuminuria to albuminuria and elevated creatinine or renal replacement therapy, look at the annual death rate. It goes all the way from 1.4% all the way to 19.2% in terms of mortality occurrences. So if you can reduce the proteinuria and keep your patients from a decline much faster, you're going to reduce the annual death rate of these patients and keep them more safer in the long run. Now, we have data which suggests that if you have presence of diabetic and kidney disease, this is the perfect substrate for all-cause and cardiovascular mortality. And these are independent risk factors. So if you look at the bar diagram, you've got, if you look at the two bars, you can see here that patients who have got none versus patients who have got only kidney disease, or versus only kidney disease, or a combination of diabetes and kidney disease, you clearly see that when you have the occurrences of both, it sort of almost you get increase the risk for myocardial infarction by 3 times, and the risk for hospitalization for heart failures by about 3 to 5 times when you have only diabetes alone. Now, this has also been validated by a population level cohort study, and there are a number of other studies where you can see similar statistics where you have a combination of diabetes and chronic kidney disease, which increases the mortality by almost 5 times in the study. So having seen this background, but the importance of albuminuria and decline in the kidney function and the correlation to increased occurrences of cardiovascular events and mortality, are we doing something about it? And in the next sort of slide, I want to sum it up and show you that these are the intervention points now that we are looking at for interventions for diabetic kidney disease at all stages. So right from nutrition modulation, smoking cessation, blood pressure control, use aggressively of RAS blockades, GLP-1 analogs, use of antiplatelets and GLP-1 analogs together, lipid management. Again, you've got, weight control because there's a direct correlation of weight and GFR declines. Use of mineralocorticoid antagonists, metformin and SGLT2 inhibitors, glycemic targets, how aggressive can you get, exercise. And these are all sort of summing up that if you can do this, at least majority of these risk factors that can be controlled and interventions that can be instituted, you may be able to keep these patients healthier and safer. Now, we have a lot of trials where you've seen that combinations of diabetes with various comorbidities, you have the benefits of SGLT2 inhibitors, GLP-1, RAS, and MRAs. And these now have become the mainstay of treatment in the algorithms of treatment that you can see. So if you have somebody with diabetes and ASCVD or diabetes with hypertension, or with heart failure, obesity, or hyperuricemia, or chronic kidney disease with proteinuria and GFR loss, you can see here that these combination agents have far superior benefit and positive outcomes versus the routine standard of care treatments that you see. And you have validated large trials which endorse these changes to happen. Now, all the while, I have been saying that we need to pick up our patients with kidney disease much earlier. And I just want to illustrate my point by showing you this diagram. If on the left you can see the graph. Suppose you have a patient with age of 70 years, and you have a GFR of almost about 70 ml per hour, and you pick up these patients early and institute intervention versus if you had done no intervention for this patient. Clearly, the intervention group, you will be able to extend his life and time to end-stage kidney disease and renal replacement therapy by almost about 11 years. Now, consider the same person, age of 70 years, and you pick up this patient when the patient has a GFR of 30, and you intervene at that point of time versus no intervention, then you're prolonging his lifespan by only about 3 years. So you can see the disparity that you tend to get when you pick up somebody very early in the course of the disease versus late in the course of the disease. And this has been shown in numerous trials that how the benefits of early intervention is versus late intervention. So please do not miss out the early diagnosis and don't sort of, miss out checking for microalbuminuria earlier on, because this is the point of time where most aggressive intervention should happen. It's like akin to the fact that, are you going to wait for your pre-diabetes to become over-diabetes, or are you going to institute measures for prevention of conversion of pre-diabetes to diabetes? Or for that matter, we talk about pre-hypertension and hypertension. So this is something like that, a group of patients where you've got albuminuria, microalbuminuria, and UHCR of more than 30, and yet not microproteinemic, and you have normal GFR. So why are we not looking at these patient groups much aggressively, given the fact we have a robust trials which tell us that this benefits? These are the new ways that we are looking at, that it's just not good enough to look at glycemic targets in patients with diabetic kidney disease. We have now tools which address the hemodynamic factors, inflammation and fibrosis, and of course, metabolic control. And we know that all this benefits in terms of, if you don't intervene, then these are the very points that causes tubulointerstitial damage and inflammation, glomerulosclerosis, mesangial expansion, and glomerular hypertrophy, which ultimately leads to kidney fibrosis and CKD progression. So now we have got a three-pronged approach, and this is ticking all the boxes, where we say each of our patients, can we give them ACE-ARBs, SGLT2 inhibitors, and non-steroidal MRAs. And how does this benefit? Because we've seen now the three-prong that we need to address. So it causes a reduction in glomerular hypertension, blood pressure control, glycemic control, CV risk reduction, anti-inflammatory effect, anti-fibrotic effect, weight loss, and uric acid reduction. And given this combined effect that you tend to get, you find that if you use a combination of ACE ARBs, SGLT2 inhibitors, and non-steroidal MRAs, these will probably tick all the boxes and benefit the patient in the long run in the progression of the kidney disease. This is the guideline that was put out by the UK Kidney Association in 2021, and they talked about management of hypertension in patients with diabetic kidney disease. Now, lifestyle management remains uppermost with physical exercise, maintenance of body weight, reduced salt intake and alcohol intake, but they have categorized patients as per who should get a blood pressure target of 120/80 or less than or equal to 130/80 or less than 140/80, less than or equal to 140/90 or less than 150/90. And there are clear groups or clusters of people who would have a differential blood pressure control or targets which will benefit these patients. So should all people get 130/80 or should all get 140/90 is what we looked at. They also looked at that can we differentiate between type 1 and type 2 and look at patients' subgroups of normal kidney function and normal albuminuria, normal kidney function and microalbuminuria, CKD stages 1 to 3, CKD stages 4 to 5 and 5.
And in each of these subsets of population in type 1 and type 2, what should be the blood pressure goals that we should be looking at? But one thing stands out. When you have patients earlier on the course of the disease, your targets should be as aggressive as possible, and the recommendations are that you should keep them closer to 130 by 80, and maybe you can go up to 140 by 90. But when you have an end-stage kidney disease, this benefit tends to go, and you need to probably keep them at around 140 by 90. But you have to institute early onset of aggressive targets in your patients. And then, of course, you have good trials which have been validated. I just want to talk about these 3 trials which looked at the role of ACE and ARBs in terms of reduced risk of rapid GFR decline, kidney failure, and death in type 2. And you can see here the benefits of ACE-ARB versus other active comparators or placebo. And you can see the ACE-ARB groups have shown a much better outcomes. So let me now give you some summing up of what is the role of oral agents and do they have strong benefit. So if you look at metformin, it has weak cardiovascular evidence for benefit. There is no kidney data. Sulfonylureas, they're neutral on cardiovascular events, and there is no kidney data. DPP-4 inhibitor agents, they're again neutral on cardiovascular events, no kidney data except for linagliptin, which is neutral data. And acarbose, cardiovascular and kidney data is neutral or there is no data at all, right? Now, the GLP-1 agonists are the ones which have shown a positive CV outcome data, as well as there is a good data which is again positive in terms of benefit. And then, of course, SGLT2 inhibitors, they have a host of trials which have shown positive cardiovascular and kidney data. So I'm going to go very rapidly in what is known in these areas, and I don't want to spend too much of time on it because you've already known this data for a long time. What about the DPP-4 inhibitors? And you've got some landmark trials right from Saver-TIMI, Examine, TICOS, and Carmelina, which have shown, which have looked at basically pre-specified kidney endpoints of albumin-creatinine ratios and post-hoc analysis of doubling of creatinine in initiation of chronic dialysis, kidney transplant, or serum creatinine of more than 6, and composite endpoints of death and any of the above. Examine again had similar endpoints. There was no pre-specified kidney endpoints, but the post-hoc analysis or initiation of dialysis and change in eGFR. TECOS, again similar, eGFR and albumin creatinine ratio. And Carmelina was, of course, pre-specified endpoints of composite kidney endpoint, death due to kidney disease or end-stage kidney disease, and microvascular composite outcomes of albumin progression. And you can see here that if you look at just Carmelina trial and Saver-TIMI and TECOS, the benefit has only been in the albumin-urea progression, whereas there has been no significant change in the outcomes in all the other endpoints that you can see. So if you want to just take away one point from the DPP-4 trials, then it is just that the benefit is in the albumin-urea progression, whereas there is no significant benefit in all the other endpoints. And you can see here that from the Carmelina trial, there's 14% lower risk of progression to albumin-urea, and that's where it stops. And dosing, of course, has to be titrated as per the eGFR of the patient. What about GLP-1 analogs? And you can see here that, again, the benefits in the composite renal outcomes are driven by new onset of persistent macroalbuminuria, whereas there is no significant benefit when it comes to doubling of creatinine level or continuous renal replacement therapy. And these have been seen in various trials where you see the benefit mostly in the albumin-urea status and not in the other outcomes that you can see. So if you want to look at all the other GLP-1 analogs, then exenatide immediate release you avoided if eGFR is less than 30. Liraglutide you can use all the way up to eGFR of 15. Exenatide modified release avoid if eGFR is less than 50. Lixisenatide avoid if eGFR is less than 30, but you exercise caution between 30 to 50. Dulaglutide you can use all the way up to eGFR of 15, and subcutaneous semaglutide you can use all the way up to eGFR of 15. SGLT2 inhibitors, I think we are quite familiar with all the trials, and these are the demographics. I just want to state in the interest of time, come straight to the DAPA-CKD outcomes, because I think I'm running short of time, but we are quite familiar with all these outcomes. of the credence and other groups where we have shown a clear benefit in all these kidney outcomes and the positive outcomes. So if I just have to look at the DAPA CKD, and you can see here the composite of primary composite outcomes of more than or equal to 50 in terms of eGFR decline, end-stage kidney disease, renal cardiovascular death. And if you look at all the subgroups of the composite outcomes, there is a clear benefit in the dapagliflozin group as against all the other groups. And this was not different very much whether the patient had presence of diabetes or no diabetes, whether the patient had an albumin creatinine ratio of more than 1 gram versus less than 1 gram, or eGFR of more than 45 versus less than 45. And you can see the summary where 39% relative risk reduction for the primary composite outcomes in whether it is more than or equal to 50% sustained eGFR decline, end-stage kidney disease or renal or CV death, 44% relative risk reduction of renal composite outcomes, 29% composite outcomes for CV death and hospital and heart failure, and 31% risk reduction for all-cause mortality. I just want to come to the last part, and this is a use of firanone, because we now have a lot of outcome data with firanone, and you've got the Fidelio DKD, which looked at the primary outcome in the kidney composite outcomes. Hypothesis being that firanone slows CKD progression, reduces cardiovascular morbidity and mortality, and Figario DKD, where the primary outcome was a CV composite outcome. The hypothesis being that firanone reduces the CV morbidity and mortality and expands the evidence base to cover broader CKD in type 2 diabetes population. And you can see here the composite outcome, there was almost about 18% reduction in the primary composite outcome in the Fidelio. In the Figario, again, about 13% risk reduction. But what is important, if you look at the pooled data of both the trials, then you can see the benefits were sort of neutral or hypothesis generating towards reduction in all the composite cardiovascular outcomes, but there were clear benefits seen in the composite kidney outcomes and hospitalization for heart failure, where there was a clear benefit that you can see in the pooled data analysis. We don't have too much data on type 1 and kidney disease and the therapies that whether the same therapies are effective. That's because there are not many trials in type 1. The data, because we don't have too much of type 1 population, so you can't do large population studies with type 1 population. But obviously what works in type 2 should also work in type 1 patients. And most of the trials have shown a clear benefit. So if you look at all the trials, can I take 1 minute more? I have a lot of time, but I'll just take 1 more minute to sum up. So if you look at all the trials and how many patients had population with diabetes and type 2 and type 1, there were only 2 trials which looked at amongst all the plethora of the trials with type 1 patients. So I just want to end up with my take-home messages that this is what the KDIGO ADA Guidelines 2022 recommends for a holistic approach. So first-line therapy should be SGLT2 inhibitors, metformin, and then of course your additional risk stratification. You look at GLP-1 analogs and other glucose-lowering therapies. Use RAS inhibitors if hypertension is present. Use non-steroidal MRAs. Or you can use dihydropyridine calcium channel blockers and then follow it up with steroidal MRAs. And obviously, because of the high cardiovascular risk, these patients should be on moderate to high statins, antiplatelet agents for clinical ASCVD, and then you can use ezetimibe, PCSK9 inhibitors, or icosapent ethyl if indicated based on the ASCVD risk and lipids. The IDF, along with International Society of Nephrology, has put out a strong data or a statement renewing the fight and a call to action for diabetes and chronic kidney disease, where they have looked at 9 points of intervention. And this should be sort of because they felt that the CKD in people living with diabetes is common and the consequences are grim and we need to take an action. So they have recommended 9 action points, which I urge you to read them. So I'll end my talk here and thank you very much for your patient listening.
Thank you, sir, for your excellent presentation. Any question from the floor?
Can be used up to GFR of 15.
Yes.
What about the oral?
We don't have data about the oral as of now.
So till date,
But I suppose you should be able to use it in low GFR states, because if you can use the injectable, then the oral should also be possible to use that.
Thank you.
Those having USCR more than 30, but it's going on, is increasing. So we ask the OPD patient to come after 3 months and to repeat the USCR. But we find that in between also it is rising. So at what stage should we add phenylalanine?
So basically there's data to show that it's an antifibrotic agent. The benefits start very early, and you can use in your maximum benefits and right from stage 2 to stage 4 disease when there's a fibrosis that is happening. By the time you've already come to stage 5 or end stage kidney disease, your fibrosis have already happened. There you're not going to help in terms of progression of the kidney disease because you've already reached the end organ failure. There, if you want to use it, it is going to be more for the cardiac outcomes, whether hospitalization for heart failure or anything. Now, if you have a UACR, you said of more than?
More than 50, 60.
Okay, so you're talking about...
Which is going on.
And you're talking about an EGFR of?
EGFR is not very low.
So clearly the benefit is more from stage 2 to stage 4 that you're looking at. So you should use phenylalanine very early in the course of the disease and not later on, because by then the fibrosis have already occurred, the kidney damage has progressed. So stage 5 and end stage kidney disease where the GFR is less than 15 are not going to benefit in terms of progression to the kidney disease with phenylalanine at that point. If you can still use phenylalanine, but it's more for cardiac outcomes and hospitalizations for heart failure.
Sanjay, for a lucid presentation. Thank you so much.
Thank you very much. Thanks.
So, going for the next topic, acute kidney injury, high value care by Dr. Manisha Sahai.
So good morning and thank you for giving me this opportunity, and I welcome you to this topic, acute kidney injury. So why is it important? Why is AKI important? It's important because physicians see a lot of AKI. All specialties see a lot of AKI. Overall, it's around 20%. That's a huge number. And in ICU, it goes up to 50%. You must be having these experiences. In intensive care, almost every other person has AKI. The risk factors are elderly, those dehydrated, diabetic patients, underlying CKD and nephrotoxic drugs who are on long-term painkillers. Those people are at risk for AKI. Fine. And it's important because 20% of AKI progresses to chronic kidney disease. And in addition, if it is sepsis AKI, the mortality is 50%. So AKI, everybody has to know, not only the nephrologist, the physicians, the GPs, everyone has to know about AKI. Now, how do we define AKI? It's important because previously we used to wait for the urine output to go down, swelling to appear to think of AKI. It's no more so. A minor rise of creatinine of 0.3 milligram per DL, 0.3, sometimes we don't even care about it. It is sufficient to define AKI, along with a decrease in urine output, 0.5 ml per kg per hour for 6 to 12 hours. Even if there is no decrease in urine output, if the creatinine goes up, it's still AKI. Then depending on the magnitude of rise of creatinine, you have different stages. Stage 1, we already know, 0.3 milligram per DL. Then stage 2 is 2 times rise of creatinine and a further fall in urine output. Stage 3 is 3 times rise of creatinine and a further fall of urine output. Staging is easy. Once you identify, you can stage it. The main thing is we miss the AKI. So remember that whenever high-risk people are admitted in your ICU, please check for AKI. This is very important. You have to pick up that 0.3 milligram per DL rise. What are the common causes of AKI? We all know traditional teaching, pre-renal, renal and post-renal. Pre-renal means kidneys are normal, but the blood is somehow not flowing to the kidney. And why is the blood not flowing to the kidney? Either because the patient is in hypotension, or there is volume loss because of maybe blood loss or gastroenteritis. So there is less volume in the body, or the heart is not beating properly, cardiogenic, it's not pumping blood properly, or there is sepsis or vasodilatation. So what's happening is the blood vessels are dilated and the blood is pooling in the blood vessels and not going to the kidney. This very often occurs in sepsis. Another important cause is vasoconstriction because of some drugs which we use, which constrict the renal arteries specifically, and as a result the blood doesn't flow to the kidney, or because of hyperviscosity. One condition is polycythemia vera, where the blood becomes so thick that it doesn't flow to the kidney. And one important cause is hepatorenal syndrome. What happens is here the blood gets diverted to the splanchnic circulation. So it's very clear, pre-renal, the kidneys are perfectly normal, but the blood is not flowing to the kidney because of so many reasons. Now the next important category is renal, where the pathology lies in the kidney itself. We know glomeruli, tubules, interstitium, microvessels are there in the kidney, and pathology can lie here in the renal forms of AKI. And what causes renal form of AKI? It may be infection, drugs, toxins, poisons, and malignancies. Infections are very common in India. Malaria, dengue, leptospira, scrub typhus, bacterial, viral, COVID, fungal, HIV, everything under the sun can cause AKI. Drugs, I'll enumerate them later. Toxins, for example, myoglobin is a toxin, hemoglobin is a toxin. Poisons, poisons can be so many, hair dye poisoning, paraquat poisoning, so on and so forth. Malignancies can also sometimes manifest as AKI. One important malignancy is multiple myeloma, which can present with AKI. Post-renal, here the kidneys are again normal, but there is obstruction to the urine flow because of maybe stones, malignancy, so many conditions which obstruct the urine flow. So etiology is very clear. This was one paper, hair dye ingestion, an uncommon cause of AKI, which we had published in JAPI. And this is unique to India, all sorts of dyes, poisoning, herbal medicines, Ayurvedic. This is unique to our country. Another important new cause is added, heat stress nephropathy. Do you know working in the hot sun and not drinking enough water can cause AKI? So this is the latest entrant to the etiology of AKI, heat stress nephropathy. And it can lead to CKD as well, such a small cause. We don't even realize in India, we work out in sun and don't take plenty of water. Another classification of AKI which we should be aware is community acquired and hospital acquired. Community acquired is common garden variety you see sitting in your OP. Scrub typhus, malaria, even pregnancy AKI comes under community acquired. It's not related to the hospital admission. So any AKI which can be detected within 48 hours of hospital admission, that means it was acquired before the patient got admitted to the hospital. That's called community acquired AKI. And hospital acquired is any AKI which occurs after 48 hours. So it's important to know that because community acquired has a better prognosis than the hospital acquired AKI. Hospital acquired occurs because of multiple drugs which are given to the patient, because of hypovolemia which occurs in the patient in the ICU. What are the symptoms of AKI? We all know decreased urine output, swelling. It's easy to understand that. But more important, it may be asymptomatic completely. I said just a small rise of 0.3 milligram per DL. We often miss it. Breathlessness, encephalopathy, seizures, vomiting. So vomitings, the patient goes to a gastroenterologist. Sometimes missed. Breathlessness, the patient goes to a cardiologist. Again missed. Encephalopathy and seizures, the patients, Indian patients, straight rush to the neurologist. So it's often missed. So AKI can present in many ways. So how should we identify these AKI? Take always a proper history when the patient comes to you, detailed history, fever, jaundice, dysuria, hematuria, gastroenteritis, stone passage, whatever causes of AKI you can think of, take proper history. Drug history is very, very important. NSAIDs, very important. Different type of antibiotics, vanco, aminoglycoside, amphotericin, sulfa are the 4 major groups. RAS inhibitors, very important. SGLT2, previous speaker has shown SGLT2 should be used. But again, they are also important cause of AKI. Contrast AKI, any CT angio done, please keep in mind, check a creatinine. Warfarin AKI is becoming very common nowadays. And bile acids, oxalate and uric acid. So these are all the drugs and toxins which can cause AKI. And keep in mind to check for all this in the history as well. Do a proper examination. Power of eye and power of hand is very, very important. So the first picture, jaundice and subconjunctival hemorrhage with AKI. What's the diagnosis? Leptospira AKI. Then again, high colored urine. It's generally rhabdomyolysis, myoglobinuria AKI. Then the third picture shows a lesion there, eschar. And the diagnosis is scrub typhus AKI, which is common in India. And the last picture shows digital gangrene with AKI. So never miss ethyloembolic cause of AKI. So these are important points on physical examination. Now coming to the diagnosis, the definition is by doing a creatinine and urea. So we have already done it and identified AKI. The remaining investigations are targeted to find out the cause of AKI. Urine examination, culture, blood culture, CRP to look at infection, CBP, LFT, electrolytes, ABJ and lactate for management as well, ultrasound, and serology. If we are not able to find out the cause with routine investigations, and if the patient has some proteinuria and RBC, always do a serology to rule out a glomerular disease or vascular disease. And biopsy, if everything is negative, the patient has unexplained AKI or is not improving within 10 days, think of doing a biopsy as well. Biopsy is also done if you have proteinuria and hematuria, because that shows that it is probably a glomerular disease and you need a specific treatment. But most of the times in AKI, biopsy is not needed. Major cause of AKI in our country is infection or volume loss or drugs. These are the three major causes. So start with the urine examination. You can see epithelial cell casts, these are normal. If you had muddy brown casts, they indicate ATN. If you have casts like this with cells and granules, it's acute interstitial nephritis. And if you have RBC casts, it's glomerulonephritis or vasculitis. So it helps in making a clear-cut diagnosis with urine examination. It's liquid gold biopsy we call urine examination. Most of the times we either do not get it done, or even if the report is there, we forget to have a look at it. So it's important. Urine electrolytes, these are not much done, but we should know about it because they help in differentiating pre-renal and renal. Pre-renal, you will have a urine specific gravity which is high. Urine is concentrating. Kidney is able to concentrate the urine. Kidney is able to absorb sodium. So you will have a high urine specific gravity and the urine will have a low sodium because kidney is able to absorb it. Whereas if it's a renal AKI, what will happen? Kidney will not be able to concentrate the urine. It will be a dilute urine. Specific gravity will be low and kidney will not absorb sodium. So a lot of sodium loss in the urine. So urine sodium will be high. So urine examination done. We have some clues there. We are not doing urine electrolytes because most of the patients are on diuretics by the time they reach the doctor and the urine electrolytes get altered. Next is CBP. Look at the schistocytes, and if the platelets are low and if you have fragmented cells, the diagnosis is AKI because of hemolytic uremic syndrome. So never miss looking at the CBP picture. Then we always get an ultrasound done. So now first ultrasound shows hydronephrosis. So it's a post-renal AKI. The second one shows stones. Again, it's a post-renal AKI. The third one, it's important. You can see the kidney shows gas in it. And even on the X-ray, you can see a gas-filled black kidney. Diagnosis is pyelonephritis, emphysematous pyelonephritis, so infective cause of AKI. So we have seen urine examination helps in diagnosis, the blood picture helps in diagnosis, and ultrasound also helps in diagnosis. And sometimes, if we don't come to any conclusion after these investigations as to the cause, we do a renal biopsy, as I already said, unexplained AKI. So in an elderly patient, bone pains, hypercalcemia, and high ESR, this is what the biopsy showed. It's multiple myeloma with cast nephropathy. So sometimes it's picked up after the biopsy. This patient, atherosclerotic disease, you can see digital gangrene, and the biopsy shows cholesterol clefts. And what physician should be aware of is a rare entity, phosphate nephropathy. You can see phosphate crystals in the kidney. This patient was being treated for AKI, not improving. And finally, it turned out that he had undergone enema procedures and the biopsy showed phosphate AKI. So we have diagnosed the cause of AKI. We established AKI, we have diagnosed the cause. What next? Management. How do we manage? A 10-point agenda. And what are these 10 points? Let us see and let us revise all of them. The first one is stop the nephrotoxins, whatever list I have given you. The second important thing is fluid management. Fluid management is very important. So there is a big shift in the concept of fluid management. Initially, we used to give more and more fluids in the first 6 hours, keep on piling with fluids. Now it is restrict fluids. So just fluids, little bit for 4 to 6 hours. After that, restrict fluids is important. So it should not be too much, not be too little. Generally, we see 3 types of patients. Either they are dehydrated or hypotensive. Here we have to give fluids. It's very clear. We are doing right here. Either we have overloaded patients, we are giving diuretics. This also is right. The problem with normal volume patients who do not look overhydrated or underhydrated, what should we do for these patients? So let us understand these 3 types of patients. First one is hypotensive dehydrated patient, give fluids. maintain a mean arterial pressure of 65, and if chronic hypertensive, maintain mean arterial pressure of 80 to 85. So MAP around 65 is the dictum. And if the patient is okay looking, euvolemic, what do? Give 30 ml per kg bolus. For a 50 kg person, that would be around 1.5 liters. So give the bolus, check the urine output. Then don't keep on giving boluses and boluses. What is next? Use a bedside echo. That's the guideline. Look at the IVC collapsibility. So if the IVC is less than 2.1 centimeters and greater than 50% collapsible, you can give more fluids. And keep on reassessing with a bedside echo. This is the standard of care now. And other important thing, bedside tool is POCUS. POCUS is point of care ultrasound for the lung. Have ultrasound and echo bedside in your ICU. So POCUS, you look at the lines, the A lines and B lines. The A lines are transverse lines in the first picture, they are normal. In overloaded patients, you will have longitudinal lines. You can see in the insert, the B lines, they are abnormal. So they will help guide you in giving fluids. So this is what we do for fluid management. There are other tests also, but these are the two tests which are commonly used. And avoid overload. So once you have given fluids, you have done the test, and IVC now has become more than 2.1 centimeters, don't keep on giving fluids. Only just give 400 ml per day for insensible water losses. So this is the fluid management in AKI. Remember the chart that in the first 6 hours, you can give fluids. From 6 to 24 hours, reduce the fluids. After 36 hours, we don't give extra fluids. And after 48 hours, if the patient is overloaded, we may have to give diuretics. So this is the fluid management, which focuses more fluids in 6 hours, but after that, be restrictive. Now, which fluids? Choose crystalloids, that's normal saline, such things. Colloids only if the patient has hypoalbuminemia, hemorrhagic shock, or hepatorenal syndrome. And hydroxyethyl volume expanders should be avoided because they themselves cause AKI. So best fluid is a crystalloid. So decided. We have trials, and postgraduates should remember the names of the trials. The SAFE trial and colloid versus crystalloid crystal trial. But for the practicing physicians, it's fine to remember, give crystalloids. Next question, which crystalloid? Is normal saline okay? So there is some concept that it might cause chloride load, is acidic, and some concept of giving plasma light. But most of the studies show normal saline is good enough. Then you have given fluids, still the blood pressure is not improving. So once you are done with fluids, the next step is to go to vasopressors. We shouldn't start the vasopressors first without ensuring adequate fluid. Vasopressors try to maintain MAP more than 65 if it's not already attained with the fluid support. Norepinephrine is the first one, then vasopressin and dobutamine. The others are all out. Dopamine is not given, phenyldopam not given, renal dose dopamine not given, epinephrine not given. No. It's norepinephrine, vasopressin and dobutamine if you have a low cardiac output or hypoperfusion. Then what about diuretics? So diuretics for overloaded patients, we have to give diuretics. The dose is 1 to 1.5 milligram per kg oral furosemide, max 200. Some studies have reported 400 also. And if the urine output is improving, you can continue giving furosemide. If it does not improve, then don't keep on piling with furosemide. IV furosemide can be given. And again, you can give a bolus, 20 to 40 mg IV. And then after 2 hours, you can keep on repeating if there is increase in urine output. If there is nothing, don't keep on piling with furosemide because itself, it can cause AKI. And if you want to give infusion, that may sometimes help if bolus is not helping. So 0.1 mg per kg per hour, max 0.4 mg per kg per hour. Antibiotics. So start empiric therapy, but before you do that, give up the blood cultures. And all this should be done within 1 hour. It's called a 1 hour bundle. Empiric antibiotic is a combination of gram positive and gram negative. Generally, you can use amoxicillin, clavulanic acid or cefazolin or Vanco if MRSA plus meropenem or amikacin. In AKI, amikacin and Vanco, we keep on hold unless cultures show something specific. De-escalate after reports. If gram positive, stop the gram negative. If gram negative culture, stop the gram positive. Often we forget to do it. And empirical antibiotics should not be continued for times immemorial. Stop after 3 to 5 days. De-escalate as per culture report. This is all mentioned in ICMR guideline, free for download. And these all antibiotics are mentioned there. I'm not going to go through the list. It's there in ICMR guideline. Google, download. It's very useful. Antibiotics needing dose adjustment. So most antibiotics need dose adjustment for AKI, but azithromycin, ceftriaxone, doxy, linezolid, moxifloxacin, rifampicin do not need dose adjustment. If you need to give aminoglycosides, if the culture shows aminoglycosides, alternate day, single daily dose. Don't split the dose of aminoglycoside because peak effect is important for aminoglycoside. So alternate day peak dose, vancomycin 4 to 7 days single dose. Antifungals, avoid conventional amphotericin. You can use the others, antifungal agents, echinocandles or liposomal. Hyperkalemia, we all know we are masters in treatment. We are scared of the T wave, the sine curve, and we know what we need to give. Calcium gluconate, immediate action, insulin glucose, albuterol, furosemide, later on you can give soda bicarb as well, and K-bind, P-bind, all those things are available, can be given for later effects, and nothing works, hemodialysis. Correct the acidosis. If the patient is not overloaded, not hypertensive, you can give soda bicarb. The formula is deficit into 0.5 into body weight. So you can correct it, try correcting it, but if the patient is already overloaded, hypertensive, it's not recommended. And 1 ml of 1 is equal to 1 milliequivalent, and you prepare by adding 3 ampules to 1 liter of 5% dextrose. Anyhow, you know that. Glucose maintain between 140 to 180. This is the guideline. Don't undershoot this target. Specific treatment. If suppose you find on biopsy a glomerular disease, then you have to treat with steroids. If infection-related glomerulonephritis, supportive treatment, lupus, immunosuppression, vasculitis, immunosuppression, etheroembolism, statin, aspirin, and myeloma, chemo. So all this will be done by the nephrologist. By the time biopsy has been done, a nephrologist is in picture. Post-renal AKI, refer to urologist, they'll do stenting or stone removal, whatever. Renal replacement therapy, we know if the creatinine is high, more than 6, generally it's required. Otherwise, if creatinine is less also, but if you have AEIOU, intractable acidosis, electrolyte disturbance, inorganic poison, overload, uremic pericarditis or encephalopathy, go for dialysis. So dialysis can be done with a lower creatinine if AEIOU are present. Should we start dialysis early with a creatinine of 2 or 3? No. There are multiple trials, ELAINE, EKIKI and IDEAL ICU, which show that early dialysis, late dialysis, both are similar. So do not start very early just for reducing the creatinine of 2 or 3, not indicated. Which modality? We have PD, intermittent dialysis and CRRT, all are equal as far as the scientific expertise and efficacy is concerned. But cost-wise, PD is cheaper, hemodialysis is cheap, made free by government. CRRT is very, very expensive. CRRT used only if the patient is hemodynamically very unstable. Otherwise, PD also helps. How long to continue? Keep on measuring. If the urine output is more than 400 ml without diuretics or more than 2.3 liters per day with diuretics, stop. If hemoglobin less than 7, give blood. If platelets less than 20,000, give platelets. Nutrition, we know that once on dialysis, you have to increase the proteins, otherwise restrict the proteins. So this is the 10-point agenda which we have covered and all of you should remember. Before I end, prevention is also equally important. So what do you do? Vaccinate. Vaccinate all your people as per the guidelines, prevent infections, prevent stones. How do we prevent stones? 3 to 4 liters fluid, everyone should be taking. Cut down on your salt. That is the mantra for reducing stones. Avoid nephrotoxic drugs and correct hypotension, dehydration, working in the sun, take fluids, more fluids. And whenever contrast studies are essential, low volume contrast, isoosmolar contrast, and hydrate before and after. So water is the key to prevent AKI. But once you develop AKI, you have to restrict water. 20% AKI progresses to CKD, thus follow-up is important. Do not treat the patient and forget. Ask the patient to come after 3 months, 6 months, and 1 year. The latest thing is biomarkers. Lot of talk is there that creatinine and blood urea are able to diagnose in the later stages. What about early stages? Early stages, biomarkers. And we have multiple N-GAL, KIM, cystatin C, tubular marker, glomerular marker. They have been around for 20 years. And are we using them clinically? No. What does that mean? The greater number of biomarkers, greater the confusion, nothing is as of now in practical use. It's a research tool. Because if you have high biomarkers and normal creatinine and a normal urine output, are you going to dialyze? No. So it's a research tool as of now. Let us see, future may be something different. So ladies and gentlemen, that's the last slide. AKI is common. All of us should be aware, whatever specialty we are in, it can be pre-renal, renal or post-renal. can be asymptomatic, have a high index of suspicion in whatever patient you see, especially in admitted patient, 50% have AKI. And how will you check or identify if you don't do a creatinine? You have to do, even if the patient is asymptomatic. Urine, biochemistry, blood picture, radiology, biopsy, all step by step. Many of the times, it can be diagnosed at the level of physician, treated at the level of physician, at the level of GP, and that's how it should be. Dialysis is the domain of nephrologists, not the management of AKI. Management, I already told you the key points. Don't overload. Antibiotics as per guidelines. Correct the metabolic milieu. Dialysis for AEIOU. Specific treatment if glomerulonephritis. Focus on prevention. And in case the patient has AKI, despite all your efforts, treat and follow up. So thank you for the patient hearing. I'll be happy to take questions.
Thank you, madam, for your excellent presentation. Any question?
Thank you, Dr. Manisha, for such an extensive presentation and for a really interesting and relevant topic. I am Dr. Sharad Joshi. I am basically a chess specialist, but I would like to add one point to your presentation that very recently 2 of the cases was reported from Maharashtra, where 2 sisters from one family were actually using a fairness cream. And within 2 months, they actually had improvement in their skin shades. But unfortunately, they developed the kidney injury. It was found out that the cream, the fairness cream they were using, had almost 10 times the amount of mercury, which actually inhibits the growth of melanocytes. But simultaneously, it actually damaged their kidney. So we know that we are dark-skinned people, and people have somehow a social bias towards the fair skin. But this cream led to their kidney failure. So this is one of the very important topics. Right.
So thank you for adding that. So as I said, in India, we are particularly prone because of Ayurvedic. I'm not saying Ayurveda is bad, but unlicensed. And by quacks and all, it's not recommended. Ayurvedic, herbal. So in fact, sir, your point is very relevant. And in fact, that should be a separate session. Special causes of AKI in Indians. That would be a 1-hour lecture. So I cannot escape by just saying that Ayurveda indigenous. That's what I did in my lecture because I was allotted 20 minutes. But otherwise, it's a huge topic. And day in and day out, we are so scared. In our wards, 30% of patients are unexplained AKI with lots of people being on powders and papers. And when we ask them to get the paper, we tried analyzing it. They are so true to their primary person who's treating them. They don't give us the drugs for analysis either. So we are Indian physicians, we have a lot to tackle, which our Western counterparts don't.
For hemodialysis, which is more important, whether serum creatinine or eGFR? And what should be the level of the creatinine if needed?
Yeah, so again, a very good and practical question. So as I said in my presentation, generally cutoff of 6 is used. That's a general guideline. But if the creatinine is 4, the patient doesn't have any urine output, and you have AEIOU, that is acidosis, electrolyte disturbance, potassium is going high despite your efforts, bicarbonate is very low, patient is in encephalopathy, creatinine 4, don't wait for the creatinine to go to 6, you have to dialyze immediately. And regarding the question of eGFR is important or creatinine, the eGFR completely depends on the value of creatinine. And in AKI, unlike in CKD, what we do is, all AKI, we presume that the eGFR is less than 10, right? So for AKI, the working GFR is less than 10. For CKD, we calculate the GFR as per the creatinine value. So in AKI, presume that the patient doesn't have a GFR more than 10. So generally less than 10. That's a dictum. Because why this difference? In AKI, the GFR will keep on changing daily. Daily, you will have a creatinine, 1 in the morning, some in the afternoon, some in the evening. You cannot have changing GFR, so we presume that the GFR is 10. So I hope that answers your question.
No, in a relatively, the patient is asymptomatic, but creatinine is increasing.
So then go by GFR. GFR is much more important because creatinine can be influenced by your body weight, obesity, gender, so many things. But eGFR is not influenced by all the factors, so go by eGFR. So relatively in community where the creatinine is a bit high and all that, Creatinine 1.2 may be normal for an elderly person, but 1.2 for a person who is around 18 years or maybe 13 years may already be high. Always go for GFR when you are checking creatinine for community people who are asymptomatic. Do not rely on creatinine.
Thank you, ma'am. Sorry, we are running late. We will end this topic here.
Thank you.
The next topic, osteoarthritis and its reality in a physician's cup of tea. I will invite Anil Samaria.
I think Dr. Sanjay Agarwal sir wants to leave. So you also have a flight. Okay, everybody has a flight, it seems. So I'll just ask my co-chairman to please honor Dr. Sanjay Agarwal. We'll do it fast. Everybody has a flight to catch. Congratulations, sir. I've heard you before also, and you were fantastic. Yeah.
Good afternoon, everyone. First of all, I thank you to organizing team to inviting me as a speaker to speak on the osteoarthritis. It is really a physician cup of tea. Osteoarthritis is the most common arthritis that is prevalent in the elderly people, especially in the patients having the acute injury patients, or also that endangers the joints. These are the commonly prevalent in the elderly groups. Osteoarthritis is a joint failure. It means there is a failure of a joint. It is a disease that involves the whole joint, not a particular segment of the joint. The whole joint is involved in osteoarthritis. In the cartoon showing that left side is a normal knee, osteoarthritis on the right side. They show the very damaged part in the bone and cartilage fragments are there, cartilage breaking down, erode cartilage is there, joint fluid and with the low concentration of hyaluronic acid. All these are seen in the osteoarthritic joint. So osteoarthritis is a degenerative disease of synovial joints characterized by focal loss of cartilage with proliferation of new bones and remodeling of joint contour. That osteoarthritis involves not only the articular cartilage, but the entire joint organ, including the synovial fluids, synovium, subcontinuous bones. The cartoon showing the protectors of the synovial joints. The most important part is a joint capsule and synovial lining, articular cartilage, synovial cavity, all has a protective mechanism, and the tendon, muscles that overlies the joint also are the important part of the protectors. If any insult to these protectors leads to osteoarthritis. Now come to the epidemiology is the weight-bearing joints are most commonly affected, especially the knee joints and hip joints. When we are reaching the more than 70 years of the age, 80% have the asymptomatic radiographic presentation. Only the 25 to 30% have the symptoms of osteoarthritis. More common in the woman. The familial tendency is there. Their distribution of the osteoarthritis joints are commonly in the cervical spine, distal and proximal interphalangeal joints, first carbo-metacarpal joints, lower lumbar spines, hip joint, knee joint, and first metatarsophalangeal joints. These are the commonly distributed disease that are involved. The spares are the wrist, ankle joints are the spare, and elbow joint is spared from the osteoarthritis. Now, what are the etiology? Primary etiology, where there is no obvious cause, there is a common form of the osteoarthritis. The secondary, when the degenerative joint changes occur in the response to recognizable local and systemic factors. Especially these are the secondary causes of the osteoarthritis are developmental, like his dysplasias. Endocrine causes are the acromegaly, traumatic like the interarticular fracture, occupational meniscectomy. The inflammatory causes are rheumatoid arthritis, gout, septic arthritis, metabolic causes like the alkaptonuria, Wilson's disease, aseptic necrosis of the joints, especially the corticosteroid use after SLE and sickle cell disease. Neuropathies like the syringomyelia and diabetes mellitus leads to Charcot's joint, leads to osteoarthritis. The miscellaneous causes of Paget disease and Gaucher disease also causes the secondary osteoarthritis. Now, what are the risk factors? They are the susceptible joints having the hereditary is most of the common. It can run in the families. Genetics are also important. There is one gene is affected that can cause the osteoarthritis in the genetically susceptible persons. Their obesity is the most common risk factor because obesity leads to overload over the joint, especially hips and knee joints, leads to osteoarthritis. High bone mineral density is also another risk factor for the development of osteoarthritis. No doubt, aging is the most common prevalent cause of osteoarthritis. Mechanical factors are trauma, joint shape, malalignment. More of the uses in occupational, recreational uses. Sorry. Now come to the pathogenesis of osteoarthritis. It is a progressive destruction of articular cartilage with accompanying periarticular bone response that leads to which leads to chondral bone, subchondral bone, which become sclerotic with increased blood vascularity and cyst formation. This leads to the pathogenesis of the all osteoarthritis. Like seen in the picture, there is the thickened capsule, cyst formation, sclerosis in subchondral bones, the fibrillated cartilage, osteophyte flipping, synovial hypertrophy, and altered contour of the bone is an important part in pathogenesis. Now come to the clinical feature. What is the clinical feature? The pain is the most and commonest symptom of the osteoarthritis. This is activity dependent and weight bearing related. It is relieved by the rest and variable over the time. Sometimes relieved by after the rest and come again, and chronic pain can appear. There is a capsular thickening, buckling, and by the osteophytes. These are the other clinical feature. The clinical finding of the nodal or generalized osteoarthritis. It is commonly present in the woman at the age of 40 to 50 years of the age. Most common symptoms are pain and swelling in the small joint, especially hands. That leads to the swelling of the Bouchard's nodes are involved in when the proximal interphalangeal joints are involved. The involvement of first carbo-metacarpal joint is also common in this type of nodal osteoarthritis, and there is a predisposition to osteoarthritis at the joint other than the hand joints. Now, clinical findings in the knee osteoarthritis. There is a target patellofemoral and medial-tibulofemoral compartment of knee. The pain is localized to anterior and medial aspect of the knee and upper tibia. The jerky gait is there because of the pain. There is a varus or valgus deformities are seen commonly. The joint line, when go for the physical examination, there is a joint line tenderness or periarticular tenderness must be ruled out to the other bursitis and other joint involvement. There is weakness and wasting of the quadriceps muscles, restricted extension and flexion motion of the knee joints. Bony swelling around the joints are commonly seen. When go for the hip osteoarthritis, clinical findings are target mostly superior aspect and less commonly medial aspect of the joint. Pain is maximally deep in the groin area. If it is on the lateral side, must rule out the trochanteric bursitis. Their patient is having that antalgic gait. The patient is trying to avoid the weight over the affected joints. Their weakness and wasting of the muscles, especially quadriceps and gluteal muscles. The pain and restricted internal rotation and flexion. Now come to the differential diagnosis. We must differentiate from the inflammatory osteoarthritis from the inflammatory joint involvement. These are the rheumatoid arthritis, gout. This commonly causes the joint pain. This is a table showing the difference between the osteoarthritis, rheumatoid arthritis, and gout. The systemic symptoms are not present in the osteoarthritis, while in the rheumatoid arthritis and gout, there is systemic features are there. The morning stiffness is last for less than 30 minutes in the osteoarthritis, that is Gale phenomena. It is also appear in the daytime, while the rheumatoid arthritis having the morning stiffness more than 1 hour. In the gout, there is no stiffness, only the localized swelling in the joint. The duration of the nodules that has appear in the burden nodes and Bouchard's nodes common in the osteoarthritis, while in the rheumatoid arthritis there is a Bouchard nodes only. No involvement of the distal interphalangeal joint in RA. There is a involvement of the great toe is common in gout. The pain with the movement increase with the pain in the osteoarthritis, while rheumatoid arthritic patient, the pain is released when they are moving here and there. The movement increase in also in the gout. The age of onset is more than 50 years of the age in osteoarthritis, while the rheumatoid arthritis patients are aged between 20 to 40 years. The gout can presented after the age of 30 to 35, especially in male. The lab findings are normal in the osteoarthritis, while the rheumatoid arthritic patient having the RA, anti-CCP are positive, C-reactive and CESR are raised. The joint fluid examination showing the uric acid crystals in the gout. How to diagnose osteoarthritis? Osteoarthritis diagnosed by clinically only. Take a detailed history and physical examination, give the answer that it is suffering from the osteoarthritis. It is typically diagnosed on the basis of clinical and radiographic evidence. Imaging finding correlate poorly with the presence and severity of pain. No specific clinical laboratory abnormalities that are diagnostically associated with the osteoarthritis. These are the few pictures that showing the osteoarthritis in the knee. The joint space is narrowing. The subchondral sclerosis are there and the excess formation in the knee joints. There is a marginal osteoid formation in the knee joints. In this excess showing the subchondral cyst, its formation is there. This is also a feature of the osteoarthritis. This is a picture of the hip joint. AP radiograph of the hip reveals a severe superior migration of the femoral head with subchondral sclerosis, prominent osteophyte formation, large egg-like structure. This is an agar cyst in the superior acetabulum. The mild flattening of the superior aspect of the femoral head is there. The CT scan, MRI, and the USG and bone marrow scan are not giving the not used for the diagnosis. These are used for only for the define the more aggressive nature of the osteoarthritis. The CT scanning may be used in the diagnosis of malalignment of the patellofemoral joints or malalignment of the foot and ankle joints. MRI not useful, but useful only when the surgical repair is required. MRI can directly visualize the articular cartilage and other joint tissues like the meniscus, tendon, muscles, and effusions. USG is not routinely advisable to the osteoarthritic patient. Only role in the routine clinical assessment of the patient is not osteoarthritis, a tool for monitoring the cartilage degeneration. It can be used for guided injection of joint, not easily assessed without imagings. Sorry, bone scanning are required in the early diagnosis of osteoarthritis of the hands, but it is not routinely advisable. Can help to differentiate osteoarthritis from the osteomyelitis, bone metastasis, metabolic bone diseases. Arthrocentesis. The arthrocentesis show the presence of non-inflammatory joint fluid, WBC less than 1000 per microliter, help to distinguish osteoarthritis from the other causes of joint pain. The negative gram staining and cultures, as well as the absence of crystals when fluid is viewed under the polarized microscope in the osteoarthritic examination of the fluid. The investigation show the normal, full blood count are normal, ESR and CRP normal, rheumatoid factor negative. The treatment goal is, treatment of the osteoarthritis goals are to alleviate the pain and minimize the loss of physical function that is very common in the osteoarthritic patients. by the means of non-pharmacological therapy, pharmacological therapy, and surgical interventions. The non-pharmacological therapy are by the education of the patient, full explanation of the condition via the patient education, properly position and support your neck, back while the sitting and sleeping, adjust the furniture like the raising the chair and toilet seats, avoid the repeated motion of the joint, especially the frequent bending, use heat and cold fomentation, lose weight if you are overweight or obese, which can reduce the pain and slow the progression of osteoarthritis, exercise each day and build the confidence in the patients. The physical management modalities to avoiding the painful activities to overload the joints, the improving the strength and conditioning of the muscle that bridge the joint to optimize their function, unloading the joint either by redistributing load within the joint using the brace or a splint, or by unloading the joint during the weight bearing with a cane and crutch. The non-pharmacological interventions are also useful in physical therapy by the physiotherapist, muscle strengthening training in the, especially in the quadriceps, strengthening for the knee joints. Occupational therapy is required when the patient are indulged in the some business or work to increase the osteoarthritic joint damage. The non-pharmacological therapy like exercise is a very important part. Aerobic exercise, aerobic conditioning of the body by using the aerobics, water activity, and there is a Chinese exercises also available that is causes the aerobic conditioning of the joints. Muscle strengthening exercises are important. Reduce the adverse mechanical factors by reducing the weight, pacing of the activities, use appropriate footwear, not to use heel and other type of shoes. Now come to the pharmacotherapy of osteoarthritis. Osteoarthritis is a commonly presented with the pain. In the initial stage, there only when we are using the joint or when we are up stairs and down stairs, when we are running, this introduce the pain. This can be reduced by avoiding these kind of exercise and running and activities. In the initial stages, the pharmacotherapy use the topical non-steroidal NSAIDs. Capsaicin can be used topically in the initial stage, and diclofenac sodium 1 gram, 4 gram applied to the knee joint 4 times a day can reduce inflammation and pain in the joints. One patient is not improving with this, go for the paracetamol in the initial stages, but it have the limited efficacy. Only the 1 gram 3 to 4 times can be used. After that, we can go for the NSAID. NSAIDs give the very good results, quick relief of the pain. Patient happy with the NSAIDs, but there is a lots of problem with the chronic use of NSAIDs like the GI side effects, increasing chances of MI and strokes. These are the few side effects that leads to the chronic use of NSAID can cause the edema, nephrotic, as said by the Dr. Sahai. The chances of AKI is also there. So not to use the NSAIDs for chronically. So we can switch over to opioids derivatives like the tramadol and the dihydrocodeine. These are less efficacious than the oral NSAIDs. If all are fail, then we go for if there is a inflammation, pain is severe, then we can use the intra-articular corticoid injection, giving the 3 to 5 weekly. It gives the relief of pain and symptom for 3 to 5 months or longer. Then some patients get not relief, some patients get more relief for the year also. One also injection can be used in to pain relief and centrally in osteoarthritis is the injection of hyaluronic acid injection for 3 to 5 weeks, give pain relief for several months. The glucosamine, chondroitin and glucosamine and chondroitin sulfate alone show the medium-term benefit with no long-term benefit for the pain and function. The mesenchymal stem cell therapy continue to be promising in investigational approach to knee osteoarthritis. However, the improvement reported with the stem cell therapy is modest. A placebo effect remains possible, and the quality of supporting evidence has been questioned. The recent guidelines show that the against use of the glucosamine and chondroitin for the osteoarthritis because of the placebo effect is there, no pain relief in these patients. The duloxetine, the selective serotonin non-epinephrine reuptake inhibitor, duloxetine has been found to be effective in treating osteoarthritic pain when there is a generalized pain, not isolated knee pain. Investigational agent monoclonal antibody that inhibit the nerve growth factor such as tinizumab is under the phase 3 trial, can be used subcutaneously, give the placebo effect. It is still under the trial. After the treating with the stage 1 and 2, and when the patient having the severe osteoarthritic pain, not disabling the physical function, we can go for the surgical treatment. Should be considered for those who do not give the response to pharmacotherapy. We can go for the arthroscopy, osteotomy, joint replacement, and total joint replacement. Arthroscopy is not giving the much relief. Also repair the meniscal injury and ligamentous injury. The osteotomy is very good results in varus and valgus deformity. Here is a picture showing the wedge osteotomy. A wedge of the lateral tibia is removed, taking weight away from the injured medial side. This procedure is allowed the lateral side to bear the more weight, and this is procedure reduces the severity of the varus alignment. As a bow like picture can be improved. Another picture showing the total replacement of the, there is a metallic replacement for the head and neck femur. There is a plastic and metallic replacement for the acetabulum. It's an artificial hip joint in the when there is a patient is disabling, unable to move, or there is severe pain not relieved by the medications. Take home message: osteoarthritis is the most common type of arthritis. High prevalence in the elderly population, diagnosed by clinical history and physical examination. There is with the no biochemical findings, easily diagnosed by the plain radiograph of affected joints. Treatment mostly by the patient education, physiotherapy, non-pharmacological measures. Pharmacology management by the painkillers only. A referral to the orthopedic surgeon may be necessary if the osteoarthritis fail to respond to a medical management plan. Thank you.
Thank you, sir, for your excellent presentation. Any question from the floor? Okay.
My collagen powder is not responding. There is no recommendation by any book and literature show only the placebo effect. They are similar to placebo. If they don't relieve the pain, they don't regenerate. On the chondrocyte replacement therapy is there, but there is also the fibrocartilaginous formation, not the hyaline cartilage formation. So giving the chondrocyte transplantation in the early stage, but we have to choose who will go for the surgery for the chondrocyte transplantation for the early osteoarthritis. So whenever we have to diagnose severe osteoarthritis, chondrocyte transplantation is not required in that stage because of the more severe pain and disability is there.
So thank you, Dr. Samaria, for the excellent presentation on the diagnosis and management. What I wanted to ask you is there any role for prevention?
There is definitely prevention is a very important part. How
do we do that?
Prevention is a better part. Every disease has a prevention. It is better than the cure. If we have daily exercise, aerobics, water activity, especially in the age group of 50, after the 50, because osteoarthritis develop after the age of 50. Before 40, there is no changes in the bone part, cartilages, except in the accidental patients. There is an injury to any part of the protector mechanism, leads to further in the osteoarthritis. So preventive is a measurement is a better part.
Sir, we'll have the questions again. I'm sorry, we are running out of time.
Oxazepam is also in the investigational part. There is but it is recommended. There is
there is good result with that. So I'm asking because you are talking on this, you might have gone through so many literature. So I'm asking your experience.
But there is no literature showing the effective part. Only the placebo effect. Most of the drugs. These are hit and trial. Most of the drugs are coming with hit and trial therapy because all the joint are damaged, not recovered by any drug. The literature said in the Harrison book, there is no drugs can recover all these recovery. Only the surgery is important part in the last. In the early stages can be fruitful, otherwise this is not useful.
Thank you so much, Dr. Samaria, for excellent deliverance. I ask the organizers to please honor Dr. Samaria and Dr. Manisha Sahai. Dr. Manisha Sahai, please.
Dr. Manisha, ma'am, please join for felicitation.
Okay, it was a excellent session. So now I would like to invite the next chairperson for the next session. I would like to invite Professor Dr. Gandharva Rai, sir. Please come to the dais, and Dr. Ravindra Kisku, Dr. Diptiranjan Darji to chair the session.
So this is almost towards the end part of the conference, and we are having a topic, managing chronic pain. You know that pain is the very important symptom in clinical medicine, which all specialties of medical science or the doctors come across. It is a very common symptom, and every day in our practice we come with patients who complain of pain. The pain may be a psychological pain or a somatic pain. It may be a visceral pain, or it may be a pain from the superficial structures or from the musculoskeletal organs. So it is a very common symptom, but difficult to manage. So for this, we have to do certain investigations, and we have to proceed for a diagnosis. And for this management of pain, we are having the speaker Anupam De. He is a professor of medicine from AIIMS Bhubaneswar. He is a very dynamic physician and academically interested, and he is regularly giving speech in various conferences. So he is invited to this forum for speaking on this managing chronic pain. Dr. De, please proceed on.
Thank you, sir, for your kind words of introduction. First, I would like to extend my thanks to organizing committee, especially Professor Jayant Panda sir and Professor Anil Vimani sir, for giving me this opportunity to stand before you. So today I'll be speaking on an important topic which we all face across our clinical work, which is managing chronic pain. So this is my outline of today's talk. I'll be speaking a bit on history introduction, and then I'll touch pathophysiology of chronic pain in brief. I'll list out few etiology and important factors affecting chronic pain. Then I'll tell a bit on diagnosis and evaluation, and then I'll go on to management, the role of opioids and non-opioids, and use in special conditions and digital methods that we now have for these conditions. So going to the history, going back down the years, where we defined pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage. This is how pain is defined. And an anesthesiologist by the name John Bonica was the one who is considered as the father of modern pain management. And WHO has worked on this, and WHO was the organization which included opioids for first time as a recognized treatment of pain as an universal right. So the magnitude of pain is chronic pain is quite high, with 50 million adults suffering from chronic pain, and it's one of the most underestimated healthcare problems in the world today. Before somebody goes to a chronic pain, then is a phase of persistent pain with changes in peripheral and central nervous systems. And so when we come to chronic pain, it is defined as pain that persists beyond the normal time expected for tissue healing. So that's usually more than 3 months. So the world population, around 30% at some time, will have this problem, and the prevalence varies according to different factors, which I'll tell later on. Now, this cartoon will show the various interplay of factors which affect chronic pain. And as we see here, biological, social, and psychological factors are involved in chronic pain. So it's not a very easy issue, it's actually a very complex issue, which involves various drug effects, age, genetic factors, comorbidities, severity of disease, social support, economic factors, social environment, the mood, cognition, coping, stress. So it's a complex interplay of factors which defines chronic pain, and thus the treatment is also not so easy. Now, pain is always a protective mechanism. So function of pain is actually protecting body and promoting healing. So there are some changes that occur in the central and peripheral nervous system that lead to this chronic pain. And thus, the treatment is often multimodality, as I told, with multidisciplinary approach in this situation. Acute pain usually resolves, whereas a chronic pain, when acute changes to chronic, that is called as pain chronification, and there are many factors which are involved, and we do not know exactly why this chronification occurs. So this, the pathophysiology is again different for different types of pain, like nociceptive or neuropathic pain. The causes are different. The pathophysiology is different. So this slide, if you can see here, so it's not showing up. So the important part of this is CNS and the peripheral nervous system. So right from the top, we can see the cortex. There are transmitters in the cortex which are involved, and thus there are the targeted drugs that we give. And then we come down to the spinal cord, where the dorsal root ganglion through which the nerve enters. At that junction, you again have the one which is depicted on the right upper round figure. You can see the dorsal root ganglion and the synapse. In that case also alpha receptors and 5-HT receptors and NMDA receptors, calcium, sodium. This is a complex interplay of factors, and thus these are the areas where the drugs act, and that is how we treat. So this is in the spinal cord. Then we come down, we can see the peripheral nerve, the lowest part of this figure, the sensory nerve endings. Now these are again targets for a group of drugs which affect the transmitters there, and there also we can see TRPV1 receptor, we see sodium receptors, we see inflammatory substance, and mast cells, neutrophils, macrophages, they act at the peripheral level, and drugs are targeted to that area to take care of the pain. So this is a beautiful article from the NEJM, and I have subsequent slides from NEJM on this article only, wherein the drugs mentioned here are the drugs. So this is the gamut of drugs used in the chronic pain syndromes. They are described in detail in my later slides. So various pain is a complex interplay, and there are many factors involved. So women usually have they're more likely to have chronic pain. So as you can see, this survey, the National Health Interview Survey of 2019, the green one is the number of females reporting chronic pain. So that is more than that of males. And with age, the chronic pain also increases. So there's another graph like that, which I have not put in here. The age slab, in a higher age slab, the pain is more. Lower income, pain is more. Mental illness, pain is more. So these are various factors which can involve. Now going across to various causes of pain, or rather various types of pain that we can have. Now we have a neuropathic pain which is very common in our practice. It can be peripheral neuropathic pain, for example, diabetic neuropathy, or it can be central neuropathic pain like a CVA, sequelae, or a cellular stroke sequelae is a central pain. Then we have a nociceptive pain, which is because of an injury, burn, thermal, sprain, whatever. That is a nociceptive pain. Then we can have musculoskeletal pain like backache, myofascial pain, which is again very common. There are inflammatory pain, which forms an important part of our practice, the rheumatological disorders, autoimmune diseases, infection, psychogenic pain, and mechanical pain, which is like malignancies. So there are many causes, and that is where we need to find out which is the cause and treat. Now this is classification given by International Association of Study of Pain, in collaboration with World Health Organization and the 11th revision. So it classifies pain according to the cause: primary, neuropathic, post-surgical, post-traumatic, cancer pain, visceral pain, musculoskeletal pain. It also classifies on the basis of temporal progression: acute pain, chronic pain, ongoing pain, intermittent pain. It also classifies on the type of assessment that it details the type of assessment you need, like pain intensity or interference or coexisting conditions, psychological conditions, social functioning. So WHO stresses, or the pain classification stresses, that these questions should be mandatorily asked for assessment of chronic pain. So the evaluation is a bit complex, I can say, or I can say time consuming. So how do you know that patient has a chronic pain? So first, there has to be some pain-related symptoms: widespread pain and pain more than 3 months, ineffective, no treatment is effective, and patient already has a chronic condition. Then there are some functional problems patient faces: poor sleep, intrusive fatigue, or mood disturbance, or hypersensitivity, poor concentration. These are added factors. Then the patient would have numerous consults, numerous comorbid illness, feeling overwhelmed, and changing physicians. All these are questions that are part of evaluation and to know how to suspect the pain. So questions like whether it's impacting relationships, or patient is depressed, or sleep, or decrease in activities of daily living, they are all questions that we need to ask, and have a detailed neurological assessment is also very important, since I've already shown the CNS and PNS involvement here. Then evaluation has many scales. So there are hundreds of scales, and if I start saying that, it will be more than an hour. So I've tried to just keep 2 or 3 things here. So there are many scales. You can see a McGill pain questionnaire, wherein the location of pain, previous medication use, past experience, all these are asked. Then comorbid conditions need to be noted down. We have Minnesota multiphasic personality inventory. We have Beck's depression scale. There are a lot of scales available, so I have chosen to exclude these things in the interest of time. And the easiest one, we can record pain in this visual analog scale, which can be more easier in our day-to-day use. So now I move on to the management aspect of this condition. So the first is a biopsychological management. Now, the pain has to be assessed, and its impact on the person's functioning has to be assessed, and risk factors has to be assessed. Patient has to be explained about his condition and realistic expectation. You cannot expect the pain to just come down like an acute pain. It's not like that. Then other professionals have to be included: physiotherapists, psychologists, sorry. Special investigations need to be done. Current medications need to be rationalized, and opioids have to be tapered. Physical activity is encouraged, healthy nutrition is encouraged, and cognitive and mind-body therapies, relaxation encouraged. So coming to the medications, it's a vast market. So US is the largest market by country. You see millions and dollars here. And China is the fastest growing market, so we can know how much drugs is going into this condition. Okay, this now is the same NHM article which I had quoted that cartoon from. Now here, the various drugs which have been used and proven to be useful in the chronic pain management. So if I come to one by one drug now here, first paracetamol, the commonest drug that is used. So the upward or higher limit of the drug is 4 grams per day. Which should not cross that. It's usually 650 milligrams, 4 or 6 hourly. Then aspirin is used in rheumatological conditions, in chronic inflammatory rheumatic diseases. NSAIDs, a very commonly used drug. Amitriptyline at the dosage 25 to 150 milligrams, and maximum single dose can be 75 milligram. Duloxetine, gabapentin, pregabalin, commonly used drugs in our day-to-day use. Duloxetine 60 to 120 milligram orally, gabapentin 900 to 3600, and pregabalin upper limit is 600 milligrams per day. And then are these patches. I'll come to it a bit later on. These are the recommendations from various societies, recommendations for nociceptive pain and recommendations for neuropathic pain. These are the 2 main categories of chronic pain. So when it's a nociceptive pain is a nociceptive stimulus like an injury, and neuropathic pain is what because of nerve CNS and PNS that I've told. So the various guidelines have made a stepwise approach to treatment. So step 1 through step 6. The Scottish guidelines, as you see, as IGN, paracetamol, NSAIDs, first step in treatment. And then upwards, when they are not working with these drugs, then go on to opioids or topical NSAIDs or stronger opioids. So in the same way, the other guidelines also more or less confirm to it paracetamol or NSAIDs in first step management of nociceptive pain. Now when it comes to neuropathic pain, the first line of management is either amitriptyline, gabapentin, tricyclic antidepressants, pregabalin, almost same across various guidelines. And then the last, when you go higher up, step 3 can be some anticonvulsant drugs, and even when you go more step, there can be some low dose opioids also. Some people are recommending they can give low dose opioids in neuropathic pain too. So the treatment is in a stepwise fashion and tailor-made. First line would be acetaminophen and NSAIDs for this nociceptive pain, and the recommendation is to try different agents. Just as in a rheumatological disorder, we try different drugs, different NSAIDs, switch NSAIDs before we label them as ineffective or failure. So that should be done. Now opioids are second line, and opioids are for severe persistent pain or neuropathic pain secondary to malignancies. So buprenorphine is a better choice, better alternative for patients who have a higher dose of morphine equivalents. And beyond 12 weeks, opioids have not been shown to effectively relieve pain or improve function. So opioid is also a short-term therapy, it's not a long-term therapy. Now, opioids are contraindicated in respiratory insufficiency or use of CNS drugs, or children, or breastfeeding, or severe CNS compromise, or pulmonary diseases. They are contraindicated in these conditions. And tramadol, the one that we commonly use, is contraindicated in epilepsy and MAO inhibitor concomitant therapy. Okay, so this is an article in Journal of Pain. It clearly shows alarming increase in the number of opioids being used. The last line you can see alarming estimates prevalence of opioids. So despite this second line, it is overused. Is it effective? British Journal Pharmacology, meta-analysis, opioids are inappropriate and multimodal therapy is required. So you cannot go beyond 12 weeks. You don't expect it to continue giving benefit. Okay, now each drug, already detailed this. We can use venlafaxine, nortriptyline, in addition to the ones that are proven to be best to be used. And there are psychological therapies. There are complementary and alternative medication therapies like cognitive behavioral therapy with sessions of 12 weeks, or acupuncture therapy to 6 to 12 weekly sessions. These are also but many of these do not have approval, as you see in the right hand corner, not subject to FDA approval. So they are used, but many of them do not have approval. There are some peripheral procedures like injections, trigger point injections with lidocaine or corticosteroids, or intraarticular injection that we use in our practice for arthritis. Corticosteroids we commonly use. Even hyaluronate is given inside joints for osteoarthritis as a viscoelastic substance. These are other methods which can be used. Now, spinal procedures are again the procedures which can be used when there is no relief. So like epidural steroid injections with corticosteroid or local anesthetic can be given, or nerve blocks with bupivacaine, lignocaine can be given. We also have radiofrequency denervation, and we also have spinal cord stimulation techniques which can be used for relieving pain. So complementary alternative medications, acupuncture, some vitamins, yoga, music, biofeedback. Spinal manipulations use high velocity, low amplitude to a joint that exhibits somatic dysfunction, and dry needling are some kind of peripheral procedures which have also been used. Okay, now for non-opioid, the last two lines, topical NSAIDs are for acute. They are not for chronic usually. And botulinum toxin has been used for post-herpetic neuralgia. These are some special situations where we can use. Now, as I told, these are the topical available options: capsaicin, lidocaine, pump sprays, clonidine patch, alpha lipoic acid patch is quite new. These are also used to manage neuropathic pain. So this is a list of various non-pharmacological methods: heat, cold therapy, CBT, relaxation, biofeedback. I have told this, I'll be skipping this in interest of time. Special situations, geriatrics, paracetamol is a drug of choice, 4 grams dose, we should not exceed that, and NSAIDs is second, opioids are for moderate, severe, never first line, they are later. Now, how do drugs affect change with renal failure? So this figure shows that drug dosage modification would be required. Paracetamol not used with eGFR of less than 10 ml per minute. The common use tramadol is we usually increase the dosing to 12 hours in case of renal failure. And the other commonly used group, pregabalin and gabapentin, you see when the eGFR falls somewhere below 70 or 30, we usually go for a dose reduction. So there are some things that we have to keep in mind when we give these chronic drugs to patients. Now for hypertension, duloxetine, muscle relaxants, gabapentin, NSAIDs, they increase blood pressure. So we have to be careful for our blood pressure evaluation, and baclofen can also decrease the blood pressure, which is sometimes given, and opioids also decrease blood pressure. Now, CV toxicity, cardiovascular, some drugs change the QT interval, heart rate, amitriptyline should be very careful in using in patients, and opioids can cause bradycardia, whereas amitriptyline can cause tachycardia, so we should be careful for that. And GI toxicity, needless to say, everybody knows the toxicities with NSAIDs. The last part of my lecture is the right-hand side of this cartoon, which shows the virtual patient engagement techniques, which is now order of the day after COVID, tele-rehabilitation, where communication is used for the patient and to help in management. That remote patient monitoring using cloud computing, smartphones, apps, sensors to help patient communicate to doctor and manage the pain and staying at home. Then chatbots are also available to help the patient make informed decisions about treatment. AI is coming also into patient management by collecting various data, respiratory rate, oxygen levels, pulse rate, and giving some ideas and treatment. And there's something called as immersive technology medicine, where a virtual reality headset can be used through a sequence of CBTs to help the patient in chronic pain management. So these are the next the future of this pain management. So to conclude, chronic pain is an important cause of morbidity and multiple factors play a role in causation. Our approach should be holistic and the treatment is multimodal and many people play a role in the treatment. What is important is judicious use of drugs and careful selection of drugs so that it does not harm the patient in long term. Thank you very much for your patient hearing.
Thank you, Professor Dev, for your excellent presentation of a complex situation in clinical medicine, and you have tried your level best to simplify it as far as possible. Now the subject is open for discussion. So any question on chronic pain and its management, any question? So I can ask one question, though it is a old question, but I can ask you now. That if a patient is having anginal pain, nowadays the morphine, which was the cornerstone in the treatment of anginal pain, is not available. The pethidinil is also not available. So how will you treat? If a patient has come to the OPD or casualty with anginal pain, what painkiller you will give?
So if it's an angina, you are right that morphine is not available now. So we'll stick with our standard way of using nitrates and beta blockers.
Medicine, you have to tackle it immediately.
So that is what we are doing. We are using beta blockers, we are using nitrates, oxygen
These are the
therapy.
things that are, but immediate relief of pain.
I think sublingual nitroglycerin.
Tramadol can
Yes, I don't. Tramadol is not exactly, cannot be recommended as a line of management of the angina.
But when nothing is available, you have to take that. Because so many other drugs are almost, they are restricted.
So I think we should first go for the standard line with sublingual nitroglycerin or intravenous or beta blockers or nicorandil. So the ones that we can use.
Yes.
Of course, I don't know. Tramadol would not be recommended for according to RIBI protocols. But yes.
Okay. Thank you. Any other question?
Sir, pain of? So actually migraine is entirely a new classification of pain. So we do have a lot of medications, and of course NSAIDs are one which are used in pain management, and we also have 5-HT drugs, preventive medications. So yes, the list of drugs for migraine is quite big. We do have drugs, and I think that's entirely a different subject and topic under the chronic pain management. Yes, correct, sir. I could not take up for because of 20 minutes. I cannot cross. Itself is a big topic.
Thank you, sir. Thank you, sir, for your excellent talk. So we'll move to the next topic. That is, I would like to invite Dr. Sarat Joshi. Kindly come to the dais and deliver your talk. The topic is mimics of pneumonia. Welcome you, sir.
Good morning, House. And at the outset, I would like to thank ACP India and Dr. Anuj Maheshwari and Dr. J.N. Panda for inviting me here as a speaker. My topic is very, very interesting. I think everybody in this house has been treating pneumonia. So what is new about pneumonia? What are the conditions where pneumonia actually can fool us? When it looks like pneumonia, but it is not actually pneumonia, and there are other sinister causes behind pneumonia. So important thing is that looks can be deceptive. From there, it might look like a bird sitting on a branch of a tree, but in fact, it is a flower which is labeled as Magnolia liliflora. So looks can be deceptive. Anything which looks clinically as pneumonia and on radiology, it looks like pneumonia or consolidation, is not necessarily going to be a pneumonia. So I'll come back to this question later on at the end of my talk, where this is a middle-aged female with rheumatoid arthritis. She is hypoxic and she has got bilateral GGO or ground glass opacities in the lung. So it looks like acute onset viral pneumonia in a patient who is on DMRDs or steroids for rheumatoid arthritis. But what actually it is will be revealed in the end of the topic. So why pneumonia is a trouble? Because the symptoms are non-specific. So cough, fever, and breathlessness with chest pain can be in any of the disease. It can be there in tuberculosis. It can be there in pulmonary embolism. It can be there in pulmonary empyema. So symptoms are non-specific. Then radiology is totally non-specific. Everything from pneumonia to vasculitis to lung cancer will look like gray in a black, white, and gray scale of the radiology or imaging. And there are multiple co-founding factors. So these are actually the extensive list of mimics of pneumonia. On one side, we have infective causes of pneumonia. On the other side, we have non-infective causes. And just to enumerate, in a country like India, where tuberculosis is endemic, and a patient comes with a fever, cough, breathlessness of 10 days or 15 days, maybe it is not community-acquired pneumonia, it can be tuberculosis. All right? We have fungal pneumonias, we have histoplasmosis, cryptococcosis, allergic bronchopulmonary aspergillosis. In a patient of asthma who has been using betnesol tablets since 20 years, it can be something else. It can be a fungal pneumonia, it can be ABPA, it can be nocardiosis or mycobacterium other than tuberculosis or atypical mycobacteria. Then viral pneumonia. Everybody in this house knows that for last 3 years we have been facing pneumonias because of COVID. So you can't treat them with amoxicillin and clarithromycin as a community-acquired pneumonia. We need to differentiate. We need to reach to the root of pneumonia. Then PCP or PJP as it is labeled nowadays, and definitely CMV or other viral atypical pneumonias. Then we comes to the non-infectious causes of pneumonia. It's an extensive list because a patient of pulmonary edema or LVF might have fever because the wet lungs can acquire infections. But actually the underlying cause is pulmonary edema and it will look like pneumonia. It will be acute onset breathlessness with fever and cough. It can be pulmonary embolism. The neoplastic causes definitely lung cancer, endobronchial tumors and lymphoma. This can cause or mimic pneumonias. Then we have immunological causes, the vasculitis, vaginous granulomatosis, cryptogenic organizing pneumonia or BOOP, which was the previous terminology we used. Then acute interstitial pneumonitis, which can be eosinophilic pneumonia or tropical eosinophilia in our country. which can be because of worm infestation, that can be because of use of Ayurvedic medicines or bhasma or heavy metals. So these acute interstitial pneumonia should be taken very, very seriously because patients are very hypoxic. Then sarcoidosis, especially the alveolar sarcoidosis, can present with pneumonias. Pulmonary alveolar proteinosis. Then lupus pneumonitis can be the presentation of SLE and it looks like pneumonia only. Then polymyositis or dermatomyositis, acute eosinophilic pneumonias or chronic eosinophilic pneumonias, and most importantly, the drug toxicity can actually cause pneumonia. I will come to the list of it, and radiation pneumonitis as we come across more and more of pneumonia patients, especially in radiation cases. So whenever we are not able to find out the actual cause of pneumonia, the patient lands up in ICU. So I'll actually substantiate my talk with few of the cases which we identified and published in the literature. This is 42-year-old male without any risk factor, non-smoker, no alcohol intake, non-diabetic. He had first admission to ICU with an MDR Klebsiella. So this patient in first admission received meropenem. He improved, went home. After 3 months, this patient was admitted with MRSA. A patient who is not HIV, not diabetic, not alcoholic, non-smoker, had these kind of serious infections within 3 months of time. So that raised a suspicion. There has to be something wrong with the airway. So we went ahead and performed the bronchoscopy, and that showed that there are multiple masses in the intrabronchial airway. These masses, although had the overlying mucosa normal, but we still went ahead, did the biopsy, and the biopsy showed that these are pseudo tumors of bronchi or the airway. So this is endobronchial pseudo-inflammatory tumors or polyps which obstruct the airway, which obstruct the bronchi, and that leads to post-obstructive pneumonitis. This case was actually published in Egyptian Journal of Pulmonology. This patient had occupational exposure to a lot of chemicals because he was working in ordnance factory. So we started him on inhaled steroids, the anti-inflammatory drugs, and definitely the stimulants were taken care of. He was provided with personal protective devices. He was advised to use N95. And for last 5 years, he haven't got any new episode of pneumonia. All these masses has resolved, which was seen on the follow-up bronchoscopy. There is another very interesting case, a 20-year-old farmer who was referred from Meerut, and he was very acutely hypoxic, history of 10 days fever, cough, breathlessness. HIV was negative, no diabetes, no blood pressure, no thyroid, and he was not taking any substance abuse. So he was severely hypoxic. He was on non-rebreathing mask with a saturation of 84%. If you clearly see, there are coarse nodular infiltrates in the bilateral lung field, so he was labeled to be as a miliary tuberculosis case. And he was started on ATT. But this patient was running 103 fever and was very, very hypoxic. So we thought that it might not be because the radiological picture is not typical of miliary tuberculosis. And we went ahead with a high risk consent. We performed transbronchial lung biopsy. And to our surprise, the diagnosis was disseminated cryptococcosis. A disseminated pulmonary cryptococcosis in an immunocompetent host because of his history of farming and digging the wells. So this case was published in Indian Journal of Association of Chest Physicians. Then there is another case. So to the entire house, this looks like pneumonia in the left upper lobe. There is no doubt. There is air bronchogram. It's a lobar pneumonia. Patient presented with cough, fever, breathlessness. Because of hypoxia, he needed intubation, so ventilator was provided. And patient had acute kidney injury. So it is a clear-cut case of pneumonia with sepsis with multi-organ dysfunction. But to our surprise, his echo showed that his right heart pressures were more than 60. It was 65 mm of Hg, almost more than 3 times of the normal values. Because of AKI, this patient could not undergo the CT pulmonary angio. Because of ventilation and a mass effect and old pulmonary tuberculosis, there was no role of VQ scan. So how do we diagnose? We were suspecting pulmonary embolism in this particular patient. So what we did is that there is an instrument called endobronchial ultrasound. On the ventilator, we took the endobronchial ultrasound, which enabled us to do a Doppler of pulmonary arteries through the airway, and that showed a filling defect in the pulmonary artery, which is clearly shown here. And this was first case published from India in respirology case report, that endobronchial ultrasound can be used not only for mediastinal masses or mediastinal nodes, but it can be used to Doppler the pulmonary vessels around the airway. So you see that radiologically and clinically they look similar. This is another case. This was not our case. This patient, an elderly female who had bilateral mass-like lesion in both the lungs, was taken care by the physician and was referred to oncosurgeon because these were masses in the lung. So the oncosurgeon went ahead with the CT guided biopsy, right? Because it looks like a mass, so it can be carcinoma of the lung. On CT guided biopsy, the diagnosis was established as granulomatous inflammation. So in a country like India, you see lung lesion and a biopsy had shown necrotizing granuloma. Your first diagnosis is tuberculosis. So definitely this patient was sent back to the physician, the ATT was started. After 3 weeks of ATT, this patient developed profound hearing loss and visual impairment, which is not a side effect of any of the ATT drugs and which is not the part of tuberculosis as well. And this is the time that after almost 4 weeks of ATT, this patient actually came to our ICU with hepatic encephalopathy and a serum bilirubin level of 16 and a creatinine of 2. So we said that this is ATT-induced hepatitis and hyperbilirubinemia leading to hepatorenal syndrome. This patient was in ICU. We managed her conservatively. The gastroenterology team was involved. ATT was stopped. And gradually, somehow, with the grace of God, she improved. The bilirubin came to 2. She was conscious, she was cooperative, she was responding to all the commands, but the hearing and the visual impairment is still persisted. So we involved the ophthalmologist and the ENT people. And to our surprise, the ophthalmologist said that there is bilateral central retinal artery occlusion. In a patient with necrotizing granuloma in the lung and central retinal artery occlusion, it has to be vasculitis. So vaginal granulomatosis or granulomatous polyangiitis can actually present like pneumonia. And it can mimic tuberculosis because it gives you granulomatous inflammation. So this patient was offered steroids, her hearing as well as visual impairment improved, and she went home without ATT. And after 6 months, she had gross improvement. So you see, whatever looks like pneumonia cannot always be a pneumonia. Whenever your patient is not responding to your therapy for CAP, don't start escalating antibiotics, right from amoxicillin, clarithromycin to tazobactam to meropenem to polymyxin to colistin. It might be something else. You need to think out of box. So this case was published because central retinal artery occlusion bilateral is a very rare phenomena even in vaginal granulomatosis. And this was published in Journal of Association of Chest Physicians of India. Nothing is what it seems. So this is a very interesting case. It's a young male who doesn't have any other history than epilepsy. So this patient was on phenytoin for epilepsy for years, almost for 5 years. And he presented with fever, cough, breathlessness of 2 weeks. And he was not responding to any of the antibiotic. He was hypoxic as well. So in a patient who comes with hypoxia, not responding to antibiotic, as a chest specialist, we go ahead and do bronchoscopy first time. But this was quite atypical to be a community-acquired pneumonia. So we went ahead and did a transbronchial lung biopsy, which showed that there are peribronchial ill-formed granulomas. So peribronchial ill-formed granuloma is a clinical and classical finding of hypersensitivity pneumonitis. So this patient is not a farmer. He's not digging wells. He doesn't have any exposure to organic dust disease. So how come he has got hypersensitive pneumonitis? So this hypersensitive pneumonitis was actually caused by phenytoin. There are more than 1,000 drugs which have got pulmotoxicity or pneumotoxicity. We all know that NSAIDs cause kidney failure, right? We all know there are multiple side effects of antibiotic. Aminoglycosides can actually damage kidney, but we do not know what are pneumotoxic drugs. A drug like nitrofurantoin can actually cause irreversible pulmonary fibrosis. A drug commonly used like amiodarone or cordron we commonly know, it can actually cause gross hepatic and pulmonary fibrosis. So a patient will behave like ILD who is being treated with long-term cordron or amiodarone. So drug-induced lung injury can present like a pneumonia. Always think about it, and this case was published in Lung India, which is a reputed pulmonology journal from India. This is very interesting and quite mind-boggling case. So this 57-year-old patient who was actually diabetic and uncontrolled diabetes with an HbA1c of more than 11.5. He presented with high-grade fever, cough and breathlessness, typical presentation of pneumonia, and his sputum examination, the culture showed multi-drug resistant Klebsiella. So he was given meropenem for 2 weeks. His fever, which was high-grade, came down to be 99 and 100. And there was some resolution, 5 to 10% in his radiology, but the low-grade fever is still persisted. So first diagnosis was MDR Klebsiella pneumonia. The second diagnosis was that we performed the bronchoscopy, which showed that they are AFB positive. The BAL or bronchoalveolar lavage was AFB positive. So this is second thing which this patient had, underlying tuberculosis and a secondary chest infection. So we started this patient on ATT obviously, but after 4 months of ATT, this fever persisted. Rather in last 2 weeks, this fever again went back to high-grade fever. And the radiological picture never resolved. So now you think of an MDR-TB, right? But to our surprise, the shadows persisted and we performed the CT-guided biopsy, which showed broad aseptate hyphae, which is actually mucormycosis. So this patient had multi-drug resistant Klebsiella, this patient had tuberculosis, and this patient had mucormycosis. This patient was given amphotericin B. So actually, his diabetes was not well controlled, and that led to multiple sequential infections, and this case was published in Respirology Case Report from Japan, a trilogy of sequential infection in a diabetic male. So now you see diabetes can actually present like anything. This was the first time that his diabetes was actually diagnosed. This is very, very rare case. Till date, on the globe, in the literature, less than 200 such cases have been reported. This is a case, elderly male, diabetic, obese, was referred from a chest specialist to another chest specialist for non-resolving bilateral lower lobe pneumonia. And you see, there is lower lobe pneumonia with some little bit of blunting of angle. So there is surrounding pleural effusion as well. And the fever was low grade around 100. And there was a vague history of some swallowing difficulty for last 2 months, 3 months. So when a patient comes with swallowing difficulty and non-resolving pneumonia, you consider it to be whether it is esophageal dysmotility in a diabetic patient, or it can be carcinoma esophagus leading to recurrent aspiration, or a tracheoesophageal fistula causing non-resolving pneumonia, right? So we went and performed contrast CT scan of this patient. Now, if you can appreciate actually, here, if you see the cursor, no. So in the center, there is trachea, which is a black rounded appearance. And just beneath the trachea, you see a thickened, enhanced structure, which is esophagus. The esophageal wall is quite thick, and there is paraesophageal collection as well as bilateral pleural effusion. So now the diagnosis is something is wrong with the esophagus, which is causing non-resolving pneumonia. So obviously the PET was done. And PET showed that there is diffuse uptake in the esophageal wall and there is gross uptake at the GE junction. So the next best thing you do is you go and do a upper GI endoscopy so that you can take a biopsy from the esophageal wall, right? To our surprise, the gastroenterologist came that there are few blind sacs in the esophagus, but the mucosa is entirely normal, so we cannot take any biopsy. So this was a surprising thing. But we knew that there was some collection around the esophagus. So what we did, we performed a gastrography study which showed that there are blind sacs intraluminally opening in the esophagus. So obviously there is esophageal pathology which is causing recurrent aspirations, and that is leading to pneumonia which is not resolving. After PET, we were almost certain that this is carcinoma esophagus and patient has to undergo esophageal resection with gastric pull-up. The family started crying, everything was hue and cry. But after gastrography, we thought of something else, and we went ahead with our endobronchial ultrasound. We didn't enter the airway, we entered the esophagus. I'll show you the picture. This was his upper GI endoscopy. So if you see, ideally there should be only one opening in the esophagus. But here you see the multiple blind openings which are leading to blind sacs in the esophageal lumen. So we performed the EUS-BFNA. EUS-BFNA is when you take endobronchial ultrasound and enter the esophagus rather than entering the bronchial tree. And we took sample of paraesophageal collection, like you see on the dark side of the picture. And this sample was sent for microbiology and histopathology, which showed that there is multi-drug resistant Candida glabrata. So it was fungal esophagitis with fungal mediastinitis leading to recurrent aspiration and non-resolving pneumonia. So Candida glabrata, this patient was kept NPO for 2 months. His esophagus was kept totally separate, and he was given antifungals for 8 to 10 weeks, and that showed complete resolution. This case was published in respirology case report from Japan, and this is esophageal intraluminal pseudo-diverticulosis presenting at non-resolving pneumonia diagnosed with EUS-BFNA. So you see, the pneumonia can be a troubling thing. It's not always simple, start amoxicillin and clarithromycin. Then definitely lung cancer. This is the great mimicker. This is DNB thesis which was carried out at our center. 85% of lung cancer in our country unfortunately diagnosed in stage 3B and stage 4. And out of those 85%, 50% of patients are actually on ATT for last 3 months. Mind it, if your diagnosis is not certain, please do investigate, because reaching to the root of cause is very, very important. Even a patient might be having pneumonia, but that can be post-obstructive pneumonitis because of an intrabronchial tumor. Right? So carcinoma can be a hidden thing behind a pneumonia. Then these are few of the drugs being used by oncologists very often and can cause lung shadows like dasatinib, crizotinib, pembrolizumab, erlotinib. These are oral anti-cancer drugs, and they have innumerable lung toxicity. The oncologist will refer a patient that this patient is immunocompromised, getting chemotherapy, and this patient has got effusion that has to be tubercular pleural effusion. Start the ATT, doctor. And we analyze the fluid, and it comes out to be that the pleural effusion secondary to dasatinib. Dasatinib per se causes pleural effusion. It causes organizing pneumonia. It causes atypical pneumonitis or interstitial pneumonitis. So it can be a drug-induced lung disease. Now with more and more lung cancer or the blood cancer patients and myeloma cases, which we discussed, stem cell therapy, bone marrow transplant can actually cause idiopathic pneumonia syndrome. An elderly lady with 80 years of age was offered stem cell therapy. I'll just take 2 minutes. This patient had pneumonia, but this pneumonia was actually because of stem cell therapy. That was an immunological reaction. So lungs are always at receiving end. A diabetic patient may have ARDS. A COVID patient, pneumonia is presenting symptom. So lungs are at receiving end. A pancreatitis patient develops ARDS very fast. So lungs can receive any injury faster than anything else. So this was the first case where we started that this is atypical pneumonia in a patient of rheumatoid arthritis. Actually, she never responded to any of the antibiotic or any antivirals, and her complete respiratory panel and biofire was negative for viral infections. This was actually methotrexate-induced lung injury. So methotrexate per se can cause atypical pneumonia or interstitial pneumonitis. There are criteria for it. What we did, we stopped methotrexate and we started steroids and everything vanished. So these are the criteria which can be used for diagnosing methotrexate-induced lung injury, although these things are very, very rare. But if you don't think, sorry, so if you don't think of a rare diagnosis, you will always miss this diagnosis and you will always miss your patient. Thank you. Because whatever we see, it actually obstructs our vision beyond. So if we see this ball, we do not see that there is a cafe outside. So we have to think out of the box. We have to see beyond the walls. Thank you.
Thank you, Dr. Joshi, for your excellent presentation on pneumonia mimics. You have shown very atypical cases which will be looking like pneumonia. Actually, they are not pneumonia. You know, pneumonia is an inflammatory condition. Usually, you mean pneumonia means a bacterial pneumonia. There can be so many other types of pneumonia, but a bacterial pneumonia is acute onset, having typical clinical pictures. So, there are certain situations. Everywhere you will not think it, and the cases which were presented, very interesting cases, but they are extremely rare. Fungal infection, drug-induced pneumonia, or this vascular causes, either this vascular obstruction like embolism, or so many other causes, granulomatous, other granulomas, tuberculosis. They are very rare situations, but for a common physician, he has to go by commonness, and when there is either non-resolution or very response to antibiotic is not proper, patient is going down, then you have to open your mind and go for investigation. Now the topic is open for discussion. Please, Dr. Paningrai.
Thank you, Dr. Joshi, for the nice presentation. Really, these are very confusing, but I'll just comment. I have two comments. In the first case, I'll comment. I think in the case of rheumatoid arthritis on methotrexate and having this sort of picture in the HRCT, there should not be any confusion. Either it can be due to methotrexate, the disease per se can also cause this type of problems. So this is a clear-cut cause picture of this is okay, interstitial pneumonia. Coming to another case, what you have shown that granulomatous changes in the fourth cases like that. You see, you have tried with antibiotics, but subsequently you have shown the CT-guided FNC. There are granulomatous changes. There are involvement of the ear. So I think no need of going to ATT and that stage. We should have more gone through the GPA. Because that is a clear cut, it's such a nodular showing granulomatous lesions. In case of elderly people like 60s or 70s, we should, I don't know what investigation you have done further, but going to ATT suddenly is not the appropriate. We should have more go to vasculitis because urine involvement is very common in case of GPA, and this type of deafness is very common in GPA. And it's a granulomatous changes, and it's a case of vasculitis. It can, whether a typical or atypical, can also cause various vessels. So these are my 2 points. So I think ATT in the past is not very appropriate. We should have gone more to the GPA first. Then we should.
So typically when a clinician is seeing pneumonia, he starts with antibiotic. If the shadows and symptoms doesn't respond, they start with ATT, and if after 2 weeks of ATT there is no response, they will start with the steroids. But actually it should not be a blind therapy for all patients.
Thank you very much. But the thing is that actually what is happening? Yes.
Arshad, the nice presentation, and it's eye-opener, some cases are eye-opener, and we actually work together and we have a lot of cases like this. So my comment on that don't go through the X-ray findings and just blindly start the treatment, because as you all know, tuberculosis is very common, but every lesion is not tuberculosis. So I think tissue diagnosis is must in every case. Most of the patients see the infiltration, then want to be positive, they start ATT, and the patient comes to us with ATT-induced hepatitis as that case. So I think tissue diagnosis is very important. Look for, if you could not produce sputum, do a bronchoscopy, this BAL, and I think BAL is available everywhere now. You can actually demonstrate, and gene expert is very important, because gene expert will tell you that, you know, if it is
definitely
there is no, you just start ADT. So I think tissue diagnosis is must in every case of lung infiltration, and for the proper treatment. This is my take home.
Completely agree, sir.
Thank you.
Thank you.
Any other comment or any question? So to conclude, this session is a very good session, and next.
Yes, I would like to invite the next speaker, Dr. B.K. Abhichandani. So kindly welcome, sir, to deliver the talk.
Honorable chairpersons and all esteemed colleagues, over the next 20 minutes, I am going to take up this topic allotted to me, travel advice for people with comorbidities. So tourism is on track and towards full recovery, as new data from UNWTO, that stands for United Nations World Travel Organization, shows strong start to 2023. Overall, international arrivals reached 80% of pre-pandemic levels in the first quarter of 2023. An estimated 235 million tourists traveled internationally in the first 3 months this year, more than double the same period in 2022. And in many places, in fact, we are close to or even above pre-pandemic levels of arrivals. As the world becomes more interconnected, travel has become an integral part of our lives. Certain travelers are at a greater risk of disease because of age or underlying medical conditions. Such conditions, however, do not dissuade these people from traveling. They are, globetrotters. Everybody likes to travel. But what is the risk? The risk of travel-related disease is 2.3 times higher in those with underlying medical conditions than in healthy travelers. Those taking immunosuppressive medications experience more travel-related skin infections than do their healthy travel companions. Given the unique health situations of high-risk travelers, there is a need for better characterizations of these persons, their trip-related risks, and their pre-travel care. So before embarking on a journey, we normally advise and recommend that every person with 1 or 2 comorbidities should schedule a consultation with their primary care physician or a specialist familiar with their medical history. This consultation should in fact focus on assessing the individual's overall health status and evaluating the risks and benefits of travel. But what is the grim reality? Up to 63% of travelers do not seek pre-travel advice, even if they are suffering from multiple comorbidities. So comorbidities encompass a range of chronic medical conditions such as diabetes, hypertension, heart disease, respiratory disorders, and immune system disorders. These conditions often necessitate ongoing medical management and can weaken the body's ability to combat infection, including those caused by emerging pathogen. And we saw this during the COVID pandemic. And honorable chairpersons, my subsequent slides reflect our routine conversation, one-to-one conversation with our patients. So I start like this. So when you are getting ready for a trip, staying hydrated while traveling might not be on your radar, but it should be, because air travel can be surprisingly dehydrating, setting you up for a possible effects of mild dehydration such as headaches, dizziness, and fatigue before you can even arrive at your destination. And the Aerospace Medical Association recommends that all in-flight travelers, especially those who are not well, they should be consuming around 250 ml of water per hour during the flight. And if the person plans to get a quick nap or gets lost in a movie, setting an alarm on his watch or cell phone can be a helpful reminder. And not getting enough fluids can interfere with short-term memory, attention, and mood. And I also recommend that my patients should remember to pack lip balm, saline nasal spray, and travel size hand cream. And if they are wearing contact lenses, they should opt for a pair of glasses on the plane to avoid what is very common, dry eyes. Regarding medications and supplies, pack an ample supply of medication, almost 2 to 3 times the routine quantity consumed at the home, and extra medical supplies and necessary prescriptions to last the entire trip. Traveling can put a stress on the immune system, so it's important that it's functioning well. Key nutrients for the immune system include vitamin A, C, D, zinc, and beta-glucans. Consider carrying a doctor's note explaining your medical conditions and the need for certain medications or medical devices. Now, 2 slides, attributed to traveling with diabetes. So, persons with diabetes should get extra supplies of medication, device spares, and backup. There is a cartoon to the right which summarizes this particular slide. And get advice on adjusting insulin on long-haul flights. This is very important. Eastward travel will shorten the day and generally mean a temporary reduction in insulin doses, whereas westward travel will extend the day and possibly increase insulin requirements. And everybody who is traveling, especially those with multiple comorbidities, should have flight details to hand, including the departure time, the length of the flight, and the local time of arrival. Now, when crossing different time zones, the person with diabetes may need to change the time or date on insulin pumps, especially those who are traveling using an insulin pump, CGM or Freestyle Libre. And this may be done manually, so the person can get the correct basal insulin dose, and it is advised to such persons to seek guidance from their HCP before they commence their travel, and this guidance should help them learn which settings to change and when. And if you are using an app, if my patient is using an app, the date and time on smartphone should automatically update when traveling across time zones. If you use a Freestyle Libre reader, one will require to manually adjust the time for accurate reports, and all this needs to be taught to our patients. Regarding vaccination and immunization, the person has to ensure that all routine vaccinations are up to date. Additionally, follow the recommendations of health authorities regarding travel-specific vaccinations, such as those for yellow fever or hepatitis, depending on the destination. So before embarking on any trip, individuals with comorbidities should ensure that their routine vaccinations are up to date, and these include vaccines such as influenza vaccine, pneumococcal vaccines, Tdap, herpes zoster, that is shingles, and among others. And these vaccines protect against common infections that can be particularly severe for those with underlying health conditions. Depending on the destination, travelers may need additional vaccinations to protect against disease prevalent in certain regions. For example, yellow fever, typhoid, hepatitis A and B, and meningococcal vaccines might be recommended for or required for entry into certain countries. So, travel-specific vaccination should be administered well in advance of travel to ensure adequate protection. That means early planning is very wise and required. And this is a snapshot of various continents' requirement for travelers landing into those areas. I will not go through the details, but there is a list of vaccines which are required to be completed before entering these subcontinents. Researching the epidemiological situation at the intended destination is crucial. So that will be done by my patient, and I will also help him in the best possible way I can. And especially check for COVID-19 infection rates in the destination place, vaccination coverage, healthcare infrastructure, and any travel advisories issued by the health authorities of the destination country. The ongoing COVID-19 pandemic has brought vaccination to the forefront of travel considerations. Previously, we were not that enthusiastic or particular, but now all of us are. Individuals with comorbidities are often at higher risk of severe outcomes from COVID-19. Hence, travelers must receive the full course of a COVID-19 vaccine according to the guidelines set by health authorities. And they need to bear in mind that some destinations might have specific requirements regarding COVID-19 vaccination for entering those countries. And individuals with comorbidities should consult their healthcare providers before receiving any vaccines. Some vaccines might not be recommended for certain comorbid conditions. I'm coming to a slide which reflects this particular statement, or may need to be administered with special precautions. For some vaccines, booster doses are recommended after a certain period to maintain immunity. So make sure to inquire about any booster requirements, especially for disease like hepatitis B or tetanus. What about the immune status? Certain comorbidities and their treatments can in fact affect the immune response to vaccines. Even if these guys get vaccinated, they may not elicit adequate antibody production. So the healthcare provider can help assess your immune status and recommend appropriate vaccinations. So there are some comorbidities listed on this slide and their possible influence on vaccine response. Relevant comorbidities are cardiovascular disease like hypertension, CAD, or congestive heart failure will lead to a reduction of vaccine immunogenicity, or COPD with a decline in lung function and a higher risk for pneumonia or infections due to influenza. So these are very common comorbidities which can challenge the immune response elicited by a good vaccine. And end-stage renal disease has a high impact on developing infections and cause immune dysfunction over all parts of immune system. ESRD is fraught with great susceptibility to develop acute coronary events as well as sinister infections. Depression, dementia, and psychological stress are associated with poor antibody response and a higher range of inflammatory markers. And there are some other conditions listed on the slide. Chronic inflammatory processes like RA, rheumatoid arthritis, geriatric syndromes and lowered functional status, malnutrition and vitamin D deficiency, and frailty. All of them have implications for vaccination response, adverse implications. So it is important to discuss potential vaccine side effects and risks with your healthcare provider. Every person embarking upon a journey with multiple background comorbidities should discuss this with the treating physician. And this discussion will help you make informed decision about which vaccines are most suitable for your specific health condition. Maintain an updated record of all vaccinations you have received. This will be invaluable for your medication history and may be required for entry into certain countries. And this is the slide I was referring to. It's from CDC 2023 recommendations. That is recommended adult immunization schedule by medical conditions or other indications. So you have the list of vaccines, and then pregnancy, immunocompromised, excluding HIV. HIV has been given a different slot. Patients who have undergone spleen removal, ESRD, heart or lung disease, chronic liver disease, diabetes. And there are some contraindications that need to be discussed with our patients and some precautions. So because of want of time, I can't go through the details of this slide. And some countries might require an international certificate of vaccination or prophylaxis known as ICVP for certain diseases. So your healthcare provider can issue this certificate after administering the relevant vaccines. And the person is advised to carry copies of his or her medical records, test results, and a list of emergency contacts. This information can prove invaluable in fact, in case of unexpected medical events. Acquire comprehensive travel insurance. This is also a part of advice we impart to our patients with comorbidities who are planning travel. So acquire comprehensive travel insurance that covers medical emergencies, including exacerbations of comorbidities and unexpected illness. Carefully review the policy to understand coverage limitations. So in learning, seeking a proper policy and knowing it thoroughly well is very important. Choosing transportation options that best accommodate your medical needs is again essential. So because long flights or long train journeys may require regular movement to prevent blood clots, especially in the lower limb or anywhere else, and thromboembolism. And while road trips may necessitate breaks for medication administration. Continue adhering to infection prevention measures such as wearing masks and practicing good hand hygiene, especially in crowded areas. Even if the country is very relaxed by now, still maintaining physical distance wherever possible, even if destination guidelines are less strict, is really worth it. What about altitude? So consider the climate and altitude of the destination, as these factors can impact your comorbidities. Extreme temperatures or high altitudes may require additional precautions and medication adjustments. For example, people who travel to Ladakh in our country, they are also advised to take one rest for first day, have only liquids and Diamox preloading before they start the flight. So the takeaway summary of my presentation is that traveling with comorbidities demands careful planning, attention to detail, and a proactive approach to health and safety. By collaborating with the HCPs, understanding destination risks, and taking necessary precautions, individuals with comorbidities can enjoy enriching travel experiences while minimizing health-related challenges. And the traveler should remember that his health is paramount, and informed decisions can lead to fulfilling journeys that prioritize both adventure and well-being. Thank you very much, sir, Honorable Sir, for this.
Thank you, Doctor, for your excellent presentation, particularly the advices people will seek before traveling. So the subject is open for discussion. Any questions?
Yes, so medication timings will be again, only thing it really specially I wanted to highlight was the timing of insulin and dosage of insulin. But this is a good question. Hypertension, no major changes in the timing of the medicines he is taking. So at the same time, during the flight he can take, and when the time zone changes, the landing, the destination time should be used for taking the next dose of antihypertensive. And all antihypertensives are permitted. There is no restriction for any of the routinely, except diuretics, which for long distance journeys are usually overnight. So diuretics are best advised in the morning, and they are done with that. So, yes, sir.
Okay, thank you. One more problem in the long journey, because now we fly almost 12 hours, 14 hours, 16 hours.
Non-stop, non-stop.
Non-stop.
Many of these flights are non-stop.
So, how common DVT is there in problem? Number one, how to prevent the DVT prophylaxis during the flying? My question, number one. And number two, this is out of context. You have shown you have to take 1 glass of water almost every hour.
Dehydration is there.
So 1 glass of water every hour. So for long journey, elderly people having
will have to go to the washroom.
So running to the urinal is a problem again. So that's a problem. Every hour, if you take 1 glass of water, then frequently the elderly people will be running to the toilet.
Should I pick up the second comment first? Because it's counterproductive. If they don't take, they may sometimes really have thromboembolism. They may have acute kidney injury. So the trade-off is in favor of taking fluids. That's my answer to your second comment and question. The first, you said how to prevent DVT. Is all airlines, and if people are attentive, they have this special, instructions of carrying out certain exercises during flight, which can prevent thromboembolism. But brisk walking and giving your legs some form of regular exercise during the flight. You will see many people walking down the alley, and especially in business class, if you're traveling, there are spots where people literally do the routine, routine exercises very regularly. But even in an economy class, one can always get up and walk. That's not bad. So I think walking is the best. Stretching your legs, stretching, doing whatever stretching with the limited space that is existing in an economy class. But these are the ways we try to, avoid.
Compressive stockings, is
They
there?
are there. But if there is an indication, compressive, for example, a person with varicose veins, I would definitely recommend compressive stocking. But in a person with lot of swellings in the leg due to, for example, congestive heart failure, they may be counterproductive. So it's just the underlying background comorbidity will decide whether we advise such patients compressive bandage or not. So thank you very much for this great questions. Yes, sir.
Goal of giving equasprin or LMWH, because we recently revised one of the international guidelines. They mention standard of care ki ideally this patient should be put on. And many times, many traveler like 24-hour continuous flight, they are asking. So what is your call on this?
I think if between the two, I would be happy offering him a low dose aspirin. Not a low molecular weight heparin. One shot of heparin is not going to offer any major protection. If it is to be started, initiated, it has to be there for minimum 7 to 10 days, 0.6 units, international units per.
Equasprin at least should give susceptible individuals.
Yes.
No, for a heparin, it will take 48 hours, it will be all right.
Come again, sir?
48 hours, you can heparinize the patient if you will start the dose.
Even sub-Q heparin? I mean that.
Oral, it will take long time. Heparin injection will take short time. For heparin.
Yeah, but that.
Low one dose also. So, no, what said? How earlier you will start for prevention of prophylaxis?
Yes, that is.
So, rather IV on fractional heparin has quick action. Yes. On fractional heparin, quick action. And this even low molecular weight heparin takes some time.
That adds to my knowledge. Thank you, sir, for sharing with me.
Sir, regarding COVID vaccine, there's a lot of hue and cry regarding the side effects of COVID vaccine. In fact, in September 11, I think US FDA has given an advisory that this monovalent vaccine produced by Moderna has to be taken annually, and it is very safe against all the variants which is circulating nowadays, and it is safe to use as 6 months of age to any age. Yes. Right? I think this would come into the travel advisory that every patient going to US to take that this monovalent vaccine for the long flights. Thank you.
Thank you for that great input. Thank you, sir.
Thank you, sir, for delivering the excellent talk. So we'll move to the next topic. So I'd like to invite the next next speaker, Dr. Sanjay Das, to deliver his topic. The topic is the management of undifferentiated fever in a PSC setting. So welcome you, sir, to deliver the talk.
Good afternoon. I thank the organizers, especially Professor Panda, to give me this platform. And I am privileged that my teacher, Professor Ray, is there chairing the session. 3 years back, I had spoken in the same topic in API Agra. 2 things have happened since then. COVID-19 swept the globe, and WHO has recommended not to use antimalarials in a case where RDT is negative. So these are the 2 things which has added to what I had spoken last time. COVID-19 I am not going to speak because that is not coming under undifferentiated fever, as well as government mandated fever clinics. Patients with SARI or ARI are supposed to go to government mandated fever clinics, which are there. And fortunately, COVID-19, WHO has not declared pandemic is not yet over, but emergency is not there. So I'll start my topic, management of undifferentiated fever in a PHC setting. I'll speak about what is undifferentiated fever, what is fever of unknown origin, what are the rural infrastructure. I've got an experience of working in such places for the last 30 years. And I've seen most of these cases which I'm going to discuss. Categories of fever. Generally, there are 3 categories of fever which account for the majority of fever cases. These categories are infections, malignancies, and systemic rheumatic diseases like vasculitis, rheumatoid arthritis. Acute febrile illness is mainly due to infections in our country. So I'll be sticking to only that one. Fever of unknown origin, I'm not going to talk about fever of unknown origin. Fever of unknown origin, anecdotal, the definition is fever continuing for more than 3 weeks and it is 101 degree Fahrenheit, and for 1 week hospitalization we are unable to diagnose with various clinical examination as well as investigations is fever of unknown origin. So I'll be speaking about India, which is a tropical country. Tropical country means which is near the equator, and the climate in Indian subcontinent is warm, humid, and there is usually less variation. In most of the part of the country, there is less variation between summer and winter temperature. Monsoon periods are actually, it's very flooded in throughout the country, and monsoon period is a convenient time for mosquitoes to breed and infected mites to thrive. In that season, drinking water also gets easily contaminated during this period. All these lead to clustering of some diseases which we all have seen, that is dengue, malaria, typhoid, and scrub typhus. These are the fevers which are known as undifferentiated fever, and with all, at least in the peripheral part of the country, we all deal with such cases. Tropical fevers, what are the tropical fevers? Tropical fevers are the infections which are prevalent in tropical and subtropical regions of the globe. Tropical fevers are caused by such organisms and vectors which can survive in this hot and humid weather, and they can proliferate. In temperate zone, what happens? These organisms are not found. They hibernate in such seasons. Some of these fevers occur throughout the year, while some others are common in monsoon period and immediately thereafter. These are commonly bacterial, viral, protozoal, or other parasitic diseases. And these are usually caused by insect bites, unhealthy surroundings, lack of clean drinking water, and poor sanitation and malnourishment. These are the main reasons for these tropical fevers happening in our country. So now I'll shift my focus to what is acute undifferentiated fever. Acute undifferentiated fever is loosely defined as a fever having 101 degree Fahrenheit of 14 or less days in duration without any localizing sign or symptom. That means there are no signs and symptoms which we can localize it to a particular organ. In developed countries, acute undifferentiated fever is normally due to viral fever and they are self-limiting. Whereas in developing countries like India, acute undifferentiated fever has been variously described in different literature, having malaria, dengue, leptospirosis, and typhoid fever. They present as acute undifferentiated fever. Please note, some of the signs and symptoms, mainly the myalgia, arthralgia, headache, altered sensorium, and jaundice, are not considered to have any localizing value. Now, the second type of which I'm not going to discuss is localized fever. Like the signs and symptoms are pointing to a particular organ like pneumonia or skin and soft tissue, GI system like diarrhea or genitourinary symptom. I'll shift my focus to what is the health scenario in our country. You all will be astonished. We all know this, but the exact data is this. India's estimated health budget in this financial year 23-24 is only 0.35% of its GDP, and the annual budgeted is 2.4% of total budget, whereas in developed countries it is 6%. The benchmark is 6% or more. The total number of registered allopathic doctors as on 31st March 2022 is allopathic doctors are more than 13 lakhs who are registered, and 70% of population of India live in rural areas where I work, and the sub-centers are 1.61 lakhs, and the PHCs, primary health centers, are 31,000, a little bit more than 31,000. And we all know that in PHCs there are dearth of doctors, and there are more than 10% vacancies for more than a year, more than a decade, and some of the vacancy rates are 35% or more. So the health infrastructure has 3 tiers in our country. First is the sub-center, which is the most peripheral contact point between primary healthcare system and the community manned or the district headquarters. And it is manned by one health worker, male and a female, or A&M, and it caters to 5,000 population in plains, and in hilly or tribal areas it is 3,000. The next tier is primary health center, which is a referral unit for 6 such sub-centers, which is 4 to 6 observational bedded sub-center, which is manned by only one medical officer. And there are 14 subordinate pharmacists and other paramedical and non-paramedical staff under him, and it caters to 30,000 in plains and 20,000 in hilly or tribal areas. The next tier is community health center, which is a 30-bedded hospital referral unit for 4 PHCs, and some specialists are there in community health center. The next tier is district headquarter hospital. So what are the challenges? What are the challenges we, the peripheral doctors, face? The challenge is, in a resource-crunched healthcare centers in the peripheral parts of the country, the treating physician or the treating doctor is overburdened with huge workload. Not only he has to see the patient, he has to examine and treat the patient, he has to do a lot of file works. Lots of healthcare government, central government and state government projects are there which he has to handle. The diagnostic facilities are also very meager and limited in peripheral centers. The cases of fever presentation of 3 to 14 days duration are quite common, and they are huge in number. I was seeing more than 200 cases a day. Individually, I was seeing a lot of cases. Cases of fever presentation of 3 to 14 days duration are very common, and the etiologies, it's very difficult to find at a etiology in such cases. These all have overlapping clinical features for which the initial diagnosis is very challenging, and unless we properly manage such cases and find what are the warning signs so that we can refer the patients to higher centers, they become very deadly. It is important for the physicians of these areas to be familiar with these diseases, which require a high index of suspicion and are easy to treat if treated at an early stage. A caveat, most of the doctors who are sitting here, they might not have worked in, recently might not have worked in peripheral setup. Most of them must have worked in big hospitals, corporate hospitals. So in ICU settings, what happened, it was there in 2017, that has now also changed. In the ICU setting, in such cases, they used to say, give 3 drugs. Now, out of them, the artesunate is now out. So there are 2 drugs. So most of the doctors sitting here, this is not going to help them because they are not going to deal such cases. In API, there were lots of patients who were, doctors who were there, who were quite benefited by what I was going to speak. So typically in an OPD, what sort of cases we find? We find ARIs, which are normally viral, which are self-limiting, which we find a lot of other cases also, diarrheal cases also. We find some hepatitis cases also, but most of the cases are acute undifferentiated fever like malaria, dengue, scrub typhus, leptospirosis, typhoid fever, and some localized cases also like UTI and bacterial sepsis. This is the data for 2017. You can see what are the distribution of morbidity reported in communicable disease and what was the mortality. So now, how to manage a case of fever? If a case of fever has come to my OPD in a peripheral setup, how I am going to manage? Like what is mentioned in Hutchinson's, we should examine the patient in detail. We should take the history, focused questions should be asked from which particular area he has come. What are the locations in my geographic area? What are the diseases now happening? What are the endemicity of the diseases, which I must know. And the detailed history will give a little bit of clue to what it could be. Then comes the examination, detailed examination, and then focused investigations are required. Once I do the clinical history and examine the patient, some clue I will be getting. So what are the cases? I will be seeing the cases of more than 3 days and less than 14 days of fever. Because if somebody has a fever, normally after 1 or 2 days, they think of coming to the health center. They don't come immediately in few hours. So normally we get cases who are having fever of 3 days and less than 14 days. So how to manage a case of fever? all fever cases presenting to a PHC have one of the more of the following features. They are having fever with chill or rigor. They are having headache, body aches, rashes. Some of them might be complaining of nausea and vomiting, and some of them have cough and dyspnea. Few of them present with altered sensorium, which is a warning sign. Initial investigations, which is very important for having in such primary health centers, are a complete blood count, which is obviously present nowadays in NHM. Thick and thin smear blood films for MP if it is possible. Vidal test, this is obsolete, but now many of them are doing Vidal test. Urinalysis, and if required, chest photograph. And if possible, now in most of the peripheral health centers, we are having RDTs for malaria, dengue, scrub typhus, and leptospirosis. So what are the common rapid tests performed to exclude the tropical infectious etiologies? As you can see, we can do immediately diagnose a case of malaria by doing the test. RDT for enteric fever also, scrub typhus, dengue fever, and leptospirosis. The rapid tests are available, and the table will show in how many days it becomes positive, and what is the SNSPs, what is the sensitivity and specificity for these particular RDTs. As you can know, in malaria, then enteric fever, scrub typhus, dengue fever, and leptospirosis, we can get a clue that yes, this could be a case of malaria or this could be a case of enteric fever. But the confirmatory tests are not the RDTs, so we have to go for the confirmatory test if at all we have to diagnose a case of enteric fever, because the typhoid dot is not very conclusive. So what are the signs and symptoms which we normally get in a case of fever, undifferentiated fever? SR, as you all know, is a black crust surrounded by a red erythematous line, which is normally present in the trunk or the axilla or the groin, or it can be present anywhere in the body. This is pathognomonic of scrub typhus, and it is normally present after 6 days, 5 to 6 days of the fever. Maculopapular rash is also very common in some of the undifferentiated fever. Similarly, lymphadenopathy is common in viral fever and scrub typhus. URI is now very common because of this. ARI is very common because of COVID. Fortunately, we are not getting a lot of COVID cases. Probably we are not doing the test, and probably it is now endemic in our country. Probably. Raised hepatic enzymes or jaundice is present in malaria, complicated malaria, leptospirosis, acute viral hepatitis. Similarly, hepatomegaly, splenomegaly, all these will portend to some, will give you some clue to where we are heading towards our diagnosis. The pattern of rashes is also very important. This table, which is a very busy slide, it can tell you the pattern of rashes. Some of the rashes are centrally distributed, some of them are peripherally erupted rashes. Measles is very common, but in children. In adult, I am basically dealing with patients of 16 years and above. Scrub typhus is now very common in this part of the country. We are getting a lot of scrub typhus cases in some of the districts. In fact, I have also seen a few scrub typhus positive cases in the last 1 month or so. Leptospirosis is not very common now, but yes, few cases of leptospirosis we are finding in the state. In my district, so far, we have not got. Dengue fever, obviously, is very common now in Orissa in so many places. Earlier, dengue fever was not there in Bhubaneswar or in Talcher, but in the last 1 decade, we are getting a lot of dengue fever. And surprisingly, my friends who are there in Jharkhand, they are telling in Ranchi and Jamshedpur also a lot of dengue fever are positive. Lots of cases are coming. My friends are telling that this is the first year they are getting a lot of cases of dengue in Jamshedpur and Ranchi. So typhoid and paratyphoid, as you all know, is endemic in our country. Primary HIV infection, we are not actually treating or diagnosing them because primary HIV infection, they come as ARI. Chikungunya is there in North India. In our part of the country, we are not getting cases of chikungunya so often. So now how we are going to diagnose most of the cases of rashes or some of these symptoms are having in all the 4 undifferentiated fever. So how we are going to say that this is dengue or this is this? So what we are going to do, what a common nomenclature has come since 2017, and that is syndromic approach. A syndromic approach means as the fever involves one or many body organs, A practical approach is to group the symptoms and signs. The symptoms and signs are to be grouped in a syndromic manner so that we can narrow down the diagnosis and come to some of the fevers, and then we can treat such fever empirically till a definitive diagnosis is made. This syndromic approach helps in arriving at a probable diagnosis and starting empiric therapy in a resource-poor setting in our peripheral parts of the country. So what are the categories of febrile illness presenting to a PHC, which is the syndromic? As you all can see, one is the undifferentiated fever. The second one is fever with rash and thrombocytopenia. Third one is fever with ARDS. These are the syndromic approach. Fourth one is the fever with encephalopathy. And finally, fever with multi-organ dysfunction. As you all can see, all the 4 diseases which I am elucidating repeatedly, like scrub typhus, then malaria, dengue fever, leptospirosis, most of the undifferentiated fever, most of these are covering all the 4 diseases. This is very important to note. So now I'll just highlight what I have said so far and come to a simple case which comes to our place. And this is a non-severe illness, and it comes to our primary health center. The clinical feature is fever for 3 days, and the patient is conscious. There is no neck stiffness. Patient is fully ambulatory. The pulse, the vitals are normal. There is no abdominal pain or sign of respiratory distress. Epidemiological context, he is coming from an area which is high malaria transmission is there. So the rapid diagnostic test which we do, MP malaria is positive by HRP2. Syndromic diagnosis is malaria, which is non-severe. So the management will be oral artemisinin combination treatment, and then we ask the patient to come after 3 days again. If he is still febrile, then we have to search for additional causes of fever. But such cases can be managed in our primary health center only. So now a severe illness. These are the patients which we have to refer, and we must triage those patients. These patients also come to our center. So clinical features of the triage assessment shows the patient is weak and unable to stand. His vitals are very poor. He's having rapid and 3D pulse. Oral temperature is quite high, 39.5 degrees centigrade. And the blood pressure is low, 85/40. He is conscious, there is no neck stiffness, and abdominal pain or signs of respiratory distress, none of these are there. Epidemiological context, he comes from a place which is area of low malarial transmission. So even then, we did RDT and it is negative for malaria. So the syndromic diagnosis will be acute undifferentiated fever, which is very severe febrile illness, or suspected sepsis with shock. So what we are going to do? We are going to revive the patient. We are going to start some fluids and give empirical intramuscular ceftriaxone, and we should urgently refer to the district hospital. So the warning signs which all must know, or I'll take 2 more minutes. Warning signs are altered sensorium, hypothermia, hypotension, bleeding manifestation, persistent vomiting, severe anemia, and desaturation. WHO acute care guidelines on integrated management of adolescent and adult also says the same way. We should investigate and examine and treat such patients, manage initial management, and such patients who require urgent management and referral to a hospital with critical care setup. We all must be aware of such cases. So now treatment. Treatment part is most febrile illness in the community are probably caused by self-limiting viral fever, and we need not treat them except symptomatic. We can give them some fluids and paracetamol. Almost all illnesses presenting to a peripheral health center have overlapped non-specific symptoms. Hence, clinical algorithm in such cases is not possible. There is no uniform guideline in our country or wherever for instituting empiric treatment in tropical febrile illness. However, in sick patients, the idea is to hit wide and hit early with the intention to de-escalate once a definitive diagnosis is established. So, empirical treatment we have to give. So, the commonest fever cases which almost all PHC receive are the acute gastroenteritis, which I have alluded to earlier, viral fever, typhoid, viral hepatitis, malaria. If we are not treating such patients, then the life-threatening multi-organ dysfunction syndrome can happen in such cases. So how we are going to treat? This slide is very controversial, but very important slide, and this is evidence-based, and this Critical Care Society of our country and other such papers, I have taken this out from there, and it was also discussed in API. Symptomatic treatment with paracetamol and fluids should be started early. If duration is less than 3 days and no danger signs, then no antibiotic to be given. And initial tests are also negative. However, after 3 days, if the patient is still febrile and still RDT is negative, we must give intravenous ceftriaxone 2 gram twice daily. Why we are giving? We are giving this because it will be covering typhoid, paratyphoid fever, bacterial meningitis, acute bacillary dysentery, as well as community-acquired pneumonia. It will cover that. Artesunate, earlier we used to say that it should be given, but now we are not giving. Artesunate should be given if RDT is positive, otherwise no. Oral IV or oral or IV doxycycline is one add-on antibiotic which will cover many such diseases like scrub typhus, leptospirosis, atypical pneumonia, and bacillary dysentery. Please note, this is all empirical. What I am saying is all empirical. In children and pregnant women, instead of doxycycline, please give azithromycin. And in ARI cases, as you all know, all such cases should be isolated first. So this empiric therapy covers almost all tropical fevers which a physician practicing in a PHC community attends. Once a definitive diagnosis is made in your center by repeatedly doing RDT after 2-3 days, then you have to shift to a definitive diagnosis and de-escalate, change and stop the unnecessary drugs. And if you are unable to treat, you should transfer the patient to a higher center before MODS has stepped in. So this is one of the algorithm, whatever I have told, this is mentioned, this is a very busy slide, but whatever I have told, please focus on the last line, and it mentions if it is malaria, if it is rapid test suggests malaria, please give treatment. If rapid test suggests dengue, please give IV fluids and supportive care. If it is typhoid, give ceftriaxone. If it is not, then empirical treatment is ceftriaxone, doxycycline. So barriers to clinical behavior. As you all know, we all are quite stubborn. We all are, as one of my friends had told to me few decades back. Once we complete our MBBS, we are walking and talking Harrison. We need not understand whatever our teachers or others are telling or whatever guidelines are telling. I think I am the Harrison, so whatever I write is the final treatment. So these are the barriers to changing clinician behavior. Still, RDT is negative in many places. Anti-malarial treatment is being given. Even because why? We are thinking that the report might be wrong. So these are the barriers to changing clinician. So summary, what I am going to summarize is, there are lack of a good medical setup in peripheral parts of India, including manpower as well as infrastructure. Endemic fevers and seasonal epidemics keep the physicians busy round the year. A thorough history taking and clinical examination will aid in arriving at a presumptive diagnosis. Even with availability of pathogen-specific points of care tests, 50% of pathogens remain unidentified. Empirical treatment guidelines therefore have definite role to play, and it is prudent to avoid injudicious administration of antibiotics if the duration of fever is less than 3 days and there are no warning signs. Fever cases need to be treated at an early stage of disease if there are warning signs to prevent MOF leading to high level of mortality. A syndromic approach to diagnose the case and early institution of empiric therapy with ceftriaxone and doxycycline or azithromycin will cover most of these illnesses. Once a definitive diagnosis is made, unnecessary antimicrobials should be discontinued and only definitive treatment continued. Please refer the patient to an infectious disease specialist or critical care center if there are signs of deterioration or no improvement.
Thank you, sir. Thank you, sir, for your excellent talk. As we are running short of time, so we'll move to the next session. Before that, I'll request Professor Gandharva Rai, sir, to felicitate the speaker. So I'd like to invite Dr. Anupam De, Dr. Sarath Joshi, Dr. B.K. Avichandani, Dr. Sanjay Das. Please be on the dais. So I request Anupam sir and Sanjay Das sir to felicitate Gandharva sir. Sir, please. So it was an excellent session. So I would like to invite for the last session, that is guarding the borders. The chairperson are Dr. Girish Chandra Behera. I'd like to invite to the dais and Dr. Niroj Misra. So kindly come to the dais, sir. Welcome you, sir. And kindly start the session without losing the time.
Good afternoon, everybody. This is the last section, the three topics. First topic is high altitude related illness. The speaker is Dr. S.K. Singh. Sir, please.
Thank you, Chairperson, sir. And good afternoon to all of you. At the outset, I would like to thank Dr. A.K. Virmani, sir, who also happened to be my mentor. And he's always an inspiring source for me and guiding me to invite me to this prestigious ACP conference and giving such a pertinent topic which most of us are not encountering in our day-to-day life, because being the terrain barrier, so most of physicians, they are not actually seen on ground these sort of cases. So next 18 to 20 minutes, I will be speaking on high altitude related illness, which is a very pertinent topic, not from the point of view of armed forces, where probably many of our physicians are practicing, but also from the point of view of travel medicine. Like the previous speaker, previous speaker, he told about like whenever you are going to Leh, Ladakh and all, so a lot of casualties are there. So what are the precautions and how to go about this, and what are the basically take-home messages for the travelers who want to go to high altitudes. To start my talk, basically these are the few of the photographs you can see which I took in my initial days, my MOS days 22 years back. These are from Tawang and few of the areas from Siachen and Leh and Ladakh. And most of them, they are more than 15,000 feet height, where terrain is so terrible, it is harsh, very harsh terrain, and actually to live in this climate is really troublesome. You can see here, you can appreciate crevasses. Many of our combatants, they died going into these crevasses. Apart from that, they also encountered a lot of other high altitude related illness, which I will be subsequently cover. So these are the preview of my talk. Now coming to the introductory part, in India, most of these high altitude area, they are actually in the region of Leh and Ladakh, and also in few of the northeastern state like Arunachal. If you all have been to Tawang, so Tawang and onwards area, that is also coming as a high altitude area. Now what is the pathophysiology of this high altitude area? Here you can see So here you can see the moment we actually ascend, like ascending from, this is showing the altitude, barometric pressure, and percentage of oxygen in the air, and also it is showing how it is going to happen. So as the altitude increases, this partial pressure, barometric pressure, temperatures, they are going to down. So this is basically, this partial pressure is a driving force getting oxygen to the tissue, and this decrease is what initially caused hypoxemia at the elevation. Now coming to these characteristics of this high altitudes, here you can see there are a lot of definition all over the worldwide. But then what we are actually following, it is stage 1, stage 2 and stage 3. So stage 1 is basically 9,000 to 12,000 feet. 2 is from 12 to 15,000 feet. And stage 3 is extreme altitude, which is more than 15,000 feet. A lot of acclimatization process are happening during this time. So you may have the respiratory components where patient may present with hyperventilations, resultant respiratory alkalosis, which is compensated by bicarb. SVO2 dissociation curve shifts to left. Then there may be pulmonary vasoconstrictions, which may cause increase in pulmonary arterial pressure, thereby causing high altitude pulmonary edema. Second, hematological changes like hemoconcentration, which can lead to increased erythropoiesis and causing the increased hematocrit. The cardiovascular system, there may be tachycardia and rise in cardiac output. And last, with physical performance, there is fall in work capacity and endurance, which is drastically down in case of high altitudes. So now coming to the topic, what are medical illness which we are encountering on day-to-day basis in high altitudes? So there are two sorts of illness. One can be because of the acclimatization failure, because rapid ascent that can cause. And second, of course, because of the pathophysiology of the high altitude, we can encounter these diseases. So here you can see the acute can be basically acute mountain sickness. You can have high altitude pulmonary edema, high altitude cerebral edema you can have, and in subacute we can have high altitude pulmonary hypertension. And there are few chronic diseases which are also supposed to happen in high altitudes. The second category is miscellaneous high altitude related problem, because high altitude being the thrombotic state, patient can have all those thrombotic events like pulmonary thromboembolism. They can present with cold injuries like chilblain or frostbite or GI related problem, dermatitis. The third part is few of the conditions they may aggravate in the high altitude like sickle cell disease, symptomatic CAD, and of course decompensated CHF. So why I'm actually divided into these three categories, these are the main high altitude related illness which we are encountering in our day-to-day clinical practice. Now AMS is very important because a lot of we are going for pilgrimage to Amarnath or Leh in our LTC or whatever for the purpose. So AMS is actually very, very frequently encountered conditions which we are encountering. So this is because of the triad of dizziness, fatigue, headache, insomnia. And there's a classifications, Lake-Lewis classification. I'm not going into detail. But then incidence of this acute mountain sickness may vary from 6 to 59%. Almost half of the person who is visiting high altitude, they are bound to experience this acute mountain sickness. So this is the Lake-Lewis classifications. Based on that, we are dividing it into mild, moderate, and severe, depending upon headache, GI, or fatigue, and also the dizziness, and last is difficulty in sleeping. Now, why does it occur? So there is a tight fit hypothesis which says effect of lack of oxygen on the brain. So there is a hypoxia-mediated mild cerebral edema which increase ICT, and it is also because of the free radical injury. So treatments remains basically in mild AMS, we give oxygen 1 to 2 liters. And mind you, whenever you are traveling in the high altitude area, there is availability of potable oxygen. In Leh, you can take it on rent from almost all the vendors. They will give you. So if you are planning to go ahead with the Leh, if you are planning to go to Khardungla or some like Peganso Peg, because these all are the celestial paradise. Everybody wants to go. Always carry these portable oxygen. It is always available with the vendor and you can always use it. You never know when you can encounter the problem during this phase. The pharmacotherapy, acetazolamide is the drug which is actually given, and in the prophylaxis we always give 125 milligram BD. So what I should actually recommend to my patients, so generally if you are planning a trip to this high altitudes, you should take these medicines almost 1 day in advance, 12 to 24 hours in advance. So if you are in Delhi and next day you are planning, take this tablet, and 125 milligram is the prophylactic dose in BD. You can start it and you can carry it for next 3 to 4 days till the time you are planning your trip in the high altitude. So this is these all are evidence-based, and there are very less studies because most of the doctors, physicians, they have not seen these patients. We have been seeing it in our day-to-day clinical practice whenever we were employed in our high altitude area. Now coming, when MS turns into HAC, this is a very clinical emergency, that is high altitude cerebral edema, and the main modality of treatment in this is patient must descend. So oxygen to maintain saturation about 90%. So first is oxygen, then dexamethasone we can use 8 mg, and of course hyperbaric therapy if the patient is unable to descend. In subsequent slide I will be showing you the portable hyperbaric chamber, how we are using it. So coming to the HAP, that is high altitude pulmonary edema. It's an emergency, and we have seen many cases of high altitude pulmonary edema, and many times it is fatal also if not treated in time. So the pathophysiology says because of this hyperbaric hypoxia, there is decrease in PO2, there is decreased oxygen diffusion capacity across alveoli, renal compensation, decreased ventilatory drive, and this is causing. There are a lot of other phenomena also like genomics, metabolic factors, which we are actually studying at High Altitude Research Center, but still these are the areas for research, not actually proven. So here what you see, there is an inherent characteristic like there is a blunted hypoxic ventilatory response, which is also triggered because of increased sympathetic tone, and if there is a rapid ascent in high altitude, so there is a lack of acclimatization, there is increased alveolar hypoxia, increased pulmonary hypertension, which is vulnerable to endothelium and epithelium, causing fluid leak, and this is what, there is an interstitial and alveolar edema, high altitude pulmonary edema, which is the genesis of this high altitude pulmonary edema. And mind you, this is 100% treatable conditions. I will be showing you few of the case where. So this is the first study which was published in Anesium. It is in 1965 by Brigadier Menon, who was pioneer, and this is the only study, the first study from the world. So he has published a case series of 335 high altitude pulmonary edema related patients who all, so one group of the patients who all came via road and another group who came via aircraft. So he found the person who came via this road, the incidence of HAP is less because they are properly acclimatized. You come from Srinagar to, if you or anyone of you have traveled, so it may take 3 to 4 days. From Srinagar you go to Sonmarg, then Dras, then Kargil, and then subsequently you come to Leh. So it may take 4 to 5 days. So you are already acclimatized. So this is one of the pioneer studies by Brigadier Menon, which was published in Anesium. So what are the symptoms in HAP? Patient will have cough, dyspnea, chest discomfort, and mainly patient is present with the dry cough. So what is the treatment for this HAP? So basically descend. The moment if you are on 16,000 feet, you should come to low height. Apart from that, there are 3 principles of management to reduce hypoxia. We need to descend, oxygen therapy and complete bed rest to reduce pulmonary arterial pressure, calcium channel blockers, and we need to avoid the cold exposure. And third one is to enhance the clearance. We are using also salmeterol. Apart from that, what we can use? Descent I have already told, and then supplemental oxygen. Now there are few trials which are conducted in our setup where we find CPAP is also equally, it can be as a adjunct therapy to oxygen, and there is a lot of benefit to the patient. So that is also there. These are few of the drugs that we all should know as a preventive measures. How much calcium channel blockers or the phosphodiesterase inhibitor we can use, then steroids you can use, and the last CPAP, that is also the modality of treatment, which the trial is going on, and the recent trial which has been done from 153 GH, we find it is better than other modality of treatment. So many patients has been benefited with CPAP. These are the radiological findings. So there may be patchy and confluent opacities, which mainly begin in the right middle zone and followed by bilateral diffuse opacity. So we can divide it into mild, moderate, and severe. This is actually based on the area. If the more than half of the bilateral opacities are involved, so that is going to be severe HAP. If The one third of the OPCTs, then it is mild, moderate, and if less than 1/3 it is. And of course, the tachycardia and tachypnea we are taking into account in definitions. So this is one of the, again, serving soldiers who come to me when I've gone on TD. So you can see, this is the first X-ray, and after day 4 with the proper CPAP and other modality of treatment, there is clear-cut resolution in the OPCT, and there's a fantastic result as well. So this is one of the case series which we published while working in the northern sector, the clinical biochemical therapeutic and complication strategies of HAP. These are the update, and here you can see same, most of these patients on the left side, they all are presented with the moderate to severe HAP, and after 3 to 4 days of proper treatment, they all come out with the complete resolution of this OPCT. So next is HAC, which is a fatal conditions, and truncal ataxia. Mind you, HAC can be mimickers of CBT. So truncal ataxia is one of the more common sign and symptoms in case of high altitude cerebral edema. And of course, CT and MRI is the main modality of treatment. The pathophysiology is basically hypobaric hypoxia, increased sympathetic activity, there is impaired cerebral autoregulation which is causing these things. So prevention is same, the acetazolamide we can use, and we can use dexamethasone also. Now, few of the differentials, so what, apart from HAC, what could be other? So severe dehydration, CO poisoning, pneumonia, hypoglycemia, alcohol hangover. This is very important between ARDS and HAP. In ARDS, lung architecture is severely disordered, while in HAP, the lung architecture is well preserved. So now this is portable hyperbaric chamber what we are using. Suppose somebody is at the height of in Siachen and suddenly he fell with hypo. So this is the portable chamber which give you same barometric pressure or PO2 as it is at the height of 9,000. So if you don't have main modality of treatment like in post or very in the tough area for the trekkers, this is the portable hyperbaric chamber that we are using, and it is actually using as a life-saving measures. And most of us, we are experienced in handling these things, including our paramedics. They are also trained in evacuating the patients with this hyperbaric portable chambers. So here you can see this is again from Siachen, and somebody will be having this problem. This is one of the hyperbaric oxygen plant. It is one of the highest hospital in the world, that is we have in Pratapur, and you see this hyperbaric oxygen therapy center is there. I happen to go on TD as a physician long back to these places, so I have already treated all sorts of cases. Now, the acetazolamide Diamox I already told, I am not going into detail, but that can cause you tingling and numbness and taste change. So that you all should know, because we all have been visiting Leh, Ladakh and all those celestial paradise, so that we should know. That is the main this thing. Now, high altitude thromboembolism, this is very important being the procoagulant stage. A lot of studies we have done in high altitude area. So basically CBT is the main features in this, and these are the because of the platelet count decrease and ADP, epinephrine and collagen, this can cause. So this is one of the case which presented to us on day 4th of the inductions, around 15,000 feet. Here you can see the patient has presented with CBT. Severe headache, ataxia, gait ataxia, these are the main symptoms. So this is again one of the study which we done in one of the tertiary care hospital at Command Hospital, Udhampur, and this is the case series of around 70 CBT patients. Because high altitude is again, it is a triggering factor being the procoagulant state, it is triggering factor for CBT. So these are the symptoms you can see. Most of these patients, out of this patients, they presented with vomiting, blurred visions, paresthesia, and mainly all the CBT cases we have seen in this. So sudden cardiac death, this is very common. Last year I had been to Begonzo and suddenly I find one of the businessmen, he collapsed. I could revive him, I was there and I was aware of this thing, but this is very common because people don't do properly acclimatization in these cases. So in CAD patients, in patients with any other comorbidities, we should be very careful about acclimatization of these cases. Though high altitude hypertension itself is a big topic, it is controversial, a lot of conflicting studies are there. So I'm not going to confuse you more, but what the Western data says, that is not actually applicable to us, because in armed forces we have largest series of the cases and experience in armed forces as far as high altitude hypertension concerned. So what actually in nutshell I will tell, because of the paucity of time, once the person is inducted into high altitude, so during the process of acclimatization, around 30 to 40%, 30% of the patients you will find they may develop BP on the borderline or maybe the stage 1 hypertension. So this is crust. So I'm not going into detail because we have lack of time. These are few studies which has been done about this high altitude induced systemic hypertension. So this is, I'm just going through this. Now, our experience, same this study we have published in Indian Journal of Physiology and Pharmacology, BP trend of low landers during first 6 days of acclimatization to high altitudes. So here you see, out of 347 cases on 6 day at high altitudes, around 51 patients out of 398, they all are level as, and this is based on ambulatory BP. I mind you, the routine and also ambulatory BP. So that is always there. Now drugs for hypertensions like AC inhibitors, ARV, all we can use. Apart from that, acetazolamide can be also used as a drug. So effect of chilblain. So this is the chilblain in few of the patients where you can find frostbite, and amputation is only the answers in these cases. We have been seeing these cases regularly. So there is a role of proteomics, metabolomics, environmental factors, genomics, and physiological candidate markers in case of high altitude related illness. Lot of research studies is going on, projects are going on at our different centers. So prior illness, these are the illness which are more susceptible to acquire this high altitude related illness, and risk factors for some of the misconceptions is there, like diabetes, pregnancy, there is no adversities in high altitude, so they can carry on with that. The prevention is diet and hydration. Hydration is very, very important because many times hydration can lead to CVT. That is one of the very predominant factors. Just 2 to 3 minutes, I'll just sum up. Then, of course, the educations, stage acclimatization, what we are very sacrosanctly we are following in the armed forces. Suppose somebody has to go to 14,000, so he will go on day 14 to 14,000. So 6 days, the one he has to stay at one place, stage 1, then again 4 days, around 12,000 feet, and again 4,000. So you just think if I have to send one combatant at the height of 16,000, it takes us for 14 days to properly acclimatize and go to that place to basically to actually reduce the cases of high altitude related illness. So antioxidants, iron, nitrates, there's a role of PDI, sumatriptan, and there's one of the research which is going on in high altitude medical research, Jingo biloba, and few of the good side effect has come, and they are planning to patent this product recently. Now, empirical administration of vitamin B12 and albendazole, that is also required in this case. Portable hyperbaric chamber at extreme, I have already shown you this thing. So this is very important. At first stage, 6 days, 4 days, and 4 days we need to acclimatize. Second stage, again 4 days, walk slowly, and third days again 4 days, we need to go in the gradual phases. So further research are there for the genetic basis of high altitude, the characterizations of substance that alter the permeability of the blood-brain barrier, and of course the drug therapy which can cause. These are the few recent proposals which we all are working on. Operational preparedness under extreme environment, OPEX, Oxol, and physiomix, the metabolomics of this thing. So in collaboration of the DRDO and PGI and armed forces, there are a lot of studies which is going on, and probably will be getting results soon. So to conclude, this all, whatever high altitude related illness I told you, hypo, hypo, or all the thrombotic state, CVT. Hypo, the first case series was from India by Brigadier Menon, which was published in NEGM. And over the last 6 years, there is better understanding to the molecular level. Susceptibility markers required to be studied, and with present management studies, HA illness is very curable. Prophylaxis to prevent the disease, we should take precautions, and there is pursuit for newer alternative with better outcome is on. And this is from, if you have been to Hundain or Partapur or Peganso, this is double hump camel. So you all can enjoy this exotic. But my take home message is like acetazolamide, you must start 1 day prior to induction, and please go slow. At least if you are going, go in stage wise, because this is an excellent place for tourism. So we should actually go in very gradual phases. So with this I have end my talk. Any questions or anything I am happy to take on. Thank you. Thank you, sir.
Thanks, Dr. Singh, for the excellent presentation. One thing I think you also let the patient come down at least by 1,000 to 3,000 feet. That helps. That helps it, at least cerebral
Yes,
edema.
sir, yes. Actually, descent is the treatment. In high altitude pulmonary edema, the moment you descend, 70% of problem is solved. But what is actually happening on ground, many times the weather is, I mean, it's most of the time it is packed and you never know. So most of the time it is impossible to actually transport these patients, sir. So these hyperbaric portable chambers, they are actually life savior. And most of the army units and all, it is there. And in fact, they are providing medical cover to all the civilians who all are going there, sir. Because hardly there is other PHC and facilities are not there.
Another is a biomarker. Whether it is edema, is a pulmonary edema, or this is some pneumonia or something, because you are already the patient might be having pneumonia. I think their BNP roles come. So
Yes,
there are
sir.
some studies saying that if it is high BNP, then it is definitely this pulmonary.
BNP or because what, like while working in 153 GH, we have a tertiary care hospital, though I had been into TD to that hospital many times. So what I find, actually every patient there behaving in very strange way, sir. There is nothing sacrosanct there or here. So in few subsets of the patients, I find very young, that Air Force chap is 22-year-old. Suddenly he presents with some difficult chest pain and all this thing. You find BNP is raised, but his other ECG is absolutely normal. He collapses. So, but by and large, most of these cases, these cardiac biomarkers are raised, sir. But the metabolics and proteomics, many studies are going at HMRC. Like one very, this CPAP I told you, sir, that is the recent modality, which is now going to come as a standard of care in management of HAPE, high altitude pulmonary edema.
Doctor, you said about antipsychotic drugs. Sir. What is the role of antipsychotic drugs? And apart from acetazolamide, are we using any other diuretics like furosemide, or there is one preparation of torsemide which is available in a sublingual form?
Sir, no diuretics per se. First question is around the antipsychotic one, sir. Actually, it is mainly all those combatants who goes there, sir. Because if you are at a speed of like 17,000, 16,000, you are just speed slow and slow. So actually, we are reporting not many cases. They go into depression and they go into very psychotic behavior. So this is very important. Almost, I would say, 5 to 10% of the combatants. Because most of from civil side, they are just going for the funds. But you stay such a harsh climate on it. Even at Madhubla, if you go, if you are exposed for 1 or 2 minutes, you land up in that. Last year when I had gone, I was just going to my bike. We got down for 1.5 minutes to click photographs. Had to give a potable oxygen. She was drowsy and all. So rapid changing and all. So lot of there is a role of this thing. And secondly, the role of this acetazolamide, no diuretics. Diuretics are not at all indicated in case of HAP. It is not indicated. For acute coronary sickness, only for the ALS, prophylaxis and treatment, we can always this. No diuretics. Furosemide, they don't have any use. They are not.
Okay, thank you, sir. Thank you, sir, for excellent presentation. Next topic is maximize benefit of telemedicine in clinics. Speaker is Dr. Bharat Panikai. Sir, please.
Okay, good afternoon to all. So, I must thank Dr. Virmani for assigning me this topic. So, when I got a message from Dr. Virmani regarding this topic, I just thought during my career, at least I have never taught beyond the core subjects. So, when I got this message, I thought, why? Should I? Then I remembered. Actually, when I was working in the government of Odisha, I was working as the state nodal officer on telemedicine, okay, in the year 2011-12. And at that time, in telemedicine in Odisha was a very infantile stage. I was just looking after the district headquarters, how the telemedicine centers will develop in that time. So I thought, okay, let me try what is there now, because all of us were aware, because we were giving advice to our patients in Slong, by telephone, by mobile, by WhatsApp, but we didn't bother about this telemedicine. And only after COVID-19 came, then suddenly this was a really boost. This COVID-19 worked like a catalyst to this telemedicine. And suddenly we are all after telemedicine, what is there, how to improve. Government of Odisha has also come up, Government of India has also come up with so many projects on this telemedicine and telehealth. So I'll be just giving in a very brief. So what is telemedicine? So this is the definition regarding the American Telemedicine Association. Telemedicine is the natural evolution of healthcare in the digital world. This is the definition given by American Telemedicine Association. And what now World Health Organization has taken a very aggressive step in the telemedicine sector throughout the world. And as per the WHO, telemedicine is defined the delivery of healthcare services where distance is a critical factor by all healthcare professionals using information and communication technology for the exchange of valid information for diagnosis, treatment, and prevention of disease and injuries, all in the interest of advancing the health of individuals and their communities. This is a very big definition, but this is the definition and very valid definition for all of us. So, how the telemedicine is being implemented? It can be conducted through various ways. One is the store and forward, consists of storing and sending information remotely. And this is used typically in non-emergency situations. We don't be very much using telemedicine emergency services. So in these instances, health data and images are submitted digitally for analysis at the time by health worker, usually specialist. This has been used for various specialties such as dermatology, radiology, ophthalmology, and of course, all the specialties. Interactive services, yes, we are doing all the interaction by real-time and synchronous mode of digital healthcare, and it calls for the communication between two or more actors in the clinical practice, and we discuss the client and the patient, what are regarding the problems and want to solve. Remote client patient monitoring, also known as telemonitoring, that enables the health workers to monitor an individual's condition remotely using technologies, and this is often for chronic conditions accompanied by communication channels for coordination of care. Coming to the common uses of telemedicine, that includes teleconsultation, provision of remote clinical service to clients' patients, and tele-expertise, where a health worker may be seeking a second opinion or guidance from the patient. You see, these are all repetitions, but after all, the whole purpose is how to improve the health care. Somebody is away from you, and how to communicate with them, and how to improve the health care delivery system. So, teletriage is also one terminology used, that is fast tracking emergency decision by transmission of health parameters and remote consultation. That is a teletriage. Somebody calls you, something that or intuition that he is having some such and such problems. So if you feel patient needs immediate treatment, so that is called teletriage, that you can guide him to immediately rush to the emergency. This is another terminology. This is called telehealth. So telecommunication and telehealth. Telehealth is delivery of healthcare services where patients and providers are separated by distance, yes. And telehealth uses information and communication technology for the exchange of information for the diagnosis and treatment of diseases and injuries. Beyond that, it also uses the research and evaluation, and also for the continuing education of health professionals. So telemedicine is a part of telehealth. Telehealth is a broader term. It is used by the healthcare providers in the country level, state level. So they use it, telehealth, to have a more of community services in the country or in the state. This is the NIM Catalyst defines telehealth. They define as the delivery and facilitation of health and health-related services, including medical care provider and patient education, health involved service, and self-care, telecommunication and digital communication technologies. So telemedicine is practically a component of telehealth, which is a broader application of technology to distance education and other applications where the electronic communication and information technology is used to support healthcare services. During the COVID-19, what we saw, that is the real telehealth service were being used throughout the world, and telehealth has become a basic need for the general population, especially for those quarantine, enabling patients in real time through contact with healthcare providers to access advice on the health problems. A recent WHO report showed that telehealth is the most common modality adopted by countries for service provision during the pandemic. And the report also shows that there is a trend increasing utilization of telehealth in the income level increases. As the income level increases, although even among low-income countries, 42% of those with service disruption during the COVID-19 crisis report utilizing the technology. So the COVID-19 period, this telehealth really helped for the healthcare provider. Now coming to the common components of telemedicine, guidelines and regulations. So you see, whatever, if something is there in a country, so the country has to develop some regulations to at least control all these health services, so the health providers and the technology providers. So everybody should also follow some rules and regulations. So every country has their own telemedicine guidelines and regulations. So although telemedicine guidelines and regulations are still emerging, they should generally contain the information on the following. So authority responsible for regulating telemedicine in the country, when telemedicine is considered to be an appropriate standard of care, which entities would be involved in the telemedicine service and the types of health, and the workers that can provide telemedicine-based treatments, that is doctors, nurses, and midwives. Community health workers, paramedics, therapists, and counselors, so they all should be also guided. Responsibility and accountability for patient outcomes, patient consent that include an explanation of the risks, benefits, and limitation of telemedicine. So data privacy and security standards. So all these should be included while providing or while forming any guideline for the country, for the providers or for the doctors. Now, technology standards of hardware, software, interoperability, training requirements and certifications, quality assurance and quality control measures, and reimbursement of health services delivered by telemedicine. So these are the specific points on which the policymakers should make the guidelines for all the people who are involved in providing the telehealth services in that country. Now I'll just show a few slides. What is the telemedicine in India? So going to the history, so ISRO made a modest beginning in telemedicine in India with a telemedicine pilot project in 2001, linking Chennai's Apollo Hospital with the Apollo Rural Hospital at Arganda village in the Chittor district of Andhra Pradesh. So this was the first trial, first project of ISRO on telemedicine in 2001. So in an attempt to coalesce the available public health data and provide easy access, the Ministry of Health in the Government of India has taken up projects like Integrated Disease Surveillance Project, IDSP project, National Cancer Network, that's the ONCONET project, National Rural Telemedicine Network, National Medical College Network, and Digital Medical Library Network. So these are all these networks, all the projects are based on telemedicine only. So in the past few years, ISRO's telemedicine network has come a long way. It has expanded to connect 45 remote and rural hospitals and 15 upper specialty, super specialty hospitals. And the remote nodes include the islands of Andaman Nicobar and Lakshadweep, the hilly regions of Jammu and Kashmir, medical college hospitals in Odisha, and some of rural distinct hospitals in the other states. So current scenario in India is, who recommends the doctor population ratio is 1:1. 1,000. But the current doctor population ratio in India is 0.62. Of course, it has little improved at the time as on today. Now, training of new physicians is time consuming and expensive. Hence, the doctor to patient ratio can be expected to remain low for long time to come. So, this deficit is partly being made up by the active telemedicine services in various parts of the country. As a consequence of the e-health wing of National Health Portal, the National Digital Health Authority of India, National E-Health Authority is being set up with a vision of achieving high quality healthcare services for Indians through all cost effective and secure use of ICTs in health and health related fields. So these are the various applications of telehealth in India. Number one, the educationals. So there is a tele-education, there is teleconferencing, there is tele-procuring. So I don't want to go in all the details also. So, and now the number two is tele-healthcare delivery. So again, this is the school-based healthcare centers that helps manage chronic conditions like bronchial asthma, diabetes, obesity like that. And the correctional facility also that caters to the healthcare needs of the inmates without the expense of danger inmate transportations. And there is also mobile health clinics, shippings and transportations, industrial health. The third is the healthcare management. This is also a part of telehealth in India. So telehealth care that uses the ICTs for prevention and promotive health care. It also, telehome health care also monitors patients from a central station, that is remote monitoring, and specialist, you know, the teleophthalmology, teleradiology, telecardiology, telesurgery, everything has been also improved. So diagnostic services also teleradiology, teleendoscopy. So all of us know how the teleradiology, every day we are facing this teleradiology. Now no radiologists are working in the centers. Everything is tele. All the plates have been sent to them and they see from their room, their house, and they reports. So this is what teleradiology, how much this teleradiology has improved. Now screening of diseases. So examples, the diabetes screening project of MDRF as Dr. Mohan's center, that is the Chunampet Rural Diabetes Prevention. This is a really project which has taken really recognized all over the world. Now ophthalmology screening by Aravind Hospital and Andhra Village. Now in here, again I want to inform you, in Odisha, in Bhubaneswar, I am also attached to a tertiary care center, tertiary eye care center, LVPI, where we do whatever. We also provide home care service. Now our technicians, they move with all the instruments to different areas. Somebody telephones, sir, I am not able to go to the hospital. My mother is 95 years old, how to see. So we provide, we just send our vehicle, that vehicle will move to the house, and the technicians, they will do all the things. And from there, the specialist will be sitting in the hospital, they will send all the photographs from there. And there, the specialist will see the photographs and he will advise what to do and what not to. So this is how video conferencing, telehealth is working in the ophthalmology center. So, but the Aravind Hospital, that is a pioneer in this health service, that is screening of diseases. So these are the various aspects of diabetology also. So what the MDRFs, they have done, early detection and treatment, provides individual health information, enhances decision making in clinical management, increases awareness, facilities remote monitoring, availability of diabetes care, easy accessibility, employment opportunity. These are all various really effects of telediabetology of that MDRF centers. This is one project. This is really e-Sanjeevani National Telemedicine Service. And this project, this has been approved all over the world. This is the project which has been adopted by Government of India. Government of India has evolved into the world's largest documented telemedicine implementation in the primary health care, e-Sanjeevani, that was launched in November 2019. I think my friends who are working in the primary health centers or district health centers, they must be knowing very well about this project. Now you can go to any primary health center, any sub-center level also. You can go at every sub-center level. There is a health wellness center where somebody is there, so a community health officer is there, a staff nurse or a BSc nursing. She is the community health service officer there, and she is managing all these telehealth service. So anybody in the rural areas, in the village, somebody comes, so she can connect with the immediately to the medical officer in the primary health center or district headquarters center. She can connect, she can take advice, and the patient can be accordingly directed. So this is the e-Sanjeevani that is being functional throughout the country from the sub-central level to the district headquarters level. So the National Telemedicine Service of India has already served over 114 million patients over 1150 health and wellness centers. They are called the sports through 15,700 plus hubs and over 1100 online OPDs serviced by more than 25,000 doctors, medical specialists, super specialists and health workers as telemedicine practitioners as on 30th April 2023. So this is the largest project around the world. The cloud-based e-Sanjeevani platform is implemented in two modes. That is the e-Sanjeevani ABHWC, that is a provider-to-provider telemedicine platform. This variant provides assisted teleconsultation for patients who work into the health and wellness. That is called at the sub-center level. You know all the sub-center level, the ASA is there, and the health worker, female health worker is there, and here is one community health officer is there. Now, she is the health and well. This is called the health and wellness center. That is the community health officer in the health and wellness center facilitates the teleconsultation for the patients who are connected to the doctors and specialists in hubs established in secondary and tertiary level center health facilities, and also she can connect to the medical colleges also. And this variant is based on this is called a hub and spoke model. And the second is e-Sanjeevani OPD, that is a patient-to-provider telemedicine platform. It empowers citizens to access health services in the confines of their homes through. So if somebody is interested also, this community health officer will assist him that from his home with his mobile phone, the patient can how to log in to the primary health center, how to log in the district headquarters. She will also help the person in the rural areas. So these are the various areas: real-time telemedicine, state service doctors, free of cost telemedicine, chat, video consultation. They are all, everything are now possible at the rural and the remotest villages also. So after tapping the potential of teleconsultation to the fullest, the Ministry of Health and Family Welfare, Government of India has augmented e-Sanjeevani further toward the logical next dimension of telediagnostics in Sanjeevani 2 that was rolled out in March 2023. So now Government of India has again adopted this e-Sanjeevani to the diagnostic purpose and added in the recently in the March also. So this entails seamless integration of a vast spectrum of point-of-care diagnostic devices, also known as near-patient testings. So the POCDs provide results of various clinical tests, including physiological parameters with minutes of taking tests, thereby facilitating rapid diagnosis and quick decisions. So friends, again I want to inform you with all these some guidelines has to be framed, because we have to control all these people, all these procedures, how it should be done in it transparently. That is the word, and also the quality should be maintained. So enabling registered medical practitioners to provide health care using telemedicine. So these are the essential principles on this, because recently in 2020, in Ministry of Health, that came out with a telemedicine guidelines for RMPs in India. Everybody must have also gone through that guidelines. So we have to follow that guidelines by delivering the telemedicine facility. So these are the essential principles. The professional judgment, this is in short. I don't want to go to the guidelines, but this is, I'll show 1 or 2 slides, but you can go through the guidelines and you can go. So these are the essential principles. So you can go through the guidelines from your laptop also. Now, this is the final thing, misconduct. So everybody, we should remember, whatever we are doing, suppose in our patient face-to-face patient service, what guidelines we are following, what misconducts we are following, what the problem we are following, what the judicial problems we are following, that is also applicable to the telemedicine. This is in short, this is the misconducts, means whatever the NMC guidelines are there, that is also applicable to this telemedicine. The application is same, not that you can just escape. I have just given some advice by telephone or by WhatsApp. That is also will be taken care of when if some problem arises. This problem, the problem or the punishment is same as you are conducting in the face-to-face service. So I don't want to go to details. Thank you.
Thanks, sir, for the excellent presentation. It's actually totally new subject, and it is going to improve. And we'll see more and more of telemedicine in the coming years. Telediagnostic coming up, and particular help for the rural people. And now medical colleges are connected. You were telling our medical colleges are connected, and that is helping a lot of patients. I know they are busy. This telemedicine people sitting in the medical colleges are very busy. Any questions? Management, Dr. A.K. Arya, invite Dr. A.K. Arya.
Good afternoon. At the outset, I would like to extend my sincere thanks to the organizing team, especially Dr. A.K. Virmani sir, Dr. Anuj Maheshwari sir, Dr. Jayant Panda, and the whole organizing team for giving me an opportunity to speak on this subject. Very common urticaria. I'm sure that most of us, all of us must have come across a patient of urticaria day in and day out. So what just I wanted to emphasize as far as the diagnosis, evaluation and management is concerned is that the most important thing while treating urticaria patient is history. We have to spend time on history, because if a patient has come an acute case, okay, we will manage and then we can take history. But in a chronic case, not only the patient, the party which is accompanying the patient, and it has been found that urticaria patients are always accompanied by either friend or relative. So history taking plays very important role in this, and with that we can conclude, because to find what could be the pathogen. So urticaria and angioedema, description: urticaria is raised erythematous, blanching or pruritic, lesions well circumscribed, typically coalesce, and angioedema. It is not that urticaria cases will always present only with rashes or with itching and all. There could be also patients who are having angioedema or swelling, especially in the eyelids or somewhere subcutaneous tissues. So that will also indicate a sign of reaction or sign of allergy. So angioedema, subcutaneous swelling, predictions to areas to loose connective tissue such as the face or mucous membranes. So urticaria and angioedema clinical features will be repeated occurrence of short. I hope the pointer will work. No, it's not working. So the repeated occurrence of short-lived cutaneous wheals accompanied by erythema and pruritus. Wheals range in size from a few millimeters to several centimeters, and wheals may coalesce to form larger lesions. Individual wheals typically last less than 24 hours. These are in acute cases. Urticaria may occur anywhere on the skin, mucous membrane. Involvement is rare, and lesions should resolve without any residual marking. So that is simple urticaria. This will resolve without leaving any marking on the or residual marking. So urticaria and angioedema, clinical features, angioedema, approximately 50% of the patients with chronic urticaria have angioedema as well. So this is very important, that more than 50% of the cases will present with both urticaria and angioedema. Episodes of short-lived deep dermal and subcutaneous or submucosal edema like urticaria symptoms generally last less than 24 hours, and larger swellings may take longer to resolve, and pruritus does not consistently accompany angioedema and may not occur at all. That is in acute cases. So acute is less than 6 weeks, affects as many as 10 to 20% of the population at some point in their lives. Etiology is frequently identified. It could be either any food, any drug, or any lotion, any dress. There are anything under the sun, a person can be allergic to it. So it is very important to sensitize and counsel the patient that you have to identify your antigen triggering factor, so that you can realize that with what this has aggravated. So drug allergy, stings, venoms, infection, viral infection leading cause of urticaria in children. So urticaria classification: recurrent, acute or intermittent episodes of urticaria lasting days or weeks with intervals of days, weeks or months in between episodes, and chronic are more than 6 weeks. It could be idiopathic or physical urticaria. So urticaria etiology is common. Most common is idiopathic, medications, stings, foods, and these are seasonal variations. These stings are basically seasonal variations, and they are very, very common. Any infection can lead to urticaria and physical urticaria, and rare causes are neoplasms, collagen vascular disease, endocrine disorder, or urticarial vasculitis. So urticaria etiology, medications, any drug has the potential, and any drug, even anti-allergic drug can cause urticaria. So this is not that only antibiotic or any other drug will be there. So we have to be very, very particular about it. And antibiotics in general and penicillins, we know that they are very, very common in causing these reactions. Aspirins, NSAID is considered second most common cause of acute drug allergic reactions and frequent. Most important is this: in these drug reactions, most of the patients they buy across the counter without even doctor's prescription. कुछ भी हुआ, चले गए काउंटर में, कुछ ले लिया, दुकान वाले ने कुछ सजेस्ट किया, वो ले लिया. They don't know the dose and all. And कभी कभी क्या होता है कि भाई जल्दी ठीक हो, so they overdose themselves. So these are one of the few of the very common causes of causing urticaria. So foods, there are also, this is very, very common, and especially the we have come in our clinical practice that patients आके बोलता है कि we say that there is a possibility that egg, you might be sensitive to egg. So the patient will tell कि सर हम तो 20-25 साल से खा रहे हैं तो अभी तक तो नहीं हुआ. It is not necessary कि आप 20-25 साल से अगर किसी से आप सेंसिटिव नहीं है, ट्रिगर नहीं है, तो वो बाद में नहीं हो सकता है. So this we have to keep in mind. So important causes of urticaria: primary allergens, foods, peanuts, tree nuts, in fact anything. Chronic, typically unrelated to food allergy, and infection, common cause of acute urticaria. Viral infection, most common cause in children. Episodes are semi-limited and rare causes of chronic urticaria. Insect bites are again very, very common, and generalized urticaria, angioedema indicates systemic reaction. requires allergist evaluation for possible immunotherapy, and urticaria in children does not require immunotherapy, and Hymentropa, bees, wasp, these are the very common things which can cause urticaria. So urticaria etiology to continue, rarely if ever causes urticaria, animals may cause contact urticaria, because these days most of us are having pet animals at home. So these are also one of the few important sources of causing urticaria. Seasonal pollens, contact urticaria may be non-immunologic, cinnamonic acid, benzoic acid, immunologic, allergic, latex, fruits, vegetables, so anything can cause. So chronic urticaria, most common etiology is idiopathic, which we don't know the cause, and 30 to 60% of patients exhibit a wheal and flare with autologous serum skin tasting, thought to be due to complement activating histamine releasing features, and treatment implications. Urticaria may be more difficult to control. Sometimes it is very, very difficult to treat, and it is equally very irritating even for the patient, for the relatives, and also for the treating clinicians in the initial stage. So chronic urticaria conclusions like suggests role of the extrinsic coagulation pathway with thrombic generation and possible therapeutic use of anticoagulants like heparin or warfarin. Natural history is again, as I had mentioned earlier, is very important, and chronic urticaria up to 50% of the patients resolve within 3 to 12 months, another 20% of patients resolve in 12 to 36 months, up to 1.5% of patients persist for 20 years, 20 plus years, and 50% of the patients with chronic urticaria will have recurrence. So it is very, very difficult to manage chronic urticaria, and it might take months, it might take years. So one has to have patience. But usually what happens that the patient loses patience, and they change the physician, change the doctor, and even they change the pathy from homeopathy to allopathy to other alternative medicines. So physical urticaria symptoms: dermographism, cholinergic, delayed pressure, cold, aquagenic, solar, vibratory, anti-adrenergic. Dermographism is very common, affects 2 to 5% of the population. Small fraction of these patients will seek treatment, and stroking of the skin results in linear wheal, which may persist as long as 30 minutes, and patients may complain of generalized pruritus or skin crawling. Physical urticaria is cholinergic, likely the most common. The physical, 30% of the physical urticarias are there, occurs primarily in teenagers and young adults. Pruritic, small macules and papules occur in response to heat, exercise or emotional stress. This is very common that sir हम बाहर धूप में जब जाते हैं तो बढ़ जाता है. So this is very, very common, and it resolves very soon. May occur with wheezing, may occur. These are the all other complications. So physical urticaria, it could be cold urticaria that is characterized by the rapid onset of pruritus, erythema and swelling after exposure to a cold stimulus, holding cold objects or eating cold items or swimming with total body immersion. So these are the results. Patients might return with some allergy. So urticaria evaluation, acute urticaria and angioedema, history to ascertain for possible triggers, food, drug, sting, exam to confirm diagnosis, and may refer to board certified allergist for specialized management. So chronic urticaria, history and physical examination is there. Confirmed diagnosis of urticaria, laboratory studies, usually none required laboratory, but sometimes we might have to go for some tests. No relationship has been found between the number of identified diagnosis. Consider thyroid evaluation is also one of the important role to be played, and that should be kept in mind if especially in chronic urticaria. Skin biopsy indications: individuals urticarial lesion persists for more than 48 hours, urticaria are less than moderately pruritic and lack of significant response, then one might consider for skin biopsy. So goals: control symptoms and keep patient comfortable, search for and treat underlying etiology, that is very, very important. It might take some time, and exclude serious diseases, avoidance, causative factor if identified, NSAIDs or ASA, excessive heat, supportive therapy, reassurance, and patient education is most important. Urticaria management: chronic idiopathic urticaria, because there is no one specific causative agent that can be withdrawn, the hives cannot be cured. So treatment is considered palliative until the condition resolves on its own, and goal is to maintain a patient's quality of life despite condition. Initial urticaria pharmacotherapy: antihistamines, we know it plays a very important role, especially H1 receptor antagonists, and then first generation generally administered on a daily basis, hydroxyzine, diphenhydramine, or dose of QHS initially may be used in chronic cases. Secondary urticaria pharmacotherapy: H2 antagonist, 15% of the histamine receptors in the skin are H2 receptors, so that can be taken care of, may use in combination with H1 antagonist, and doxepin, very potent H1 antagonist is there. Leukotriene, it can also be used. Secondary urticaria pharmacotherapy: oral corticosteroids plays very, very important role. Role of systemic steroids in the treatment of chronic urticaria is limited. Short-term use in special situations can be used, and prolonged treatment complicated by severe side effects along with worsening of urticaria upon withdrawal. So alternative agents are there. There are few drugs which can be alternatively tried, like leukotriene, dapsone, sulfasalazine, and there are so many long list which can be tried. Secondary urticaria pharmacotherapy: immunomodulatory agents are there. Limited studies demonstrate efficacy of cyclosporine is in improving urticaria along with decreasing dependence, and suppressive effect of basophil and mast cell activation requires monitoring of a patient's blood pressure and renal function also. So pulse urticaria and angioedema frequently is not an allergic condition. Urticaria does not respond to topical treatment. Urticaria is the setting of antibiotics use might be due to infection rather than the antibiotics, and almost all urticaria is responsive to antihistamines. If your initial dose does not work, use more. We might increase the dose, and when all else fails, refer to your favorite fellowship trained allergy and allergy asthma clinic. Thank you so much. Sorry? You want me to get back to the slide? Please tell me where to stop, sir. Yeah, I'm going back.
Okay, how doxepin?
You want this one?
Yeah. How does it help?
Which one?
Doxepin.
The studies have shown that if a patient is not responding to H1 receptor antagonist and all, it has been found that doxepin is very potent and it can be effective, but this is only in chronic cases where it has been found to be very effective. Sir.
Regarding the main drug, as you know, is the H1 antagonist. The thing is that it doubles the dose.
Yeah.
If suppose 5 milligram levetiracetam not go to 10 milligram, you can go up to 4 times. So go up to 20 milligram levetiracetam before you go to other drug. So that is recommendation. Sir has told increase the dose, but you can go up to 4 times the recommended standard dose. Before you think that okay, this is not working, you can switch over to something, because that is the safest and the easiest way you can manage. And if you are using a leukotriene receptor antagonist, always with another antihistaminics.
Yeah.
They should not be used.
Yes, sir. Sorry? No, sorry, I don't have any experience with this.
Yes, actually, think is that now omalizumab,
Yeah.
that is the drug. They say that is for the refractory cases. Yes, yes. That is the latest recommendation.
Yeah.
It can cure up to 50% of the case. I think that brings to the. Thanks, Dr. Arya.
Thank you, sir.
Presentation.
Thank you so much.
Excellent topic. So I would request Dr. Birmani sir to felicitate the speaker and chairperson also. So I would like to invite Colonel Dr. S.K. Singh, Dr. Bharat Panigrai, and Dr. A.K. Arya. So Dr. V.K. Avichandani, please come to the dais.